As we know, hybrid procedures, as an introduction, they have come up out of the need to decrease the morbidity, mortality of the different congenital pathologies, and they're based on a collaborative work among surgeons and interventional cardiologists, always attempting to avoid competitive attitude. And we've seen over the years that we've been able to reduce morbid mortality of procedures, also reducing the number of procedures to treat these infants and the final costs as well. To address this fascinating chapter, we have 4 prestigious professionals that will be discussing different hybrid procedures performed by themselves. Dr. Horacio Faella, who's here with us as a moderator in order to introduce the first speaker. Horacio? So we'll introduce the doctor who is part of the staff of the Hospital Passanese from Sao Paulo, will be addressing the possibilities of aortic coarctation.
¿Estamos así? ¿Dónde está? No lo veo.
Sí. Marcelo Ribeiro.
Ok. Marcelo Ribeiro.
Muito obrigado, Dr. Horácio. Gostaria de agradecer o convite da comissão para a apresentação desse tema. Todos veem minha tela?
Te vemos. Eu te veo perfeito.
Ok, nesses próximos 15 minutos eu vou falar a respeito do stent como opção de tratamento da coartação da aorta no lactente. Não tenho conflito de interesses nessa apresentação. Fazendo uma breve introdução, a correção cirúrgica convencional, ela implica em morbidade não desprezível, apesar de baixa. A sobrevida livre de reoperação em 30 anos é de 69% naquelas crianças abaixo de 1 ano ao tratamento. No entanto, em recém-nascidos e lactentes jovens, cerca de 50% deles evoluem para requartação precoce, com necessidade de reintervenção. E neste cenário foram os primeiros pacientes onde a cardiologia intervencionista pôde atuar. Na coartação, o tratamento da coartação com stent também é sabido em crianças maiores, adolescentes e adultos que evoluem com menores taxas de complicação, mesmo quando comparadas à cirurgia, especialmente aquele tipo de lesão que envolve a parede da aorta, as dissecções e os aneurismas. No entanto, o implante de stent para coartação em lactentes é desafiador, pelas limitações de acesso vascular, em virtude dos materiais de alto perfil e a necessidade de reintervenções programadas, conforme a criança vai crescendo e as necessidades de redilatação do stent. Esse é um trabalho clássico publicado no JACC em 2011, onde se comparou cirurgia, balão e stent. Em relação às taxas de sucesso, são muito semelhantes se a gente compara a cirurgia ao stent, o balão um pouco menos quando a variável é a pressão sistólica. E em relação também ao gradiente braço-perna, todas elas são bem comparáveis, a gente tendo gradientes finais maiores no balão, mas quando se compara stent e cirurgia, gradientes residuais bem próximos. No entanto, quando a gente fala em complicações tardias, há uma diferença significativa, o stent correspondendo a 12,5% das complicações, 25% de complicações na cirurgia, sendo que 12,5% complicações da parede, especialmente aneurismas, em comparação aos 5% do tratamento com stent. O primeiro tratamento proposto para coartação da aorta na história, e também foi assim nos neonatos e nos lactentes, foi a angioplastia com balão. Nessa faixa da população pediátrica, é um tratamento interessante, pois permite a vinda pelo acesso femoral, mesmo em neonatos, com introdutores de 4 frentes, e tem melhores resultados quando o tratamento é objetivado para requartação cirúrgica, onde são lesões decorrentes da fibrose tecidual. Esse é um trabalho interessante, publicado pelo Juan Pablo Sandoval, grupo de Toronto, ano passado, na CCI, onde ele avaliou o tratamento da ortoplastia com balão em 68 lactentes, entre 3 meses e 12 meses de vida. Houve um sucesso de 88% dos casos, 6 complicações correspondendo a lesões da parede aórtica, sendo uma somente relacionada como grave, um pseudoneurisma, que mesmo assim teve tratamento conservador e não evoluiu para necessidade de exclusão. Houve perda ou redução do pulso em 30% dos pacientes, sem que houvesse isquemia do membro. O follow-up média foi de 7 anos, e nesse follow-up a gente pode ver que a chance de intervenção no decorrer do tempo foi de cerca de 20%, mesmo após 6 anos do tratamento. Então, é um tratamento que, além de ter um sucesso imediato bom, tem boas taxas de manutenção no decorrer dos anos. No entanto, a anatomia mais favorável para o balão, aquela anatomia onde a coartação é localizada, com arco ístimo normal, não é a mais frequente nessa população de recém-nascidos e lactentes. Normalmente, as coartações vêm com algum grau de hipoplasia tubular, redução do istmo aórtico, às vezes com canal e outras cardiopatias intracardíacas associadas, né? Que fique bem claro, quando existem outras cardiopatias de tratamento cirúrgico associados, esse paciente ele deve ser encaminhado para cirurgia. No entanto, a hipoplasia do arco e a redução do calibre do istmo por si só não contraindicam o tratamento com stent. Em relação aos stents em crianças, a gente tem 2 tipos de stents, aqueles stents pré-montados e aqueles stents que vêm separados do balão. O benefício do stent pré-montado é um perfil menor, vai em bainha 4 a 6F, são compatíveis com artérias femorais pequenas. No entanto, a imensa maioria dos stents pré-montados não podem ser redilatados até a idade adulta, exceto stents fórmula, stent valeu, que são stents que têm o uso em coartação mais recentes, então a gente ainda não tem dados de follow-up tardio. No entanto, os testes em bancada e os testes iniciais mostram que sim, podem ser redilatados. Em relação aos stents separados, eles são redilatáveis até 18, 30 milímetros, o que corresponde a um bom calibre de aorta de adulto. No entanto, tem uma limitação para o implante, que é o alto perfil. As vias de acesso para o tratamento da coartação da aorta, a gente pode usar a via femoral. No nosso grupo, a gente sempre tenta em pacientes com peso maior do que 10 quilos. No entanto, a gente precisa fazer uma avaliação criteriosa antes da anatomia da artéria femoral, e isso a gente faz pelo ultrassom imediatamente antes da punção, e logo depois da punção a gente também confirma com angiografia. Normalmente existe algum grau de espasmo, como vocês podem ver aqui do lado, puncionado, mas quando a gente compara o contralateral e espera-se que as artérias femorais tenham calibre simétrico, a gente pode ver um bom calibre da artéria femoral contralateral, que permite, nesse caso, o avanço de bainha longa e stent balão. A via carotídea, no entanto, é a via preferencial, uma vez que a maioria dos lactentes tem menos do que 10 quilos, e também é utilizada quando as artérias femorais são pequenas em crianças maiores para o tratamento proposto. É um acesso que no nosso grupo a gente prefere obter pelo cirurgião ao invés de punção direta. O cirurgião, ele disseca a carótida comum direita. Normalmente elas são grandes, né? Os vasos pré-coartação são de grande calibre, então permitem introdutores 6, 7F, são os necessários para o tratamento de um stent convencional, crimpado em balão. E aí sim, depois de dissecado, a gente faz a punção sob visualização direta, e por técnica de Seldinger habitual, a gente introduz o introdutor necessário. O introdutor curto de acesso femoral, ele permite a chegada, inclusive passar a coartação funcionando como uma bainha longa quando vem pela carótida. Depois do procedimento é feito o reparo vascular com prolene, fios separados, e na nossa casuística a gente não teve nenhum evento adverso grave, quando a abordagem foi por meio da cirurgia. O grande benefício é que permite acesso direto para a intervenção no arco e no istmo aórtico, com baixas taxas de complicação conforme publicado por Henry Justino em 2016. Em 45 pacientes, ele teve trombose do acesso em 5% somente, que corresponde a 2 pacientes, foram estenoses leves, sem nenhuma repercussão neurológica, nem imediata, nem tardia. Esse é um caso de um paciente de 3 meses, síndrome de Down, internou pelo pronto-socorro com coartação grave, disfunção ventricular esquerda grave, insuficiência cardíaca em uso de dobutamina. E nesse paciente, observem, o acesso carotídeo esquerdo deu um acesso direto à coartação numa linha reta, e através dele, um introdutor 7F, foi possível o implante de um stent palmagênesis crimpado num balão Powerflex. Esse é um outro paciente que eu trago como exemplo também, de como o acesso carotídeo ajuda, também um acesso direto à região recoartada de um paciente num pós-operatório de interrupção de arco aórtico e fechamento de CIA, que na época, há 4 meses atrás, tinha sido periatrial. E aqui, pelo acesso carotídeo, também foi possível um implante de um stent redilatável no istmo com bom resultado. Essa é a indicação clássica, eu acredito, de um paciente com coartação no lactente, 7 meses de vida, 8 quilos, a princípio, uma anatomia favorável para o tratamento com balão, vejam, arco normal, dilatação pós-estenótica, uma acentuada coartação do istmo. No entanto, depois da angioplastia com balão, foi usado um Aviator 7F, apesar da melhora do calibre no istmo, ainda permanecia com gradiente residual alto, e aí, portanto, foi mudado o acesso, e o introdutor vindo pela carótida permitiu o implante do stent no istmo sem maiores problemas. Os nossos resultados com o stent publicados na literatura são razoáveis. Eu trago aqui para vocês dados de um estudo publicado esse ano, a experiência do grupo de Columbus, no Nationwide, de 39 pacientes com menos de 20 quilos, todos eles feitos por punção femoral, nesse caso não foi utilizado. Os pacientes feitos por via carotídea foram excluídos, mas os dados são muito interessantes. Uma média de idade de 1,1 ano, 9,9 quilos, 20 desses pacientes tinham menos do que 10 quilos, quase metade dos pacientes eram lactentes bem jovens, 72% desses pacientes vinham de recoartação cirúrgica, 56% deles foi tentado balão antes e esse balão evoluiu para falha. 10 pacientes tinham coartação nativa, e nesses pacientes a média de peso era de 14,9 quilos. O sucesso, dado como gradiente residual menor do que 10, foi obtido em 97% desses pacientes, 38 dos 39, sendo que houve redução significativa do gradiente sistólico de 26 para 0, aumento do diâmetro de 3,6 da coartação para 7,7, e aumento da relação entre diâmetro da coartação e a aorta descendente de 0,84 para 0,8. Houve eventos adversos em 7 pacientes, correspondendo a 18% da amostra, sendo eles um aneurisma, foi um aneurisma agudo identificado no momento do exame, que foi tratado com um stent CP coberto, sem complicações, 3 lesões do sítio de punção, 2 pacientes com lesão da parede aórtica, todos eles tratados clinicamente. Um paciente teve instabilidade hemodinâmica durante a insuflação do balão e um paciente embolizou o stent, que foi sepultado. Esse é um caso de uma coartação tratada por via femoral num lactente, aqui feita a angiografia basal, uma coartação localizada, no entanto, um istmo que vai afilando, que também precisaria ser tratado, não é a melhor anatomia para balão. E após o implante do stent, igualou-se os diâmetros com o diâmetro do arco. Esse é o paciente cuja a injeção da artéria femoral eu mostrei anteriormente. E no final do procedimento, como de praxe, a gente sempre recua a bainha até a artéria ilíaca e faz uma nova injeção em busca de complicações locais, e aqui vocês podem ver, não existe extravasamento de contraste nem dissecção. Naquele trabalho de Columbus, também foi avaliada a evolução a longo prazo, num follow-up médio de 67 meses. Foram necessárias 28 reintervenções, sendo que 27 desses pacientes foram eletivos. A média de tempo para a primeira intervenção foi de 50 meses, isso dá mais do que 4 anos, é uma boa sobrevida livre de reintervenção média, e essas reintervenções corresponderam a 19 redilatações por balão e 8 reimplantes, implantes de novo stent por fratura. Na reintervenção foi mais precoce quando havia recortação como base, quando o peso era menor do paciente, quando o diâmetro do stent eram diâmetros menores em decorrência do calibre de referência. Também a reintervenção foi mais precoce quando o paciente tinha menos do que 10 quilos, vejam a linha atuarial nesse gráfico de Kaplan-Meier, em relação à sobrevida livre de reintervenção naqueles maiores do que 10 quilos. Obviamente, crianças menores do que 10 quilos, têm a aorta menor, você necessita colocar stents menores, e nesses primeiros 2 anos de vida, o paciente ele aumenta muito o seu peso e a sua estatura, e consequentemente, o calibre da aorta. Isso faz com que a primeira reintervenção tenha que ser mais precoce. Aquele paciente cujo stent eu mostrei para vocês, coloquei a 7 milímetros, ele foi redilatado 3 anos após, quando tinha 3 anos de vida. Um gradiente sistólico de 25 milímetros de mercúrio. Foi feita a redilatação com PowerFlex 9, e o resultado final a gente pode ver aqui com gradiente residual de 8. Sem nenhuma complicação da parede, um stent bem expandido e aposto nas paredes da aorta. Como eu falei para vocês, o grupo de Columbus teve 8 pacientes cuja fratura existiu, em todos eles a fratura foi circunferencial, essa é uma foto do artigo da publicação, e nos casos onde havia fratura e necessidade de redilatação pelo crescimento do paciente, aqui a gente pode ver uma leve coartação residual no lugar da fratura, foi possível o implante de um novo stent e resolução da estenose e alívio do gradiente. Um outro trabalho publicado pelo grupo da Haueda, em 2020, buscou exatamente avaliar o comportamento dessas fraturas do stent. E na série de casos dela, ela chegou a ter até 33% de stents de baixo perfil, dentre eles o Palmagênesis, com fratura. Ela usou também fórmula e valeu. Geralmente acontecem nos primeiros 4 anos de implante, ela não conseguiu detectar fatores de risco claro para fraturas e não houve complicações, todos eles possíveis permitiram o implante de novo stent. Essa é a experiência nossa no Dante Pazzanese, com crianças menores do que 30 quilos, em 27 pacientes dos 37, a coartação era coartação nativa e o implante do stent foi o Palmagênesis XD em todos. Infelizmente, a gente não tinha, na época, o stent fórmula, que a gente já tem no Brasil há cerca de 2, 3 anos, e o valeu ainda não temos. Houve um aumento significativo do diâmetro da coartação, uma redução significativa do gradiente pico a pico, o segmento médio de 18 meses, a gente pôde avaliar que houve uma resolução da hipertensão, então houve um aumento do número de pacientes sem medicação, assim como uma redução do número de pacientes com hipertensão. E na sobrevida livre de redilatações programadas, aquelas redilatações para aumento do stent em relação ao crescimento do paciente, a gente observou em 5 anos 81% de pacientes ainda sem indicação de redilatação. Houveram 3 fraturas nesse período e dessas 3 fraturas todas permitiram tratamento com novo stent por dentro com resolução do gradiente. A reintervenção não programada foi feita em 3, um paciente com aneurisma, 65 meses depois foi tratado com CP coberto, um paciente com coartação residual também tratado percutaneamente, um paciente foi para cirurgia, pois persistia hipoplasia significativa do arco aórtico. Em relação ao futuro, se aposta muito em stent bioabsorvível. No Brasil, não temos ainda disponíveis os mais modernos, que ainda estão em fase de estudo pela literatura. No entanto, a gente testou em 2016 o stent absorbe para o tratamento das coartações neonatais. Esse é um paciente que tinha 20 dias de vida, 3,8 quilos, um istmo de 4,3 e uma coartação de 2, confirmada pelo ultrassom intravascular. Foi possível o tratamento com stent, vejam aqui o resultado imediato final. No entanto, 5 meses depois, havia fratura circunferencial do stent e recoartação. A gente implantou pela carótida um novo stent, Palmagênese 1910, montado no PowerFlex 6, e o resultado final vocês veem aqui à direita. Foram ao todo 2 casos, os 2 evoluíram com recoartação precoce, os 2 por fratura do stent, atribuída à pouca força radial, e desde março de 2016, depois dessas 2 experiências, descontinuamos o implante. Como conclusões, o implante de stent em lactentes e crianças pequenas é factível, seguro e eficaz no curto e médio prazo. A redilatação do stent é possível, com excelentes resultados. O stent absorvível ainda não é uma realidade, apesar de dados promissores publicados. Novas tecnologias para o stent no neonato e no lactente estão em desenvolvimento, e os objetivos são força radial adequada, baixo perfil para o implante e que seja redilatável até a idade adulta. Respondendo à pergunta que deu nome à aula, é a primeira escolha o implante do stent no lactente? Sim, especialmente naqueles casos de recoartação da aorta, com ou sem hipoplasia do arco e do istmo, que podem ser tratados pelo stent. E naqueles casos de coartação nativa, eu deixo muito como preferência do serviço, né? Essa preferência ela deve ser compartilhada com os cardiologistas, com os cirurgiões, também com o paciente e com a família. São 2 algoritmos diferentes. A cirurgia traz todas as questões de um procedimento mais invasivo, com toracotomia, em comparação ao stent, que traz também resultados muito satisfatórios, mas tem o inconveniente da redilatação. Como vocês sabem, o conhecimento ainda está em construção e a gente necessita de maiores estudos para poder realmente afirmar qual dos 2 é melhor nesse grupo de pacientes. Muito obrigado.
Thank you very much, Marcelo. Great presentation. Let's carry on, because time is short. Now we're going to have a presentation of Jesus Kardansky Barbosa from Buenos Aires. He's going to talk about the closure, the muscular ventricular septal defect closure, for whom and how. Good morning. I'd like to thank the scientific committee for inviting me to participate. This is a very important and very attractive topic, the closure of muscular VSDs. I think that they are simple, and they also have some difficulties that we need to consider. Let's start. These are my disclosures. We will divide the patients in over 10 kilograms and under 10 kilograms. That's a nice way to divide the work, because there are different difficulties. Let's start with over 10 kilos. This is a patient, the first patient for whom we did an MVSD closure. A 45-year-old female had had surgery when she was 4 years old, and she had a residual shunt. She arrived to the visit on the first day. She had a catheterization. She had QP-QS index of 2 to 1, and then we occluded the stroke, the VSD, and she recovered her function after several years. And she usually calls and tells me that she was very happy with the final results. From that moment on, we started receiving MVSDs. This was another VSD, mid-ventricular. So we had a lot of hemodynamic overload. We can see the left atrium, which is huge, and the QPQS was 2.3 to 1. So we decided to occlude it using an ADO device and check what the issue that we had. When we were trying to move forward, then the sheath went out of place. And then is when we found out of several works in which they placed guides, 0.018 guides that could prevent kinking of the sheath. And we have done this several times, and we were able to prevent the sheath to come off and to be able to have the guide to restart to continue the procedure correctly. Here we started again, and when we saw the kinking, we decided to go through an anterograde access. We went for an AU2, so we can see in the final image that the VSD is completely closed. Another interesting case that was similar in time was this mid-ventricular VSD that we had, and this mid-ventricular VSD was not an important one. It was debatable if we needed closure or not, but we can see in the image the tricuspid, in which we had a moderate tricuspid insufficiency. So even though it's true that I don't have all of the images, all of our backups were stolen, so unfortunately I don't have all the images, but this was starting to become an issue for this patient. And we debated if it was worth it to occlude it, and we decided to do it. The procedure was not complex. Well, the access was simple. We were able to use Mitoclip 2.6 device. The patient became better, slowly and surely, until we reached a mild insufficiency. That, in our follow-up, is the condition that our patient has right now. And the debate was if we were to close it with catheterization or with a surgery. Here we have the controls. These were after 1 year, after 1 month, and after 1 year. And we have that the insufficiency became mild slowly, and the patient is in general good condition. And other aspects that are complications for our VSD are the multiple muscular VSDs. And if you read the information available, these are procedures that require surgery, that for some people do banding, some people do corrective surgeries. There are always options, and it becomes difficult. The road for these patients is difficult, and we need to pay attention to see which are the patients that we decided to treat. Even so, I'm going to tell you about a couple of cases that were very interesting. This was the patient in which where you see that there's a very important work from 2002, in which for 3 patients they placed a total of 17 devices, which is an enormous number. And in general you can have different types of devices, different designs, but you need to have coils, you need to have prostheses to occlude them. So this is a kind of MVSD which has difficulties. So I'm going to tell you about a patient that we received a few years ago, 4 years old, with severe pulmonary hypertension. We had this debated if they had hyperresistance, Eisenmenger, and after all of the tests, the hemodynamic tests that we performed, we saw that that was not the case, and we started placing different kinds of devices, and we had one prosthesis per procedure. So now we can do more, but we know the procedure better, so we can do more. But at that moment, we could only do one per procedure. Here you can see at 4 years old in this front and hepatoclavicular on the right. The 40-degree anterior left oblique and the cranial. And here we can see to reduce the number of images, you can see the amount of prosthesis towards the edge, and you can see that most of these prostheses were placed using the anterograde technique. So this was the first patient that we did through the foramen ovale, through the transeptal anterograde, using the internal jugular, and we did the loop, the venous loop. So you can see here we have the lower vena cava, the foramen mitral valve, the internal jugular, and for this patient we can see the prosthesis control before releasing and after releasing. This patient continued after 4 prostheses. The pulmonary pressure had been normalized, but they had a residual shunt, and we needed to continue performing procedures. And I remember a comment from Federico Borges. He's my brother from another mother, and he once told me that when you start placing more prostheses, you may have residual shunt, but we don't know what happened. And at 18 years old, the patient had sudden death. We don't know which was the reason, but that was what happened, and we need to think if such an amount of devices is good for the patient. One of the interesting cases that we had to live was this VSD that seemed high muscular or membrane VSD, and we can see the size that it had, and then we went and did the angiography. We had an entry of 6.7 millimeters and 2 exit orifices of 3.7 and 2.3 millimeters. This patient was implanted a LifeTech prosthesis, 7 millimeters. The procedure was perfect, and with a minimal residual shunt at 24 hours, and it disappeared in follow-up. And check out the electrocardiogram after 24 hours. We got quite scared. We could not see what was happening, so we did an atropine test. And we were able to ease our minds a little bit, see the ECG after 1 week, and see the ECG. And we started seeing these. It looked like a VTAC, like veno conduced. So we continued seeing the ECG, and that's when we started studying and consulting. Of course, my 2 consultants are Dr. Raúl Arrieta and Dr. Federico Borges, and you share the cases with people who know more than we do, to see how we could solve this difficulty. And the only thing that we were able to see was in this work in Dr. Hijazi was that out of 8 patients, they found one with a transient junctional rhythm in 1 patient that disappeared afterwards. So we started seeing that the MVSDs don't have so many conduction issues, and this VSD, since it was in a high position, may be a little bit related with the conduction or the maneuvers, the entry maneuvers for the VSD. Sometimes you exert some kind of friction that may have been able to cause this electrical disturbance that using oral steroids and atropine tests, we were able to improve the condition of the patient. We can see the ECG 11 days after, and as we say now, there's peace on earth the piece arrived, we were with our tongues out, exhausted, very tired, but happy. And I want to tell you a little bit more about our results for our patients. Out of 21 patients with MVSDs, 13 were female, 8 were male, 5 were high, 9 were mid-muscular, 5 apical, and 2 multiples. The degrees that we used for the projections, for the angiography, were 40 and 20, and for 21 patients. Sometimes we use the right oblique, and the imagination is, of course, great to clarify the type of VSD that we need to treat. The mean procedure time was 85.8 minutes. The MVSDs are not normally easy. We need to be able to go through with them, and they are not easy. So we usually work for a longer time than with other VSDs. The mean fluoroscopy time was 44 minutes. The number of procedures was 26 because we had 2 multiple VSDs that we had to solve. And 2 of them received 4 prostheses, and the other one received 3 prostheses, multiples. The arteriovenous access was 25 and 1 transeptal antegrade access. Now let's move on to, I will go to some concepts with the patients under 10 kilograms, which we had already heard something about that, but they are completely different patients. Here we have a mid-muscular VSD with a patient with 4.5 kilos. The first thing that we did was take them off the surgical list. Here we have the VSD, the ventricle, and the angiography. And we also went with the echo, with the ultrasound. Clearly it's mid-ventricular. We did the arteriovenous loop. In that moment we were still very influenced by these kinds of procedure. And then we performed the placement of the prosthesis, the installation, the implantation, mid-ventricular prosthesis, and the patient solved its it's VSD, and it was the patient was in the hospital for 48 hours. We would probably release the patient before, but it was the first patient, so we needed to keep him in observation. And we can see now the different works that there are available for these types of patients. I've shown you a little bit the group of Shaquille Qureshi, and they use the transeptal anterograde access, either going through or perforating with a Brokenberg needle. And this is a way that we can do what they call anterograde transeptal puncture. Another work we have here where they show the VSD going through the foramen ovale is the veno-venous loop through the femoral veins. This is like in this work by Sattner with a patient of 2.2 kilos. And of course, we can continue with the multiple VSDs, which are difficult to work with. This is one of the cases that we had with a VSD that had been had surgery, and it had an apical VSD. The patient was with a respirator, and they could not stop using the respirator. And then we see the VSD that we did the transeptal anterograde access. And then check out the veno-venous loop using the internal. And this patient received a ductus prosthesis, which a 10-8 LifeTech device. We believe that it was that for the length of the septum was more adapted to these kinds of prostheses due to the type of anatomy, and the result was excellent. The patient was discharged after 15 days after completing the treatment in an excellent general state condition, and there's no residual shunt, either from the surgical and from our end. And this was, of course, published. Then among the patients that we have had, the musculars, we have over 20 totals, but 15 of them were between 2.6 to 6.5 kilos. 9 of them were female, 6 were male, 2 were high muscular, 5 mid-ventricular, and 8 apical. In these weights, we have associations, in which we can see the associations that we had, the TGA, then the AOCO with stenosis, then the TABVR with pulmonary vein stent, 3 patients with aortic coarctation, which had received surgery, 1 with a DORV and subaortic VSD, 1 patient with ASD with apical VSD, and a patient with pulmonary banding with perimembranous VSD. I will show you, right now we see that the devices were all received devices. For a patient of 5 kilos, we had 1 embolization. Here we see work which was similar. They did 8 cases in which 1 of them had an embolization. We were not able to remove the prosthesis due to the position. We sent the patient to surgery, they removed the prosthesis, and the patient died during surgery. This was one of the first procedures that we performed with a retrograde transseptal. This is a patient with aortic stenosis. We did the pulmonary valve, and a week later we treated the MBSD. We placed an FO, 10-8 FO. And the control, we can see the hemodynamics, the echo ultrasound control. And this was another patient who had the banding. We went in through the perimembranous VSD instead of the foramen valve. We went through the anterograde transeptal. This was done through to a vena-venous loop. And then instead of using the foramen valve, we went through the perimembranous VSD. We reached the VSD very simple. It was very easy to cauterize, and we could place prosthesis for this patient, an MFO-75 prosthesis. And 3 months later, the patient was received surgery. We closed the perimembranous VSD, and they are in an excellent general condition after the treatment. So what should we recommend? All patients need to have TTE and TEE if possible. The TEE simplifies a lot in the procedure. The transeptal access could be antegrade or retrograde. The positioning the device and avoiding the arterial. We avoid the arterial approach. Many times through the jugular we move the sheath, and through the femoral we move a catheter to start contrasting. Contrast should be avoided as far as it is possible. We have very small children with severe cardiac insufficiency, so reducing the contrast is better. And the ultrasound is a great way of controlling the procedure. And sometimes it's not easy, but we know that these procedures are long in duration, so we need to try to avoid long procedures because these patients are very unstable hemodynamically. So in conclusion, the MVSDs, the closing the MVSDs is a valid alternative due to high effectiveness and a low rate of complications. And for the MVSDs in patients under 10 kilos is frequently associated with other complex heart diseases, but we can do the endovascular treatment to ensure that the surgical treatment can be successful, either surgery or the catheterization. The multiple VSDs need more than one procedure, and different types of devices and different numbers of devices. The echocardiography is mandatory because it allows us to choose the best device in design and size, and it allows us to monitor the whole procedure. And of course, you heard me before, we suggest avoiding the arterial approach. I would like to say, to conclude, that we started the road of closure with a series of institutional references, but we're on the way of working with this. Many of these patients are going to be treated with hybridization when we have established our own protocol. And to conclude, I would like to thank you all, and I'm expecting your questions.
Good morning, everyone. I'm Dr. Daniela Aguirre Nava. Before we start, I would like to thank the organization of SOLACI for allowing me to participate once more talking about this topic within intervention, and I hope it is useful for you to share within the clinic. We're going to be talking about the branch pulmonary artery stenting, planning, and interventional algorithm. I don't have any disclosure for this lecture. As you know, stenosis of the pulmonary arteries can occur in isolation as part of a syndrome or in conjunction with other cardiac defects, or we can also have them after the surgical repair of any cardiac disease, and could have a significant impact on clinical outcomes. In fact, this is one of the most important needs for intervention in patients with complex cardiopathies. We're going to be dealing with this later. The significant narrowing of the pulmonary artery origin can lead, as you know, to a reduction in the pulmonary blood flow and to a disproportionate distribution of the circulation on the lung depending on the place of the stenosis. So today the treatment of choice for this type of pathologies is the branch pulmonary artery stenting. And this is very important because it will determine the clinical outcome when we have a stenosis. It is important to consider that stenosis of the pulmonary arteries can be congenital, for example, for hypoplasia of the pulmonary arteries, small branches being underdeveloped, a supravalvular pulmonary stenosis, multiple or circumscribed stenosis associated with other cardiopathies or syndromes such as Williams-Nguyen, Alagille, or others. Or it can be acquired and be associated with different pathologies such as the phylotetralogy, pulmonary atresia, post-trunk repair, in the single ventricle arterial switch, post-Norwood-Sano, and some other cardiac congenital malformations that after surgery can appear, severe stenosis that require urgent intervention. So it is important to consider that when there are pulmonary branches, we need to know that if it is associated with surgery, you can plan for the intervention before the surgery. Let's remember that surgery sometimes does not create parenchyma lesions or distal lesions, and sometimes the surgeon cannot correct them with a patch, but after a corrective surgery they can solve that, or for palliative care. Which are the conditions you need to consider for a successful treatment? First of all, you need to have a balance of bilateral pulmonary circulation to improve pulmonary function. It is important to reduce the right ventricle hypertension. Sometimes these patients have a significant pressure of the right ventricle that may lead to ventricle failure, mainly of the right one, and then affect the left one. It is important to consider that we need to improve the flow into the distal pulmonary arteries to reduce the degree of pulmonary regurgitation or reduction of the right lung shunt, especially in congenital cardiopathies, which are very complex. What are the indications for intervention? It is important to consider that when the systolic pressure of the right ventricle is over 50% systemic, when we have bilateral stenosis, it is important to consider an intervention. Also, it is important to consider the lung perfusion when the lung flow, if the perfusion is below 35%, if there is pulmonary regurgitation, the criteria is less rigid, but it needs to be considered in this type of patients. We also have to consider when stenosis are very long, especially in older children and in infants. This is one of the main problems or difficulties that we have, since the profile of a lot of stents and balloons are different, so we need to consider the dilation with balloon, but sometimes we have severe stenosis with great compromise of the patients, and that makes us place a stent, as I will show you in a couple of minutes. We need to consider that neonates and infants that are small are considered a challenge because they are low weight, and the profiles of the catheters, in spite of the fact that we have a great technology, but these are limited. We need to consider the type of stent that we're going to use. The Genesis stents are the ones that are mostly used at the level of the pulmonary arteries in small infants. We need to consider that when I place a stent and I choose a type of stent, I have to consider that this stent has to be adapted to the somatic growth, and we hope we can make it dilate to 15 or 18 millimeters so as to provide an adequate size of the pulmonary arteries. They can be implanted in infants over 5 kilograms. We have to be careful with ones of low weight, and that is why neonates and infants are a great challenge. We also need to consider and plan for the procedure very carefully for these types of patients. It is important to consider the definition of the anatomy, so all the details of the pulmonary arteries, if they have stenosis in the origin of both of them or one of them, which segment, what is the length of the stenosis, so that we can choose the correct stent to treat this lesion. It is important to select the proper balloon according to the stent, and to consider, as I said before, that when I'm going to place a stent, it can be dilated to adult size, and that would facilitate the good outcome of the intervention. It is important to consider the anatomical details and a good exploration of the diameter, the length of the stenosis, the diameter. I will take this pulmonary branch too, and also considering that I must have the correct support when I am doing the stenting. The steel guides in the pulmonary arteries of children, particularly that have severe stenosis, and the guide that I'm installing at a pulmonary level must be stable enough with a sheath that allows me to move the stent and place it in this stenosis site that is appropriate. It is also recommended to use very long sheaths to stabilize the position of the stent, facilitating balloon and stent delivery. And they also allow for the exchange when I need to move with a different diameter, with a balloon with a different diameter, and redilate the same stent I have already placed, and also facilitates angiography and the hemodynamic evaluation, so the record of pressures and gradients to see the outcome of the intervention and the stenting. There are a lot of stents, as you all know, and today technology allows us to use different types of stents. Let's remember that the first stents that we had were the Palmas, as you can see in the picture. Then the Palmas 308, that was very rigid. It was very difficult for us who started doing interventions in the pulmonary artery. With that one in particular, it was not that easy to reach the stenosis site. We needed sheaths that were bigger to move the catheter. Today with the Genesis, we do not have that problem, and we have a lot of alternatives for stents so that we can navigate through the sheath and be placed in the site of the lesion to facilitate intervention and also, of course, the results. Depending on the lesion, it is important to have all the material available of sheaths, guides, and catheters and stents, and also to consider that you need to have covered stents because sometimes these lesions may be ruptured, so we need to be prepared to inflate a stent. This is very frequent. The pulmonary arteries tend to break in very rare occasions, but it is important to consider these complications and have all the materials available. Now I'm going to show you a couple of examples. This is a truncus arteriosus that underwent surgery at 4 months of 5 kilograms. You can see in the first angiography, it shows a very significant stenosis. Here we have a 3D reconstruction, and that shows the stenosis of the origin that was very important. So in these types of lesions, as both lesions are from the origin and are very close together, we need to consider the kissing stent, where I have to do the catheterization of both branches of the pulmonary artery, as you will see later, and to be placed in so that I can implant both stents simultaneously in the kissing technique. So when I'm releasing the stent and I have not done the catheterization in both branches, that may compress or make it difficult to access the other pulmonary branch. So we need to consider this, and in this case in particular, we are with one stent that is placed and the other on the parallel position, and this is the result of the treated lesion and the outcome. In the middle, let's see how the lesion changes after being treated, of the stenosis of both branches with 2 stents during a kissing, which clearly shows a benefit and a hemodynamic and clinic benefit for this patient. This was a patient, a 4-month-old patient, and we could place a Genesis stent, and this is the same case at 3 years of age. The weight is not correct there. We needed to redilate the stent because of the growth of the baby. We can see a stenosis, and the pressures of the right ventricle were over 50%, so he was 3 years old, and we do the same. We do the catheterization of both branches, and we inflate both balloons to re-expand the stent as the image shows, and the definite result where we release the stenosis. So it is important, as I said before, that when I'm doing stenting, we need to be able to redilate them, because the children are very small and we need to consider the anatomical growth when we are releasing a stent. This is a different child, a 6-month-old child that underwent a gland surgery. Persistent cyanosis, pressures in the fontan area. You can see here this surgeon had placed a patch, but it was not very good, and you can see that there is a severe stenosis of the left pulmonary branch, the catheterization that we performed, and we place a stent at that level so that we could treat the lesion. It is important to consider that if, in particular, I'm showing you this case because we sometimes use in the pulmonary branches rigid guides, but on some occasions I changed the technique of using guides that were not that stiff, because sometimes if we have a lesion from the vena cava to the left pulmonary branch have a rectangle, such as this one, sometimes it deforms the anatomy, and sometimes we have problems to define the proximal and distal site where the stent will be released. So in this type of patients, I'd rather use more flexible guides so that they do not alter that much or rectify that much the vessels and the anatomy, so that it is easier to place the stent. This is another patient. This is a patient with a transposition of the great vessels, where we close the VSD after the arterial switch. This patient had a severe failure of the right ventricle and left ventricle, so we had to place him in ECMO. These are the guides of the ECMO. We performed a catheterization to see what was happening, and in the angiography, when you do a ventriculography on the right ventricle, you can see only one branch of the pulmonary artery, so there was an occlusion of the left pulmonary branch that we should treat. We could do the catheterization of this branch that was very small, and we could move a stent. Let's see the flow, and there we have a stent. In this case, it was a stent that was released with 0.14 guides, approximately 5 millimeters. The stent pre-assembled on the balloon, and this is the result that makes us treat the lesion. Although this stent, that due to the size of the patient at 18 years of age and 2.2 kilograms, was very difficult to place a Genesis one. In this case, we sacrifice the future in a way, because it is a stent that we will have to redilate and possibly break in the future as the patient continues to grow, so that we can have good outcomes. This is the same patient 6 months after that, and it was necessary to redilate the stent. We placed a balloon, 9 millimeters balloon, and we redilated to the diameter, normal diameter of the patient. So we have a reconstruction of the treated lesion. This is a different patient with interruption in the aortic arch with VSD that went to Norwood Sano, 12 months old and low weight. This patient was very bad after the surgery. We can see the severe stenosis of both branches of the pulmonary artery, the left and the right one. In this case, as we were very away, we did not do a kissing stent. We decided first of all to place one stent in the right pulmonary artery, and then on the left pulmonary branch, and then you can see They are distal, so it was not necessary to do the kissing stent, but you always have to consider that there is a reconstruction of both the treated stenosis, and the patient could have good outcomes after surgery. The same patient, 20 months after, with a better weight, more weight, we redilated the stent. First of all, the left pulmonary branch and then the right one, and the result of both stents after being dilated. And this is part of the need to consider in these patients, that we will have to do an intervention in the future because we need to treat them. This is the same patient, 3 years old with 14 kilograms. The same patient, the stenosis is not very significant, but the pressures of the right ventricle start to go up because there is a moderate stenosis. So we redilated with a 12 millimeter balloon initially, and in the other lesion there was a segment in the proximal area, mid-proximal area. We decided to place a different stent at that level, and the result of both branches of the pulmonary artery and the reconstruction. As a conclusion, I would like to say that it is important to consider that technology nowadays allows us to perform these types of interventions in very small children that are the most challenging ones, and we are seeing stents with lower diameters and also balloons or pre-assembled stents, and that is one of the advantages of the technological breakthroughs that allow us to do these interventions. We need to consider that the stent in pulmonary arteries is a challenge. It's important considering the anatomical aspects of pressures of the right ventricle. For the success of this intervention, to alleviate the pressure of the right ventricle, and as you know, and we all know, the success of these interventions is very high. The success rates are very high, and as I said before, you need to adapt to the somatic or anatomical growth of the patient. Some of the messages: we'll always have to consider the anatomic and clinical details when you are scheduling an intervention. Sometimes when we have patients who are clinically okay, the pressures of the ventricle are raised over 50% and the children is growing well, but the children is very small and requires an intervention to place a stent. Sometimes you'd rather wait, and depending on the anatomic and clinical details, you can intervene the branches or not. You have to take into account that when you place a stent, you have to redilate and adapt to the somatic growth of the child. It is important to have all the instruments, the proper instrument guides, catheters, sheets, different stents for the success of this intervention. And of course, as I said before, considering the somatic growth of the patients for future interventions, because I'm going to have to, and in small children particularly, reintervene them. And the success will depend on a proper planning for the intervention. This is what I had to say. Thank you very much for your attention, and I hope I've solved cleared part of the doubts, or that this interesting topic has been useful for you. In the event there are any questions, I will be open to answer them. Thank you very much.
Good morning. I would like to thank the scientific committee for allowing me to this talk, and for inviting me here. And the topic that I was offered was when and how to apply the hybrid approach to a pulmonary valve implantation. We know that pulmonary efficiency is the consequence of the treatment of the VD outlet, the right ventricle outlet in different cardiopathies, in which the fallout tetralogy is the most frequent. These issues in the right ventricle lead to a valve implant, with either by surgery or catheterization. The percutaneous implantation of the valve has revolutionized the interventional cardiology. Patients who used to require open heart surgeries now can be less because thoracotomies can be reduced due to the possibility of doing this percutaneously. But what are our alternatives if we have certain difficulties, like the inability of performing extracorporeal circulation, either by hematological reasons or neurological reasons that cause a greater risk, or there are contraindications, some of the neurological conditions that could create a higher risk, and they put in jeopardy the performance of such a kind of procedure. Low weight. Every time we think about the implantation of a pulmonary valve, we need to be very aware of that. Another issue is the impossibility of having vascular accesses. We all know that patients have numerous surgical procedures that lead to that require catheterization or interventional procedures. So many vascular accesses are occluded by those procedures, and one of the other difficulties is the caliber of the vessels, which don't allow us to use high French catheters that are required for this procedure. Another issue are thoracic deformities like severe scoliosis, and secondary to thoracotomies or other procedures in these patients. That makes the access more difficult. We also have heart-sternum proximity, which is a very high risk for initial catheterization due to the possibilities of a catastrophic bleeding. We also have pectus excavatum, which is a pathology that makes the access very difficult. What happens also if we have pacemaker cables or defibrillator cables, implanted defibrillators, of course, that we may have the unplugging or the detaching from their implantation site, and this could cause very serious arrhythmia. And another issue could be pathologies of the tricuspid valve, which may be worsened due to the ingress of the entry of the sheaths, which are very thick, which carry the valves to be implanted. So these are situations that appear in our practice, and we can solve them, or we can perform as an alternative hybridation. We know that hybrid procedures have become one of the most important strategies as a possibility, as a treatment possibility. First as a safeguard, and then after regulated procedures. So the heart team is a fundamental condition to be able to carry out these procedures. I'm talking about cardiologists, interventionists, and surgeons to be able to do the best type of approach and treatment for patients. Here we have two cases I would like to present that we've had, that we were able to perform. This treatment is patients that we have known, in which we have done hybrid strategies here in Argentina. The first case was tetralogy of Fallot with agenesia of the pulmonary sigmoid arteries, disseminator, sorry. The weight was limited, and we had a history of a first surgery with homograft number 12, and then we had other issues. Second surgery after 13 months, when the homograft was changed for number 17 because we had a severe stenosis. The patient improved after that surgery in the first moments, but they had a good progress in weight, but they had a history of febrile seizures, and they had treatment, medical treatment with medicine. They had some spironolactone and naloperidol and phenobarbital, and we performed an MRI. We saw significant dilation of the right ventricle, with some of the parameters were conserved, and we had some the TSVD, which is the conical OT, which was not appropriate for the age. So we moved to the procedure with the surgeons, and here we have the first image to see what we do it with a subxiphoid incision. It's in 5 to 7 centimeters below the xiphoid appendix, and we need to do it to place the spreaders and to do the necessary maneuvers in the edge of the heart, which is the first thing that we see exposed during the technique. And then we do it a puncture with an avocath, with a normal avocath, a 22 or an 18 avocath, and placing a 0.35 guide to position ourselves in the right ventricle and to go into the outlet and the pulmonary valves. That allows us to position an introducer, and this is going to serve as the sheath to perform the implantation or the dilation of the outflow tract of what we need to do. Here we have a 14 French introducer, which allows us to move forward and with anything that we need for the treatment of this patient. Inside we put an 8 French introducer, which is allows to access better, and it allows us to prevent blood loss. This is for you to have a panoramic view of the way that we see the field, the surgical field, and the action field that we have as interventionists. Through the sheath, we were able to do the necessary interventions that allowed us to enter the device or the balloon or whatever it is we needed, and we see that with a cranial frontal projection. And after analyzing the measurements, we started the implant with a CP of 34 millimeters. And remember that we had a graft of 17, and then we had a secondary dilation of 18 by 40 to generate a good landing zone where the stent is very tight on the graft. So this moved us to the next stage of the implant. See that this is one of the images where we can see how we can take the sheath out with the guide position in one of the pulmonary branches, and here we can do the introduction of the loading system of the melody valve, in this case, which allowed us to open the purse string suture. This allows us to introduce a sheath with very simply, very quickly, and this is notorious, and we can direct the sheath with rising motions or going up or down, directed to the outflow tract to be easier for us to work with this. Here we see the melody, the implanted already in an 18 millimeter balloon. You can see it perfectly placed. You know that melodies are placed on a 54 CP, so the one that we placed before. So both of them are very well connected. Here we see the valve working, performance, and then we remove the system and we close the ensiform opening. This is another case, and here we have an issue with the clinical situation, and here we had an issue with a BSD and hypoplasia on the left side, and this is a very low weight for this person for an access. We have the particulars of a surgery at 7 months with the closure of the BSD and left pulmonary branch, but it had an ischemic stroke, but complication, operation complication, but a good recovery. They needed to change the outflow tract at 5 years old with a subaortic resection, a homograft, a 20 millimeter homograft, and the presence of new ischemic stroke, which was more extensive with repercussions. So the patient required hospitalization with rehabilitation for long term. So this was an issue for this ischemic event. Then the evolution of after the dysfunction of the homograft and with the antecedents, we decided we had a lupus anticoagulant. So we started with the anticoagulant treatment. We see an important dilation on the right ventricle, which forced us to make a decision regarding the valve replacement, the pulmonary valve replacement. In the same situation, we discussed this in cardio, and we decided to go again to hybrid procedure, the same way that we discussed before, with the ensiform process, with the antiplatelet, and with the platelet, the pursuing suture, and so that we could pass the catheter through, like we see now. The frontal and profile projections, and here we cannot see exactly the outflow tract, but we managed the projection and the right oblique projection, the one that we are using right now for valve implantation, where we can see a lot better the outflow tract, so that we can perform the measurements. So once we knew the antecedents, the history that the patient had, we paired with a CP of 34. We also had a BMB balloon of 22 by 40. Here we can see in the later check of the stent, and you can see in the right image, we can see coronary control to see if we had any compromise or repercussions on close to the left side, and this way we saw that this was okay. Then we implanted the valve. We used a 22 millimeter balloon to mount the melody valve. We placed the implantation and dilation. We placed the implant with the same balloon, in which we mounted to keep this firm, and we did the controls to see if everything was okay, if the location was proper. We had no vision of the wall, so we removed we removed the system, the mounted system of the valve, while the valve remains on, and we did the appropriate controls to see the competent performance of the valve. And we can place the 14 introducer to be able to do the implantation of the the pigtail catheter. So what advantages do we have here when performing this valve implantation through this hybrid approach? We have a direct access to the outflow tract, to the RVOT, and it's directed very easily to the outflow tract. Then it's a minimally invasive procedure. It's a very small incision. It's sub-ensiform. So it allows us to visualize the tip of the right ventricle. It reduces the time both for anesthetics, that some of these patients have some neurological compromise. It reduces radiation dosage, so we need to be very careful over this time with the amount of exposure that we may have for long procedures and of the procedure itself. The procedure takes many minutes less than we do with normal valve exchange procedures. Valve replacement, sorry. And this prevents the possible damage of the tricuspid valve, because trying to pass the valve, pass through the tricuspid valve with a pretty rigid system, with a pretty thick system, that we need to maneuver, we need to manipulate, handle it through the right ventricle, sometimes is a complication that you do not want, and sometimes it's very hard to prevent because it cannot happen in this type of procedures. And we prevent the possibility of detaching cables of defibrillators or pacemakers. So this allows us to do other treatments with different access routes. And of course, another advantage is the early discharge. These patients are discharged after 48 hours, which is what they need to have is a drainage tube, a preventative drainage tube, due to the possibility of bleeding, due to and also due to the mechanical issues of what we do, also the purse strings, and there could be a little bit of a bleeding, so we have a drainage tube that is removed after 24 hours, so that would not be a problem. So as a conclusion, this is a procedure with very low risk, low risk and very low morbidity. Patients are discharged after 48 hours. This requires a hard team, obviously, because we were always discussing this. In order to do the scheduling, the programming, the planning, the organization, sequences for the implantation. This is completely reproducible, which means it's repeatable. If we have teams that know the technique, that only need to be able to reach an agreement, so we can do it on every kind of pulmonary valve implantation. And we also need an operating room that has the conditions to perform hybrid approaches. Not only with asepsis, but also we need to be able to have high quality imaging to perform procedures like we've seen before. And of course, this is the most important thing. We need to have an access for any kind of valves, because since all of the valves that we have in the market, this could be the access of choice when we have any and all of the valves that we have available. So thank you very much to everyone, and I hope that you have liked this presentation.
We're ready, Horacio. You're on mute. You're on mute, Horacio. While we are waiting for Horacio, we thank you for the great presentations we have had, and we are going to ask one of the panelists, Gabriel Echegaray, if you would like to make a comment, a question to one of the speakers. I believe we have 1 or 2 minutes and then the transmission is over. So, Gabriel, if you want to make a question, or only one question, please. Yes, the presentations were great and very clear. I had some questions for everyone, but we're going to try and do one to Marcelo. One of the things I would like to listen from Marcelo is that there are no risk factors to prevent the fractures of the stent. This is very important to highlight, to consider in which type of lesions we're going to control and use that procedure or not. But one of the things I would like to ask you is which treatment as regards hypoplasia tubular, hypoplasia of the aortic arch, if there is a treatment, a recommendation from your service for these type of lesions, and which of these types, if all of them are surgical for you, or which of them can we treat?
Muito boa pergunta, Gabriel. Em relação às fraturas, realmente não há fator de risco, não há como controlarmos isso previamente, mas o mais importante é que mesmo quando elas existem, não estão associadas a piores desfechos, né? As crianças seguem bem, precisam obviamente de um novo stent, mas evoluem bem com redução dos gradientes e sem complicações maiores. Em relação à hipoplasia tubular, de maneira geral, quando ela acontece após a carótida esquerda, tratamos com stent da mesma forma. Mesmo que cavalgue a subclávia esquerda, o stent permite um fluxo pelas células laterais para esse vaso, e mesmo quando há redução de fluxo para a subclávia, a vertebral esquerda tende a fornecer um fluxo adicional adequado. Tentamos evitar ao máximo cavalgar a carótida esquerda. Geralmente, quando a hipoplasia do arco é grave e está entre o tronco bracocefálico e a carótida, optamos por deixar para o cirurgião, a não ser que a condição clínica da criança seja muito ruim e o risco cirúrgico alto. Nessa condição, colocamos stent da mesma forma e, se preciso for, dilatamos a célula lateral do stent em direção à carótida esquerda.
Thank you very much. Well, I believe we may have a couple of minutes. I don't know what the technicians say. Can you make a question? Scarlett Sinisterra. Yes, thank you. Congratulations. The presentations were great. I would like to, Marcelo, to tell us a little bit about the preference in patients below 10 kilograms with special coarctations. Do you go directly, or can you tell us the preferred stent, or only with a balloon angioplasty?
Ótima pergunta, Scarlett, obrigado. Quando a coartação é pontual, localizada, com istmo e arco normais, a gente tenta o balão antes. A não ser que a condição clínica da criança seja muito ruim. Um dos casos que eu mostrei era um bebê de 3 meses com uma disfunção ventricular esquerda grave e insuficiência cardíaca grave dependente de dobutamina. Nesse paciente, não queríamos deixar gradiente residual algum. Então, fomos direto com o stent, apesar da anatomia ser favorável para balão. A gente queria fazer um procedimento rápido e bem resolutivo. Exceto por esse caso, nos outros todos tentamos balão, primeiro, quando a anatomia é favorável. Agora, a gente sabe que nessa idade existe associado hipoplasia de istmo ou de arco, que precisam também ser tratados numa proporção grande. Então, nesses casos, a gente vai direto com o stent, não tentamos balão.
Thank you very much, Marcelo. Horacio, you're still in mute. Let me see, 1 minute. I would like to thank you. We have to stop with the session because we have a new one. Thank you very much for all the speakers and the panelists. The presentations were amazing. So we'll continue with the following session and let's enjoy the rest of the Congress. Thank you very much, everyone. Good morning, everyone. Welcome to the SOLACI Congress 2021. We're going to be dealing with a very complex topic today, controversial one. We're going to talk about radiation protection. Are we doing enough? So as the talks would be one after the other, I will introduce the speakers first of all, and then we will listen to them. In order, we will listen to Mercedes Portas, head of the Plastic Department of Buenos Aires. She founded the first hyperbaric chamber in the public hospital and part of the burn care facility. And she authored a lot of papers on this topic. This topic is very interesting for us. Then we have Rodolfo Tauset. The doctor will be, he's in doctor in radiochemical part, nuclear and radiological protection, former president of the Latin American Society of Cardiology Protection. And he will talk about how to prepare a cath lab for pediatric procedures, taking into account the expert's opinion. Then we have Carlos Úbeda, a researcher associated to the Medical Investigation Department of an important institution, has performed a lot of research and published a lot of works in this area, and we'll talk about protection in pediatrics interventional cardiology. What can we reduce? How can we reduce dosing? And then we have Walter Mosquera Alvarez. He studied in the University of Buenos Aires, coordinator of pediatric interventions, and he will talk about how to control patients with excessive exposure. I will also introduce the panelists. We will have Cárdenas Luis, Comas Francisco, Jaramillo Mauricio, Mas Romero Carlos, and Ríos Méndez Raúl. We will listen to them all. Thank you very much. I am Dr. Mercedes Portas from the Hospital of Burn Care. This is located in Caballito, in the geographical center of the city. We are a monovalent hospital taking care of burn patients referred from the capital area or all of the Argentinian territory. This is very important because in 1997 we formed a committee of radiology to treat adult patients, and we established statistics, an algorithm of diagnosis, and a treatment algorithm. The topic we're going to be dealing with today is what happens with exposure to radiation by the pediatric population. It is true that in international articles and national articles we do not have data about this. We need to know what happens in the skin, on the skin lesion, due to the exposure to rays. we are going to be dealing with interventional cardiologists. There are some other procedures that use radiation and that may produce skin reactions in patients of different characteristics. And as we can see in the slides, the number is increasing in the clinical applications and treatment of certain diseases using radiation and minimally invasive interventions. This has had a lot of impact in the population, but also comes with radiological damage, and the health staff needs to take this into account in the cath lab. They allow to solve things without surgery and to prevent open surgeries, and then the fluoroscopy has allowed us to do interventional procedures that were very fast with more recovery. But what happens with children, pediatric patients? Although the radiation doses emitted during their procedures are low, and it is not foreseeable that they produce acute lesions, in interventional procedures guided with imaging, you can produce doses that are high enough to produce deterministic effects, such as skin lesions. The onset of stochastic effects and the radiological damage produced in a chronic way and random, where we have genetic mutation, and this is the most challenging or worrying part of the treatment or interventions guided with fluoroscopy in pediatric patients. Children are more vulnerable to adults to have different types of cancer, and they have more lifetime for effects to appear from radiation in the long term. We have used from 2000 the severity score of the European Oncology Radiation or European Oncology Union, and this has allowed us to see if we see the deterministic effects that are produced with a threshold of doses that is represented here in this column, and these are the effects that they produce: erythema, transitory alopecia, the dry epithelitis and the wet epithelitis, and radionecrosis. So we have a threshold of doses on the column of the right that produces the damage on the skin and skin complications that can be acute or late complications, appearing early or in the long term. This is what we can see, the analysis of the area. We have the thermal trauma producing due to the release of, and we have obliterant endarteritis, which produces reperfusion ischemia on the skin of the vessels of the skin affected, and free radicals. This is an inflammatory type, we could say, a type of diagnosis. We cannot treat a skin lesion if we do not try to improve the microcirculation and the antioxidant therapy. When am I talking about radio-induced erythema? An erythema that, as the conventional one, but with different characteristics as regards the base membrane and with persistent vessels that allow for recovery. We have an exudative epithelitis when it has affected the basal membrane, but we have some annexes that are compromised, but we have some of them. And the radio-induced necrosis when we have cell death and we have lesions of all the layers of the skin affecting circulation, and the in situ restitution. Which are the diagnosis methods that we indicate in the hospital? Ultrasonography with Doppler ultrasound to see in high resolution the skin, in this case the forehead of the patient, where we have a very good circulation, and the affected area we see a microcirculation that is also affected. This makes us have a radio-induced lesion. Telethermography is done in the burn hospital. These are diagnostic methods to have a conclusion. The severity score is divided into 4, from mild to moderate, severe and critical. We are talking about acute radiotoxicity when the manifestation is below 90 days, and when it is over 90 days, we have different skin manifestations. So to have a good diagnosis, we know if we have degree 1 or 2 acute or chronic. Here we describe the phenomena that we can find on the skin that are worse as the doses increases. We have degrees 3 and 4 that are more severe, the lesion is bigger, and recovery is slower for them, and they have different complications. And the group 4 is the most severe one, with bleeding, ulceration, and necrosis between the acute and the late one. So we have a case for you to see the exudative epithelitis in a patient who underwent an interventional cardiology procedure, and you can see the areas with blisters, the perilesional frame. And what we do, this patient, adult and child, can be treated as an outpatient treatment. It depends on social security of the patients and on the treatment, but these are not deep lesions. This would be like a second-degree burn. And what we use are gauzes with lidocaine, with restitution ad integrum, which is a very good one. The groups 1 and 2, the methods that we have, the ultrasound with Doppler ultrasound in all the patients. And we can see the groups 1 or 2, mild and moderate. There is no muscular compromise. Vasculature is not compromised. We have to wait from 6 to 12 months for a good evolution to assess the patient. And the local evolution, there is a remission of the signs and apparent recovery. In this case, we have a necrosis and a scale of a patient with angioplasty. For you to see that from a necrosis area that evolves and it apparently is closed, you would say it is healed, but no, because of the depth is number 4, late type of lesion, a skin that is with very low defense, and we have to control permanently because we have this bleeding 6 months after. What happens? We have an orifice of a small vein, and this is creating the bleeding. In groups 3 and 4, there is a change. The Doppler ultrasound can show a muscular compromise. There are signs of compromised vasculature. The evolution is uncertain. They need constant monitoring. And the local evolution, the patients of ischemia of reperfusion, there are repetitive crises of pain, partial response to the treatment, and there is pain and bleeding. This is very characteristic in the group 4. So the idea is to provide adults and children some alarm signs to consider. The place, depending on the procedure, some other symptoms such as skin decoloration, itching, blisters, hair loss. For example, if it is in the head, hair loss, pain, that is very characteristic, local edema or ulcers. Follow-up is very important in these types of patients. It is even more important in pediatric patients because you need to assess the compromise of the skin, and someone from the team needs to alert, and in this case the parents of the patients call us to see whether there has been a change on the skin and be committed with the treatment. And it's also important, as we have here, the informed consent form. It is very important that patients, in this case the parents of the patients and the family, is committed to the procedure. This procedure has saved the life of the patient, has allowed him or her survival with good prognosis, but there is a risk that we can control, and a necessary control, and we can do the different checkups for the evolution. So family and parents have to be involved in this. I would like to show you this. It is a poster that you can download for free that we did in the International Association of Medical Physics. You can download it from the website and has all the local evolution that may appear in erythema, for example, to necrosis, which are all the procedures that we can find, or stages, the local treatment that has to be performed by a surgeon. In the burn department, we have a radiopathology department that is open every morning, and the patient can come here, or doctors can refer them to us with a note, and we will assess them and treat them, and all the adjuvant treatments that we have to close the wound, managing pain, and follow-up of the patient. This is what we all do together with the physician that has performed the intervention. It is also important to say that we have a hyperbaric chamber of mid-pressure, and we do the hyperoxygenation to improve the wound healing. This is also related to microcirculation, oxygenation. We cannot consider only one local treatment. Treatment has to be local and systemic, what we call a tripod of treatment, or a triangle: antioxidants, vitamin E, management of pain, and better microcirculation. We have to take all of this into account for patients to control the pain, to control the lesion, and to have a better quality of life when the lesions are more severe. You have to do a different treatment, maybe surgical one with flaps, but sometimes the lesion we do not have to do a biopsy of this kind of tissue, because maybe if we have an area with these characteristics, such as an erythema, is transformed into a necrosis, because this is what tends to happen. The biopsy are contraindicated in radio-induced lesions. The treatment is medical. We need to control the antitoxic for the patient to have a better quality of life, and to manage the stochastic risk for cancer in the long term. Thank you very much for your attention. The hospital works in the city, and this is my contact information.
Good morning and good afternoon. It's a pleasure to be with you. I've been participating in the SOLACI meetings for several years. I am a specialist in radio protection, and in some way I am leading the radio protection program in Argentina for a while now. I work in the National Atomic Energy Commission, and I've been in the International Association of Radio Protection. We'd like to start with this topic by saying that interventionism, out of the practices that involve radiation in medicine, is the one that produces larger doses in the patient and in the doctor, in the physician. So we need to be more careful. First thing we need to discuss before talking about the activities is what are the problems that we need to consider. First of all, the doses in the patients could cause lesions. There are high doses in the physician that could affect mainly the legs, the head, and the eyes. So there are in many cases a lack of quality control for some of the equipment. Sometimes there's a lack of radio protection elements, and this is very important. And many times the medical staff or the auxiliary staff do not know which are the doses that they receive and the dose that the patient receives. If I don't know the doses, I cannot work or I cannot try to lower them. Another problem is the absence of specialists in radio protection or medical physics, which is something that is requested and demanded by international standards, but we do not have them normally on site. Plus, there are no controls in our country by the health ministry, which is the regulatory authority. So if things are looking bad, they continue looking bad. So this situation becomes chronic. So we've seen some of the problems. Now I'm going to try to show you a little bit about the transparency. Here we have doctors with no protection, with high doses. Patients, you can see many of these pictures with lesions after the intervention. Doctors, physicians with hairless legs, physicians with lesions in the legs, usually in the area before the lead apron. And you know that in the SOLACI we performed, we took a look at the eyes, at the lens in the eye, and we see that the doctors have a larger incidence of cataract in comparison with a blank population that is not exposed. Then we know that the working radio protection that starts in evaluating the doses is complex. So we know that we are working with non-homogeneous fields. The dosage changes, the shape, the way of working with cinescopy or with all of the different kinds of imaging. So you can see that a physician has one doses for one leg and half of it in the other one. In the left eye they have one dose and in the rest of the body is completely different. So this is a complex scenario. So after describing the problems, now what do we do now? How should we treat them? And the first thing that we need to consider is the equipment. The first thing is the radiation source, both for the patient as well as the physician. First we need to have a spectrum, formed spectrum. We need to know that the spectrum needs to be as appropriate as possible for the imaging. The basic spectrum, the initial spectrum, is a continuous spectrum from 0 to the voltage in the tube. So this we need to form it with filtration. We need to filter to lower the energy and to conserve the mid energies, because low energies only affect the skin. They are not good. High energy is no good because they go through everything, bone, whatever, soft tissue, and they do not create an image. So the ideal is to use the intermediate energies, 40 to 50 kilovolts. So this is what we need to do, because if the energy, the beam is not formed, radiation is not formed, so let's check with aluminum filtration, which is the blue bars. If I reduce the filtration, the dosage in the patient goes up, okay? The less the filtration, the higher the dose. Also for the physician, if we reduce the filtration, or if we have improper filtration and the dosage increases in the physician, because if the patient has larger doses, the patient irradiates more, so the physician is also exposed. So the first thing that we need to do is to see with the spectrum, and we need to measure three things. The quality of the beam, measuring the semi-reductor layer of aluminum to see how hard is that spectrum, then measuring the doses in the skin of the patients, and the spatial resolution, which tells us how can we look at details. Because if I have a low dose and the image is absolutely useless, then that's not good. So we need to check the dosage and the resolution. Because I cannot work with the patient, so we need to use a phantom. So to use the equipment, I need to use the same conditions. If I change the distances, we change the doses. So I need to work always on the same position. So we need to go to a standardized use. First, I measure the distance from the bulb to the detector, from the X-ray. If I increase that distance, they are farther, they're going to receive a smaller dose. Then, everything that I do is measuring distances, to work always in the same way. Instead of using a patient because I cannot use them to measure the experience, we can use a plexiglass boards or a bottle, which is the easiest, the cheapest, and the fastest. And I place here a bottle like this, and I put 20 centimeters of water, and I always use it the same way. We always need to have a distance, fixated distance between the table and the source, and then we have the camera here that's going to absorb the dosage and measure the dosage. Then I put this in the reference point for the intervention, which is the back of the patient. And then conditions, the different modes, the low scopy, high. For fluoroscopy, if I use digital filtration, subtraction, then I check and I observe if the data are acceptable in comparison with different standards. So we need to take a look at what happens when I increase the thickness and move to 20, 25 centimeters. I see how the dosage changes in the physician and the patient. And then I see the field, if I'm going to choose a small field or if I'm choosing a large field. The larger the field, the larger is the doses, and it's obviously larger the doses that the physician receives. Because the physician receives the dosage that's reflected in the patient. So the more dosage that the patient receives, the more dosage that the physician receives. Then I check the automatic exposure control. Then we have when we get less information on the detector, the physician increases the amperage or the voltage, so that the image that we see is always good. It's always in a good resolution. This we need to measure. We need to measure what happens when I change the thickness between the different elements. Other than seeing what happens to the patient, we also measure what is the dose that the physician receives. Because then we put 50 centimeters a detector to see how it changes, and I can also measure the doctor working, the physician working in the positions that they have, which is in front of the screen, behind the screen, in the hands, etc. This is called planning. I don't expect things to happen. I don't wait for things to happen to take action. I first need to look at the way that I'm working. How does the team work? what's the dose that the patient receives, what's the dose that the physician receives. So once we're ready, we need to start working. We have the equipment in good condition. We have the protection, the appropriate protection for the doctor not to receive radiation. So once we have all of this, we need to understand which are the protocols that we're using, in which way we're working for each case, for each situation. So for our doses and the doses of our patients to be as low as reasonably achievable, ALARA, that means. This is the optimization that we need to do. I have the equipment and conditions, and I need to see how I'm going to work, at what distance do I place everything, and here's what we need to care about: the field, the collimation, distances, the times, the modes. So if the time we go 2 seconds or 2 hours, we care about the modes, we care about the projections, anterior, posterior, diagonal, and the magnification that allows us to see greater detail. So all of these things we cannot explain to you right now in detail, but we need to know that it's important that the distance between the patient and the X-ray tube needs to be as much as possible, because the smaller it is, the larger the dose is. It's important for them to be far away from the detector as well. And we need to see what happens with oblique projections. They have a larger attenuation rate, and the doses are higher, and they can cause lesions. Then we need to see all of the protective elements, the screens, the curtains below the table. We need to check all of this. And there is a small curtain here for rotational equipment, where it works rotationally. The equipment we need to be protected for all the geometries, and then we need to check the use of the protective elements. They are personal. We need to check for the staff to have the PPE, but also to see how they're using it. So they have, for example, the apron, but they are sitting and they are receiving radiation. We need to see what happens with the eyes, and we need to have the probability of cancer, which is larger for children than for adults. So we need to be more careful, and we need to look at this with a greater level of detail. We can see that, for example, we should not use the anti-diffusion grid, because if we have a small thickness, there's no dispersion, so the screen is not useful. Every pediatric interventionist knows this, but we need to know what happens at different doses. The physician needs to have this information. They need to know what happens with one dose, with the particular dose on the patient. So all of these are static elements. We also need to consider the dynamic aspects of interventionism. So we need to see if I should release the pedal when I'm not looking at the screen. We should not cinescopy when fluoroscopy is enough. And many equipment allows us to take images from a fluoroscopy, so we do not need the cine, so which uses 10 to 20 times more larger doses than the fluoroscopy. Of course, if we have a pulse fluoroscopy, we should use it. We should use the appropriate magnification. We need to avoid cinescopy that are very long by freezing the image. We need to release the pedal when contrast has reached the maximum value and starts diluting. We need to use wedges to compensate different densities. Here we have of course the image of the cinescopy is a lot better. But if we want to see how the balloon is inflated, we don't need to do it with a cinescopy, we can do it with a fluoroscopy. Sometimes we need to use wedges to make sure that the densities are the same. And we need to consider that the closer the patient, the larger the doses. we need to consider all of this. And once the intervention finishes, we need to record all of the parameters to see what happened with the patient, to see if we need some follow-up. And so we need to see how the intervention finishes. We've seen that there are many parameters that we need to control. We cannot speak about any of them in detail, but how can we improve immediately and continually the radiological protection, the radio protection with a single tool? How can we control this, all of these parameters, all of these static dynamic parameters? The answer is using the reference levels. And we are using parameterized reference levels. So what does this mean? This means that we are going to measure the doses, and we're going to record them, and we're going to analyze them. And we determine, why did I provide a larger dose yesterday than I do today, or the other way around. We can check seeing the difference that there are using a set of operational parameters, and this is the way to achieve continuous improvement. This is the way of using a quality system. If we don't measure, we do not know what happened, and if we don't if we don't record, we cannot compare. So the analysis is the tool to know and to get to know and to analyze the processes. Why do we use parameterized reference levels? Because we need to share dosage values in the same conditions, and we know that if the thickness increases, the dosage increases. So we cannot compare the dosage that you can do with a thin person than the one that I need to give out when we work with an obese person. So, or when I placed 1 stent versus 47 stents. So this is the parameters. This is the dose that we can see based on the patient, but considering the thickness of the patient and the number of lesions. And I invite you all to work with these reference levels. I've done very many sacrifices here to work here in Argentina, and we have these reference levels, and it's important for all of you to analyze the doses and determine why you're getting a high dose and other people are getting a lower dose, and there's no other way than to see all of the parameters. These are things that we have done in different hospitals and centers all throughout Argentina. That we obtained data on the doses and times of the fluoroscopy. And we have compared this with the BMI of the patient, and because you see that you have the average obtained values when we work on 1 vessel or 2 vessels. So okay, this is sorry for the speed, but this is what I wanted to tell you in a condensed manner. Work with reference levels. We're willing to help you. Here's my email. If you want to work with reference levels and improve continuously, please contact us with my team, and we can help you. Thank you very much.
Good morning. I am Dr. Walter Mosquera from Cali. I work at Valle de Lili Foundation. I thank all of the organizing committee of SOLACI and Alejandro Pairón especially for the invitation. Today I have to talk about radiological protection in pediatric intervention. Can we reduce the doses? How? I do not have any conflict of interest for this lecture. We know that the development of interventional cardiology has performed a number of procedures that are very important, and year after year we have more procedures. But we worry about the collected dose received by physicians. We see the advance of these procedures, the increase, but the development in the radiological protection has not been going at the same pace with these procedures in time. So the interventional cardiologists are the ones that are affected the most with radiation, and we have even more professionals in this field. Just to remember the measurements that we use in radiology, we have Sievert, the absorbed dose is the absorbed energy by unity of mass in 1 point in gray. The equivalent dose is the absorbed dose by factor of weighing, WT1, the biological efficacy of certain type of radiation, and effective dose equivalent by the weighing factor. This is simply to see the absorbed dose, the effective dose, equivalent dose, and activity, radiological activity. And here we have the weighing factor of each of the tissues. One is over the other, so sensitivity can be different. Radiological protection in pediatric interventions. We are repeating the same. We have seen an increase. That has been one of the greatest breakthroughs in history, and this poses a challenge. What is it? Making procedures that are very effective, but trying to produce less radiation. We always have to take into account the ALARA criteria that has to be as low as reasonably achievable dose, and we always have to take this into account. Which are the biological effects of ionizing radiation? We have the deterministic effects that are known as tissue reactions, for example, skin relations, but there are some effects which are the stochastic effects or probabilistic effects, which do not have a threshold for their onset. The deterministic effects do have a threshold that we can define. And the importance of trying to have a dose as low as reasonably possible to prevent stochastic or cancer effects to appear. What is the objective of radiological protection? The objective is, we are saying this again, for biological effects, the deterministic ones and the stochastic ones or probabilistic ones do not appear. And we have 3 things to take into account. Justification. All the procedures are very good. The limitation of doses is important, and the optimization of working to reduce the doses. These 3 concepts have to be taken into account. And what happens when we have these deterministic and stochastic effects in the cells? The cell may die, a deterministic effect, but if 1 cell or 2 die, that's okay. But if a large number of cells die, the organ may fail. The cell may mutate and repair itself, but it may continue to live and mutate, and here we have cancer or stochastic effects with time. We can have late effects. We need to take them into account. The deleterious effects of X-rays. This is very important. The low doses we have, the less risk we will have of having stochastic effects. The risks are over in women and than in men, and in children than in adults. So this is why, as pediatric physicians, need to try to take this into account, because children are not small adults, and radiation children receive is more damaging because their organs are less developed, so the lesion may be greater. What do the ICPR and the AEA recommend? That operators to use 2 dosimeters, one on the apron and the other below that at the thorax or abdomen. For pregnant physicians or interventional professionals, we have to use an additional dosimeter to measure the dose of the fetus. The section of radiological safety or physical of the hospital must check the personal doses, and we need to do a research to see if we are using more or less radiation, if we are using the dosimeter okay or not. We need to do a research when we go over the level of 2 millisieverts per month in the exterior dosimeter. Here we have an important question: how can we reduce the dose? There is something that we need to take into account, that are the DRLs. This is a tool to help on radiological protection in the exposure of the patient and the physician or interventional professional that is exposed, to evaluate if the dose of the patient for a clinical job is well defined, is unusually high or low for that procedure. These are the limit doses to professionals who are exposed by the ICRP. And this is what we have to keep, the level that we always have to keep at the levels of the eyes, 10 millisieverts, and effective dose 20 millisieverts as well. This is always important to keep in mind. We need to have reference levels in each of the places, in each of the regions. And this is what we do with the PAHO and WHO. We're trying to determine the reference levels in each site, in each country, in each place, to have regional values to help have a proper radiation level. Optimization of radiological protection is very important. There are some gold standards or golden rules in the protection of the OEW. We need to reduce the time, increase the distance from the foci of radiation and the other area, and to wear a shielding. This work is very important. I always mention it. When we have here an AP position, and here is practically in zero, the amount of radiation is lower, and as long as we move and increase, if it is left oblique or right oblique, we see the increase in radiation, and if we see this caudal, we see that it increases. We also need to take this into account, that the images, the cranial or caudal ones or lateral ones, are more produce more radiation than any other position that is non-oblique, non-cranial, or non-lateral left or right. And here we repeat again the distance, the time, and shielding. This is a cap, the goggles. Having shielding is always very important. Here we have the collar. The apron is always very important, and not entering the area without the radiological protection equipment, so that we can optimize radiation. What happens with pediatric interventionism and the DRLs? We have that the numbers of procedures are very low in children as compared to adults, and the doses of radiations are dependent on the weight. And samples must be grouped in groups of age and weight, but weight specifically, because we may have children of 4 years old with very high weight, and we may need to change the protocol in the machine. The clinical indications are different and are used differently in various regions. We need to have different work teams with various procedures, and complexity of the interventional cardiologists are bigger and more complex. This is basically for us to take into account. This is the last publication of the ICRP about the reference levels. These were mentioned there. You can look for them here. How are the DRL established? The ICRP recommends the use of patients of values in medians and percentages of 75. The DRL depends on the technology we are using, and we need to know how to work with each of them and how to achieve the reference levels. We need to determine the proper dosimetric magnitude. We need to establish DRLs in pediatrics by weight and not so much by age. This work is to show you that we participated in this article of CCIESC. We evaluated the radiation doses by weight, by age, and what we found was that interventional procedures have more radiations than in diagnosis procedures. Recommendations for the protection of our patients. Everything that is beneficial to reduce the dose for the patient is beneficial for us as professionals as well, and not working with only one projection, always using the collimation, and that is very important. Another aspect to take into account is not using the cine mode to do the angiography, and to record them, but no cine mode to have less radiation emitted. And in children undergoing invasive procedures, we need to reduce the dose even more. Quality control is very important. We need to perform quality control in teams and equipment and the procedures of the medical staff as well. We need to have a good quality of image with lower radiation dose. If possible, we need to take into account the recommendations of the protocols and the parameters to change the dose, the duration of pulse per dose, the levels of radiation, and collimation. This is just a control protocol that is about to be published of the WHO PAHO for Latin America, and quality control for radiodiagnosis, and this is a part dedicated to interventionists. And to conclude, the objectives of the radiological protection are to avoid the radio lesions and to reduce the risk of cancer as low as possible. We need to compare the values with the DRLs in the different centers. This has to be part of the quality control program. These principles are applied to professionals and to the general population. And there are a series of measures to reduce the doses in patients and professionals. it depends on us. We need to create a culture of protection. And the question that we mentioned before, everything that we have heard, but it's okay, but can we have reference levels? We need them and we need to record them. We are interconnected with having reference levels for them to be regional and be useful for everyone to have a map, a roadmap to use this very effectively. Thank you very much. I thank the organizing committee of SOLACI, especially Dr. Alejandro Peirone, for inviting me to give this presentation. Thank you very much.
Have everyone good afternoon. It's a real pleasure to have been invited to this congress, such an important congress by SOLACI. It's an honor to me because it allows us to share information at a regional level. And I would like to introduce myself. My name is Carlos Úbeda de la Cerda. I'm a professor in the University in Tarapacá, in the city of Arica in Chile, the north of Chile. I also work as a consultant of the PAHO and the WHO for a particular regional program. So, in order to expand on the title of this talk that I have been invited in, this is how to control patients with excessive exposure. And the question is are we doing enough? Are you or I or we doing enough? In order to try to answer this question, the contents that I'm going to develop, it's a little bit of an introduction. Then we're going to talk about the regulatory framework. Then we're going to discuss some radio protection strategies. I'm going to talk to you about the program OPRIPALC, the PAHO and WHO program. And this is related with radio protection and radio safety for patients, and particularly for cardiological procedures and interventional radiology. The first question that I think that we should ask ourselves is what are the benefits of using interventional cardiology? First of all, that interventional cardiology is an alternative to the surgical treatment of many medical conditions. They bring faster, less risky and less painful solutions. The procedures are cheaper. There's a shorter recovery period for the patient. And we definitely reduce the complications due to the types of procedures that we perform. Mainly because the duration of the anesthesia or sedation is lower. Many of these procedures can be performed as an outpatient. This allows the patients to have a recovery, very fast recovery, and it can be done as an outpatient in their own homes. Okay, so which are the risks that we have when we are applying ionizing radiation? As many of you know, the ionizing radiations in the electrons, particularly but what we use specifically for interventional cardiology, have two types of effects: the stochastic effects and the deterministic effects. The stochastic effects, or non-deterministic, are effects that appear without a radiation threshold. One of the main effects is maybe cancer or hereditary disorders in the descendants. On the other hand, we have the deterministic effects. The deterministic effects are non-stochastic, so these effects, for their work, they necessarily need those threshold. So some of the in that context, some of the examples are the lesions in the lens of the eye, and these are some of the issues that we have on professionals who work in this type of specialties when they don't have appropriate radio protection equipment, and damages in the skin, which is very well documented. Here are some examples in the literature that we have collected throughout time of particular situations that we've been having in patients that are subjected to cardiology procedures. However, at an international level, and unfortunately, we have a regulatory framework that gives us an umbrella on how we should apply the radiological protection. We have ANSER, which is occupies on the atomic radiation and ionizing radiation, and this organization starts in 1955 and provides scientific evidence on the biological effects. On the other hand, we have the ICPR, which starts in 1928, and it provides a series of recommendations on how to face appropriately the radiation management. And on the other hand, we have the AIEA. So the agency starts in 1959, and it's the leading institution that starts providing notifications to the different countries that are subscribed to the United Nations, so that they can incorporate, if they want, these recommendations to their standards or their regulations. This is a joint teamwork. We also have other organizations, the ICRU, and this multidimensional work creates these international standards. Here you can see the road of the international standards and the latest thing that we have for the basic safety regulations, safety standards. These safety standards for us Spanish speakers have been translated to our language as well as English, and this document is there's a set of recommendations, of tips, so we can have handy. And I always tell the people that when I have the chance of interacting through these forums and talks in courses, I always tell them, if you want to know and be able to work with safe use of ionizing radiations, this is the main document that you need to use. This includes the entire regulatory framework and the strategies that you should apply to have a safe use of the ionizing radiation. In the standards, you will find the quality assurance programs, you will find the different types of radiation and other things that we're going to refer to tangentially. So I recommend that you should read this documentation. The framework, in the regulatory framework, we can see what we call the radio protection system, which has of course, that you should know these parts. So the first one is the justification of practices, that no procedure applied to a person should have all the procedures should have more benefits than risks, so benefits should exceed the risk. So there's an evaluation that the physicians need to do, and they establish this balance between the risk and the benefit. Then we have the limitation of doses, which means that we should radiate a patient up to a certain level, up to a certain limit. But for patients particularly, this principle is not used. Dosage limitation is used for other groups of people who we're talking about the professionals and the general audience. And finally, we have the final principle would be for the system in which we are, that goes around our work. It's related to the optimization. So trying to have an appropriate protection using an image that is good enough for our diagnostic study and to determine what happens to the patient. And this optimization, we have a certain number of tools that we're going to mention also ahead. The deterministic effects, the idea is to avoid them, because if we don't exceed the threshold, we don't have these effects, and we intend to reduce the stochastic effects. And among the things that I want to suggest to, as we said in the title of this presentation, how to control patients with excessive exposure, I would change it and say, what should we do to have the patients receive the appropriate exposure? And ask, are we actually doing enough here? So, to answer this question, it's very simple. We need to apply the radio protection system, the justification of practices, and the optimization of protection. We need to have the most appropriate evaluation, and we need to do this procedure. We need to check if there's an alternative that doesn't use ionizing radiation, and in the cases we know that we need to have the programs of quality assurance, of radio protection, so that's what's going to help us moving forward. In 1992, this work by the American Society of Interventional Cardiology mentioned how to make a safe use of radiation, of ionizing radiation. So this is the update for 2011, where they issue a reminder of the strategies to make a safe use of the ionizing radiation. So here we see how can we manage the radiation levels of patients. You know that all of these organizations work hand in hand. So this is how we see how the ICRP also has a section on the safe management of the doses of radiation to patients. And we have recommendations before, during, and after the procedures. We also have our study group. We created an article that gathers these recommendations and fuses them into the following tips. Before the procedure, the first strategy is to identify the procedure, but during the procedure we have recommendations that include the patient and the professional. We need to make sure before applying the radiation to have all the staff protected. We need to apply radiation only when necessary. During this catheterization procedure, we need to radiate when it's only necessary. When the catheter is being introduced, the physicians need to define that, but we need to minimize the use of operation modes that increase the doses, like the cine mode and the magnification. To look at the fluoroscopy, we need to place the image intensifier, the detector, as close to the patient as possible. We need to monitor the real-time monitor of the doses. This is something that is essential. So the doctor, the nurse should be looking at the monitor in the cath lab so that they can see the radiation that we are having here. And the other important point is to use the equipment properly. The collimation properly, sorry. Then we need to have a comfortable elevation of the table for the operator to be able to have a better way of working. Then changing the angle of the radiation beam to expose a single zone of the patient. Then we need to remove the anti-diffusion grid in patients, in pediatric patients with weight under 6 kilograms. We need to save static images in the monitors. This is all fundamental things. What do we do after the procedure? We need to get a doses report. In the dose report, here we have one from the Siemens brand. You can see the total fluoroscopy time, the total dose, and the dose in skin. And here we have a dose report. This is a Philips equipment. We have the total time, the fluoroscopy, the total dose. As for dosage product, which is what we need to look at to have the diagnostic reference. Also the dose in skin. After this procedure, what should we do? We need to do follow-up to patients who have larger doses. The recommendation is that when we exceed 5 gray, we should do follow-up on the patient, or if we consider as parameter the area dose product, which if it exceeds the 500 gray per centimeter square. So the patient should be informed on the possible changes in their skin, which is very unlikely. It could happen in pediatric patients, but it could happen in other patients. Then this is why the OPRIPALC program is born. This the optimization. It's a project, joint project of the PAHO and the WHO and the AIEA. And this is in order to help countries implement the basic international standards, safety standards. So among the results that we expect from this project is strengthening the radio safety culture, and we also having a shared methodology to assess X-ray equipment and interventional equipment. Also to have an optimization program with reference levels for diagnosis for Latin America and the Caribbean, to have these DRLs for diagnosis. They are the main strategy, they are the main tool to apply the principle of optimization. We also want to have clinical audit proposals and the dissemination of the results, the identification of difficulties, to get the lessons learned and the conclusions, etc. Here are the participating centers: Argentina, Brazil, Chile, Colombia, Costa Rica, Ecuador, Mexico, Uruguay, Peru. We are in Venezuela, we are in centers in Panama, and this is an open study. Here's the web address of our project, and so you can check and be part of this wonderful program. Here's part of the professionals who are working in this project. This is what we have been doing throughout the pandemics, which regrettably we haven't been able to get together, but the work has been very intense thanks to the virtuality. So I would like to thank you all for your attention, and I would like to send you a big hug. Thank you very much.
Jose, I don't know if you would like to make a final comment. We have had great presentations, and if we have any question from the audience, Jose, can you see one? The presentations have been perfect. It was a privilege sharing this session with all of you with such knowledge. We're a bit delayed, but we're having 10 minutes for questions. Dr. Comas Cardenas or Dr. Mas, if you want to make a comment or a question, you have 3 minutes each. Thank you very much. I'm Dr. Cardenas from Santiago, Chile. I wanted to ask something to all panelists, actually. Our part as regards radiological protection is very clear with your exposition and everything, but is there a gap as regards the equipment in Latin America, or in the team, in the colleagues, in the different hospitals and the different regions? Do you have knowledge of the level of the equipments that are being used in Latin America, and whether those pieces of equipment reach the minimum requirements to work in safety levels as regards radio protection? I don't know if you have that information. If you could answer that, if I may. Within the OPRIPAL project, we have had gathering information of the equipment, and we need to feel comfortable enough that our equipments are the best. The equipments are used in Europe or the States are the same that we fortunately are using in this region. However, the difference lies in the implementation of certain standards of radio protection that sometimes come accessory or supplementary in the equipment. What we want to do is to establish reference levels for diagnosis. And in Europe and in the States, those reports by the equipment are with a technology that is called structured informed dose. And in our countries, that is not implemented. Not because the equipment are not cannot do that. It is because the companies do not provide us with that information. So I can answer a little bit your question with that. The equipment are there, but sometimes companies do not implement that in the same way as compared to different countries. Yes, that is very important to know, because for us, the technicians, having that kind of knowledge allows us to make some adjustments, and these are not programs that are optional. They should be the mandatory ones when you buy the equipment. So thank you very much, Carlos, for your answer. Good morning. About that question as well, I would like to say something. We here in Cali, Colombia, are in Valle del Lidi Foundation with new equipment, and we are paying a lot of attention, apart from the technology of the equipment that are very good. They have great hardware and software, but there are companies that are working on the doses levels, and I cannot say names now, but it is important to know that when you get those pieces of equipment, there are some important techniques that some companies are already developing, and they are working very strongly with this, and this has to be taken into account when we buy the equipment. When we want a very good image, we get it with higher doses, for example, so we have to be careful. I have a question, if I may. Yes, Francisco. Doing an analogy with personal protection and the patient protection, doing an analogy with cars, for example, every year cars must go to the technical verification to check the lights, the brakes, the suspension, so we make sure the car is safe to be used, the same as the seat belt. All of them have to be there, and if you are driving, if you do not protect yourself, the person is fined. So the question is, seeing the lack of compliance with the protection, we do not use the goggles, the aprons, we do not take into account all of these measures. Should we implement a specific system to control ourselves, to check ourselves as regards the equipment and the PPE? Because in the practice, for example, of the car, people only started doing that when they were fined. So if you're not using the seatbelt, you will have to pay. I'm not asking for people to fine us, but which measures could we apply to be more compliant with these protection measures? I'm sorry, that is a very good question. I believe, in my experience over the years, we have seen effects, abnormal events. Dr. Porta talked about a lot of cases. In general, everything that has happened could have been foreseen. Doing maintenance, as you see, of the equipment in the same way we do with cars. Here in Argentina, we need to take the cars to technical inspection every year. There is an angiography machine or a CT machine that maybe for 30 years has not been serviced, and this is due to the lack of regulations, and second of all, for the lack of professionals. There are no specialized professionals in a lot of departments, and the physicians or technicians cannot do the controls, so it is necessary to comply with that. As Carlos Ubeda, we need to follow the international standards that say that we need to have specialists and that equipment must be checked, and it is not necessary to use the most updated regulation. We could see on social media that there was a new quality assurance for equipment, the last one. We don't need the last one. It is enough if we look for a standard of 10 years old from Tanganyika. It is not necessary to have the most updated one, but we need to take a look at them. And it is convenient that the departments have a permanent indicator. For example, every day before I go to work, I check a specific thing to see whether yesterday it was marking 50 and today I have 100 or 40, so to check for the changes in the equipment. And for that we need not a very sophisticated technique, but we need to see if in the same conditions today I have the same measurements as yesterday. So these basic things are not complied with. And I believe that your question, yes, has been a very has been a soft spot. We have modern equipment and very old equipment as well. I believe we can work with all of them, but they need to be serviced and the staff needs to know the condition they are working on. That is my opinion. Thank you very much. Thank you very much. I believe we all live with a message, and we understand that with small changes we can do great good in radio protection. Unfortunately, we do not have any more time for questions. We need to move on now. But I really appreciate this. It was an honor for me being able to be a moderator together with Rolo, with such distinguished guests and panelists. Thank you very much.
Good afternoon. My name is Alberto Segata. I'm the head of hemodynamics of Hospital Garrahan. Going to start the oral presentations for pediatrics of the August the 4th. Going to have a moderator next to me, which is Dr. Rafael Gutierrez from Costa Rica. And the idea is to do the 10-minute presentations, which have already been recorded. And we will do the questions after we finish. I'm going to do a little bit of an introduction. The first presentation is going to be Dr. John Breinholt, the head of cardiology division and the head of the catheter lab in Arizona, United States. He's going to talk about PDA device closure in neonates less than 3 kilograms and how it improves the growth and the respiratory status. The second one is going to be Raul Arrieta from Brazil. He's going to talk about the intentional fracture of biological prosthesis in pulmonary position to allow for a IPVP. And then we have Diego Antoni from Fundación Favaloro. He's going to talk about percutaneous replacement of pulmonary valve, the follow-up of valvular function in short, medium, and long term for 30 consecutive patients, single center experience. The next one is going to be again Raul Arrieta, talking about the percutaneous closure of ductus arteriosus, patent ductus arteriosus in premature babies with weight under 2 kilos, the initial experience in Brazil. Then Vittorio Lucchini from Casacuna is going to talk about fetal cardiac interventionism, the experience in Argentina. Then we will have Dr. Tarita Ribeira, a hemodynamist from Brazil, Curitiba. She's going to talk about percutaneous treatment of coronary fistulae in reference service for congenital cardiopathy. And finally, we will have Dr. Judith Ackerman, head of echocardiography from, and she's going to talk about the echocardiographical guide and ductus in closing through venous.
Thank you to the organizers of the SOLACI-CACI Congress for this opportunity. It is a pleasure to present our research that PDA device closure in premature neonates less than 3 kilograms improves growth and respiratory status. I have no relevant financial disclosures, and I will discuss off-label use of commercial devices. PDA closure in premature neonates is accomplished primarily by one of 3 modalities: medical management with cyclooxygenase 2 inhibitors, surgical ligation, and more recently, transcatheter device closure. Each has its drawbacks, with medical therapy having a lower success rate with risks of GI bleeding, necrotizing enterocolitis, and renal toxicity. Surgical ligation has an excellent success rate. However, it has risks of recurrent laryngeal nerve injury, pneumothorax, and hemodynamic instability. And catheterization, which also has an excellent success rate, has potential complications of device embolization, adjacent vessel obstruction, and vascular injury. In traditional PDA closure of a large PDA, vascular access is obtained in the femoral artery and vein. Most of us were taught never to cross the PDA prior to the angiogram. Device delivery is then through the femoral vein. These angiograms depict a typical procedure: aortic angiogram via the femoral artery, angiography with the device attached in its release, and then a final angiogram. Due to the complications previously reported on vascular injury in premature neonates, we changed the approach to obtain only venous access and by necessity, abandoning the teaching of not crossing the PDA. The primary angiogram is with the catheter near the aortic origin of the PDA, We then use echocardiography to look at the aortic arch to evaluate for success and evidence of obstruction. This is a pre-procedure echocardiogram of the PDA. This is the primary angiogram with the catheter across the PDA and a small caliber wire in the descending aorta. The device is deployed, and an angiogram via the delivery catheter demonstrates good position relative to the pulmonary arteries. We then employ echocardiography to look at the aortic arch and be certain there is no obstruction to flow. And we can look at the pulmonary arteries by echocardiography to ensure patency of its branches. We then release the device and the procedure is done. We then repeat echocardiography prior to returning the baby to the NICU. These are the devices reported in this study. The type 1 Amplatzer ductal occluder was infrequently used and was one of the early entries in this review. Additionally, the NIT occlude was seldom used. The Amplatzer vascular plug type 2 was a common device used until the introduction of the Medtronic microvascular plug, which became the primary choice of device used in our patients. The majority of these were performed prior to the introduction of the Amplatzer Piccolo device in the United States. Our objectives were to, 1, demonstrate the safety and efficacy of transcatheter PDA device closure in neonates weighing less than 3 kilograms, and 2, to analyze the effect of transcatheter PDA closure on respiratory status and growth in this patient population. This was a retrospective review of premature neonates less than 3 kilograms who underwent PDA device closure between 2012 and 2018. We reviewed procedural details, patient weight, respiratory support over the course of hospitalization, clinical outcome, and echocardiograms at different time points. Respiratory status was quantified using the pulmonary score, an equation reported in 2005 that takes into account oxygen, degree of mechanical ventilatory support, and medications used. We had 65 patent ductus arteriosus device closures that were performed on 63 patients. 10 patients had additional cardiac defects that required medical management. 4 patients died over the course of hospitalization that were unrelated to the procedure. 3 patients had no discharge information. This was because they were transferred out of our hospital to another facility that was not among our system hospitals. And there were 56 patients that achieved hospital discharge. The median weight of our patients were 2 kilograms. 65% of our patients had a weight of less than 2.5 kilograms at the time of catheterization. The median age at the time of the procedure was 53 days. We had a procedural success rate of 100%. There were 2 device embolizations that occurred after the procedure was complete while the patient was in the NICU. There was no residual shunt reported in 92% of the first post-procedural echo, and there was no residual shunt by hospital discharge in all patients. There was an overall improvement in respiratory support as shown by an average decrease in the pulmonary score of 0.14 in all patients and by 0.23 after excluding patients with additional cardiac defects requiring medical management. And this was at a median follow-up of 45 days. We noted a decreased pulmonary score or clinical improvement in 75% of patients, or in 88% of patients after excluding those with additional cardiac defects. There was no change in 9% and 6% respectively, and worsening of their condition in 16% and 6% respectively. This graph depicts the growth rate velocity relative to the timing of the catheterization. Growth velocity increased at 2 weeks post-procedure by 9 grams per day in all patients and by 7 grams per day after excluding patients with additional cardiac defects compared to 2 weeks pre-procedure. There was no procedural mortality. The major complications were the 2 device embolizations previously mentioned that were retrieved and a new device placed, thus the 65 devices in 63 patients. Moderate complications included arterial insufficiency that was treated with heparin. This complication no longer occurred once we started venous access only. The patient with endocarditis was unrelated to the PDA device. The others were hypertension and transient decreased systolic function that was treated with milrinone. Minor complications with no treatment provided were for arterial insufficiency, a possible valve injury that resolved, and mild flow acceleration in the aortic isthmus. So we conclude that transcatheter PDA device closure is safe and effective in infants less than 3 kilograms. Our procedural success was 100%, with 92% having no residual shunt at the first post-procedural echo. 16% of patients had an adverse event. 13% required treatment or intervention. And 2 patients with device embolization had successful transcatheter retrieval and repeat device closure. We further conclude that PDA device closure is associated with overall improved respiratory status, with 75% experiencing improvement and growth velocity increases of 9 grams per day after device closure. This is an example of one of our observations, a former 27-week premature baby who was on an oscillator the day prior to the procedure. He was extubated 7 days later and had significant post-procedural weight gain. Gracias por la atención.
Hello, good afternoon everyone. I would like to introduce this following topic, the intentional fracture of a biological prosthesis in pulmonary position to it's a percutaneous implant, so for the percutaneous implant of the pulmonary valve. As you know, the percutaneous implant of the pulmonary implant has been the method of choice to substitute the valve in the large majority of patients, of adult patients. Those patients with biological prosthesis are excellent candidates for percutaneous implants because they have an anchoring zone, a landing zone, which is very interesting in size. But some of the prostheses that have been implanted surgically have a small diameter, so those that are under 18 millimeters, and it could be a contraindication for the percutaneous implant of pulmonary valve. So the goal of our work is to talk about the initial experience with the intentional fracture of the pulmonary valve, of the biological prosthesis, and the PIPV afterwards. So we were able to achieve this intentional fracture in 3 patients who were taken to the cath lab to do this procedure. As I said before, it was we were going to mention a little bit about the manufacturers of the valves. But they were over 18 millimeters. This was calculated with an application called VIV aortic UBQQ, measured with their internal diameter with another application. This is the application that we used, we mentioned before. This is an easy to access from every cell phone, and you can, if you know the different valves, you can see the valve that we used for of these 3 cases. We had a Brazilian valve, so we can see the true internal diameter, and patients with a true diameter of 17 millimeters, and you can see there the radiological appearance of that valve. It's a very useful application, and if we know the brand of the valve, that's what we know. Find out the true diameter, internal diameter. This is the use of the valve in a tomography. We measure the diameter a little bit, and it's a little bit different because it's been placed. We get 17, we measure 18 to 20, and here we need to do the actual calculation of the internal diameter for our patients to measure here in the waist of these prostheses throughout the years. So what we do to break the valves, we use ultra high pressure balloons, Atlas Gold, in our BARD in successive diameters until we reach the ideal valve diameter without exceeding the valve diameter. We found an abrupt drop in pressure of the manometer. It was confirmed by the solution of continuity of the annulus in the radioscopy. And we found a statistical analysis performed by the SSP-23. And the results was that the median of age and weight were 29.9 years and 55.6 kilos, and the valves were from the over 90 millimeters in all patients. And the duration was of 12.6 years, in a range of 2 to 30 years. And there was, based on the difference that we had in the application, there was a significant difference between the internal diameter, nominal one, and the real one. And as for the fracture procedure itself, it was achieved in all patients with balloons of 18 by 40 and in 2 patients, and in 20 by 40 in 1 patient. There were no adverse events, there were no complications, and in all patients it was possible to implant a melody valve, number 22, in 2 patients. And a sapien valve number 23 was implanted in 1 patient, in which the patient in which we implanted the sapien valve replaced the stent previously because we had an angiographical doubt, but because we believed that there was a minimal dissection, so for precaution we placed the stent. So there is a large difference of 57 plus or minus 15. This is statistically significant, and there was no valve insufficiency afterwards. Here are some examples. In the annulus of the valve, implanted in the oblique right profile projection, we see a diameter quite reduced, and here we see the moment where the annulus is fractured. That exact moment when you can see on both sides with this continuity solution, in this case with the melody valve directly, because I had it covered with a stent. And the second case that I'm going to show is a patient that had also the cord valve, and this is a more important one, for the coronary. This is mandatory for all kinds of implants. Here we see when we do the fracture, check out the separation that we had and then the implant above the fracture of the valve that was affected. Then this patient, you can see after placing the stent, we implanted a sapien 23 valve. So as a reference of the valve plane, we can see the interior side, and the valve is of course a lot shorter than CT, which was 45 millimeters. And in this patient, we could see literally the placement of the valve, and here we can see the implantation of the sapien valve. As a conclusion, we can say that the intentional fracture of the biological prostheses in patients who received surgery is feasible, safe and effective, allowing for the PIPV in all cases without any complications and with excellent results. Thank you very much.
Hello everyone, I'm going to present our experience. The follow-up of the valvular function in short, medium and long term in 70 and 37 patients in our center. percutaneous replacement of the pulmonary valve. I'm going to start saying that cardiopathies involving the RVOT constitute an important group in daily practice. There are a lot of congenital pathologies that affect the outflow. These patients will require some treatment of the RVOT. The treatment for them changed drastically in 2000 when Dr. Bonhoeffer did the first percutaneous replacement, and from there a lot of valves have been implanted and new ones were designed. Some were self-expandable, the others were not, to adapt to the new anatomies of different patients. Echocardiogram is the method of choice to assess the function of the pulmonary valve. It has proven that there is no correlation with the gradient and with the catheterization, and a correlation with the MRI to assess the pulmonary lung function, the function of the pulmonary valve. We determine what we're going to do with the patient based on the echocardiogram. So this is very important for us and for the follow-up of patients with problems in the RVOT. The objective was to assess the pulmonary valve function with an echocardiogram in the short, medium, and long term of patients who had a pulmonary valve replacement in our center in a percutaneous way. You can see the images of patients, of the 37 we treated, and we can see the valve that is implanted. The first one with an anchorage area created, then a metal valve was placed. Then we have a venous valve. Some of them have self-expandable balloons and the others do not. How did we do this? This was a retrospective study. We included patients. We intended to treat with a percutaneous valve replacement, and we saw whether they were candidates or not. We treated 37 patients of 38 that were analyzed. 21 were men, 17 were women. 24 years was the mean of age, from 12 to 70 years. Which were the cardiopathies we treated? Most of them were tetralogy of Fallot, but there were some others, such as thrombosarteriosis, aortic stenosis, with Ross surgery, pulmonary stenosis. We treated also a type of connection of the right ventricle to the pulmonary artery with homographs. Which were those connections then? There were 21 patients with homographs, 12 with native RVOT, 3 with biological valve, and 1 Ionescu tube. When we separated these patients according to the different pathologies, we have a mixed disease of stenosis and insufficiency in the RVOT in 25 patients, and we also had a different group of 12 patients with pulmonary insufficiency. Here we have a ROS, the situation that we have with, where we can see the severe calcification, a graph with calcification on the right, and on the other image what we can see is the typical patient with phalloid tetralogy corrected with transannular patch, with a big truncus, with a big outflow tract. This was the type of patients that we treated, which were the implanted valves. Most of them were Melody valves, 22 patients, 1 Edwards, 6 venous, and 8 Polsta. We can see the images of these valves. First one is balloon expandable. This is the Polsta, and on the right the venous one. We're not going to go into detail of these valves. As regards the evolution and the results of our patients, we had one patient who died. We could not implant the valve due to technical difficulties in all the maneuver. The patient had pulmonary bleeding, hypoxia, then she was on ECMO, and several days after she had a hemorrhagic stroke. There were no other major complications related to the procedure. The hospitalization time was of 24 hours in all patients. We had one patient with endocarditis a year and a half after the replacement with viridians, with antibiotic treatment, and that patient also required a reintervention 3 years after the replacement with the homograft. It was a patient with a moderate stenosis who developed a more severe stenosis and then a moderate insufficiency. As regards the the ultrasound evaluation, it is important to have this tool. We need to do the follow-up in all of the patients. All of them underwent echocardiographical control, and 56% have over 3 years of follow-up and 24% over 5 years with echocardiogram. It's interesting to see the evaluations we did with this tool. In this chart, once we can see the gradients in time. We need to do a follow-up of 7. In one patient, we have a follow-up of 7 years or 6 years in some other, and some others less than 2 years. This is our experience, and we could clearly see that from the initial gradient before the replacement, there was a change, and from the replacement onwards, maybe they continued to have stenosis, but they were moderate, not severe. And we have follow-up of 2 to 7 years of follow-up in different patients. This as regards stenosis. As regards failure, pulmonary failure, depending on some quantitative and semi-quantitative measures, we define mild insufficiency 1 point, and we did this scoring to have this chart that we have here, and that line starts in 10 and goes down to 0, represents all the patients from the moment of the implant. kept mild insufficiencies, except in one patient who had an endocarditis, and this insufficiency progressed to being moderate. For us, the conclusion is that valve function after the valve replacement in a percutaneous access was very successful in the short, medium, and long term in our population of patients. The results obtained in the long term, with follow-up of over 5 years in some of the cases, prove that the pulmonary valve replacement in the percutaneous access should be the method of choice in patients with dysfunction of the RVOT when the anatomic conditions so allow. That will be all. Thank you very much.
Okay, good morning everyone. The topic that I'm going to introduce, I was accepted for a presentation, is the percutaneous closure of the patent ductus arteriosus in premature babies. As you know, the ductus arteriosus could be present in up to 50% of prematures, and it's an important cause of the late weaning of the mechanical ventilation. It's an important risk factor for necrosant enterocolitis, intraventricular bleeding, and bronchopulmonary dysplasia. The surgical ligation is not free from complications. 45% of the patients have developed instability after the surgery. As you all know, because we get as we said, up to 45% with the syndrome after the surgical ligation of the channel. So they could develop inflammatory syndrome of the premature baby. So the appearance of new devices has revolutionized the treatment of the DAP in PDA in prematures under 2 kilos. As you know, the treatment of choice for closing the ductus is the percutaneous approach, but in these children we still have an important challenge. So our objective was to describe the initial experience here in Brazil, 4 different centers where we performed the closure of the ductus arteriosus percutaneously in children below 2 kilograms of weight. We started on March 2020 to June 2021. We included 11 premature babies from different centers of Brazil. All of the procedures were performed in the cath lab through femoral vein puncture using an ultrasound, an echo, or a fluoroscopy. And we excluded PDAs with minimum diameter. We excluded the PDAs, with this experience with minimum diameters below 4 millimeters and compression over 3 millimeter. And as for the result, the mean gestational age of these patients was 25.5 weeks. The median weight at birth is 922 grams. And through the age of the median weight was 39.2 the growth and 1.28 kilograms. The minimum diameter was 2.3 millimeters with a range of 2 to 3.9. The prostheses used were the AD02AS from Abbott, and the Piccolo duct occluder is the new Abbott device in 3 patients. This is a new device. For people who don't know it, is a very small device. It fits in a 4 French system, has 3 parts, 2 discs and a central part. They have different diameters from 3 to 5 millimeters. and different lengths as well. 2, 4, and 6 millimeters. All of the implants for our premature babies were done successfully. We didn't have any kind of complications in these procedures. The residual shunt was seen in one patient with an ADO2AS. The pressure gradient in the pulmonary artery was found as 14 millimeters of mercury on the left pulmonary artery, and we found that there was a diastolic invasion. And we found a pressure gradient in the aorta through the device of 16 millimeters of mercury in one patient. This patient was weighed 800 grams, and the device was set in place. The patient evolved pretty well for 1 week and was extubated 8 days after the implant without an increase in the gradient. So in the follow-up and mid-term, all of them had a full occlusion. The extubation was possible in 9 of them, with a mean time of 9.8 days after the procedure. One of these patients died after a few days, but it had nothing to do with the percutaneous procedure. And here's one of the cases where we have 1,150 grams, PDA type F, 3.2 millimeter pulmonary, and we placed a 4x2 piccolo device. It's important to show that these patients, the device needs to be completely inside the ductus arteriosus, either in the pulmonary or in the aorta. And as a conclusion, we can say that our initial experience on closing the PDA in percutaneously in premature babies under 2 kilograms was a safe and effective alternative, which allowed for a good clinical evolution.
Eu sou residente de hemodinâmica do Instituto Dante Pazzanese e vou falar sobre o tratamento percutâneo de fístulas coronário-cavitárias em serviços de referência para tratamento de cardiopatias congênitas. As fístulas coronário-cavitárias são comunicações entre a artéria coronária e um vaso ou câmara adjacente, sem que haja passagem de fluxo pelo leito microvascular coronariano. Elas são entidades raras e sua incidência na literatura varia entre 0,019% a 4,5%. Das fístulas encontradas acidentalmente, 75% delas, pelo menos, não têm significância hemodinâmica. A principal origem das fístulas é da coronária esquerda, representando 52% dos casos, e cerca de 90% se comunicam com o lado direito da circulação, principalmente o ventrículo direito. A manifestação depende da magnitude do fluxo esquerda-direita e em pacientes em que a relação de fluxo pulmonar e fluxo sistêmico é superior a 1,5 para 1, as manifestações são similares àquelas de portadores de comunicação interatrial. Lembrando que a clínica de insuficiência cardíaca congestiva e hipertensão pulmonar é rara, mas pode acontecer em lactentes de baixo peso com fístulas significativas. Por outro lado, fístulas grandes, não tratadas após a segunda década de vida, podem evoluir com roubo de fluxo coronariano e isquemia miocárdica. Não há consenso quanto à indicação de tratamento nesses pacientes, mas de maneira geral, pacientes sintomáticos são tratados na maioria dos centros. O tratamento cirúrgico é de baixa mortalidade, com cerca de 10% de incidência de fluxo residual, mas ele requer circulação extracorpórea em cerca de 50% dos casos. Já o tratamento percutâneo, por ter menor morbidade, acaba sendo a primeira opção na maioria das instituições. Os objetivos desse estudo foram relatar a experiência de 2 centros de referência em hemodinâmica na oclusão das fístulas coronário-cavitárias com diferentes dispositivos e analisar os resultados imediatos após a realização dos procedimentos. Esse foi um estudo retrospectivo descritivo, com análise de prontuários de uma série de pacientes submetidos ao fechamento percutâneo das fístulas coronário-cavitárias no Instituto Dante Pazzanese e Hospital do Coração. Foram incluídos todos os pacientes com fístulas coronário-cavitárias ou coronário-venosas, tratados com dispositivos do tipo plug ou mola. Foi realizada análise de dados demográficos, dados clínicos, os dados técnicos dos cateterismos cardíacos e dos exames de imagem realizados. Na nossa casuística, nós encontramos 17 pacientes submetidos à oclusão de fístulas coronário-cavitárias, sendo 14 do sexo feminino e 3 do sexo masculino, com uma mediana de idade de 55 meses e uma mediana de peso de 14,5 quilos. Cerca de metade dos nossos pacientes eram crianças e metade desses pacientes eram adultos. 3 deles apresentavam cardiopatias associadas e a média de diâmetro das fístulas foi de 5,2 milímetros. 5 dos pacientes foram tratados com molas e 12 pacientes foram tratados com plugs vasculares. Na nossa casuística, mais de 50% dos pacientes tinham fístulas originárias da coronária direita e quase todos eles com fístulas que drenavam nas câmaras direitas. Desses pacientes tratados com mola, nós utilizamos coils do tipo de Jean Turco ou coil de Flipper, e os pacientes tratados com coils tinham fístulas de menores diâmetros, e nesses casos a técnica era ligeiramente diferente. Isso porque, com o fechamento de coil, como a gente observa no segundo vídeo, o implante do dispositivo é realizado através da via transarterial, ou seja, o catéter que entrega o dispositivo, ele avança através da fístula coronária, ele se aproxima da região de drenagem, onde então é liberado o dispositivo. E aqui, numa angiografia de controle, a gente vê a oclusão realizada com sucesso. Já no caso dos pacientes tratados com plugs vasculares, nós utilizamos plugs vasculares da Unplatter, do tipo 1, do tipo 2 e do tipo 4, e nesse caso a técnica empregada envolveu a confecção de alças arteriovenosas. Então, como se vê no segundo vídeo, aqui também de um paciente com fístula coronário-cavitária a partir da coronária direita, e se vê que existe um guia que avança através da fístula e alcança a cavidade de drenagem. Na cavidade de drenagem, esse guia é laçado, e então, completando a alça arteriovenosa, e a partir daí consegue-se avançar com a bainha adequada, que são bainhas mais calibrosas, através da via venosa, ao invés de utilizar a via arterial. Isso permite o implante de dispositivos de tamanho adequado para fístulas maiores, com menores complicações em relação aos acessos vasculares. Da nossa casuística, 10 dos 17 pacientes tiveram oclusão completa e imediata das fístulas, e no ecocardiograma de controle realizado 24 horas após, apenas 3 pacientes apresentavam fluxo residual, mas eram fluxos residuais de baixa velocidade. Nós tivemos 2 intercorrências. Uma dessas intercorrências foi em um paciente de 1 ano e 9 meses, com 11 quilos, que tinha uma fístula da descendente anterior para o ventrículo direito. Esse paciente havia sido tratado com o uso de coil flipper, houve embolização do dispositivo para a artéria coronária proximal, esse paciente evoluiu com infarto agudo do miocárdio de parede inferior, edema agudo de pulmão e uma parada cardiorrespiratória que foi prontamente revertida, e ele apresentou recuperação completa no segmento. Outro paciente que teve intercorrência também foi uma criança, mas uma criança maior, de 5 anos, com uma fístula da coronária direita para o ventrículo direito. Essa criança também foi tratada com coil, 2 coils de Jean Turco, foi ocluída a fístula com sucesso, mas na angiografia de controle foi identificada a lentificação do fluxo da coronária direita e alterações eletrocardiográficas compatíveis com isquemia. Foi visto que o enchimento distal se dava através de colaterais da coronária esquerda. Esse paciente ficou, então, com anticoagulação oral e teve normalização do traçado eletrocardiográfico sem maiores intercorrências. nós concluímos a partir desse estudo que o fechamento percutâneo das fístulas coronárias é uma opção segura e eficaz para o tratamento dessa doença em casos específicos. Os diferentes aspectos da indicação e da técnica desse paciente precisam de uma análise individualizada, porque não existe consenso absoluto, e são necessários estudos maiores para compreender a eficácia e a segurança do tratamento a longo prazo, além da análise da relação de risco e benefício do tratamento em casos de pacientes assintomáticos. Muito obrigada.
Hello, my name is Judith Ackerman. I'm going to talk about my work as a transthoracic echocardiogram for the DAB, for the PDA. This is done currently with an angiographic guide, and it was implemented through the TTE, which prevents the use of contrast and reduces the time of radioscopy. Ductus is the persistency of the arterial conduct, and its persistent in isolation is normal until 3 months, where it does not produce hemodynamics overload, and the approach is percutaneous to solve it. The percutaneous closure prevents the complications of the surgical closure. It's done routinely with an arterial puncture in a cath lab and a fluoroscopic guide, and it has been done to exclusive venous puncture with TTE without angiography. This is one of the many great objectives, is the population of prematures, where we could do the closure of the ductus in the crib of the patient, since we have been able to do in our hospital with a 900-gram patient. We wanted to describe our experience in guiding with TTE, percutaneous PDA's closure, through venous approach in relation to assess the usefulness of the guidance in terms of the use of the prosthesis. It was a prospective, descriptive, and observational work with 23 patients with a median age of 26 months and 12.7 kilograms. The procedures were performed through anterograde approach, and inclusion criteria were patients with diagnosis of ductus with hemodynamics repercussion, patients with under 10 kilograms or over 10 kilograms with a good echographic window. The exclusion criteria were the ductus associated to congenital cardiopathies with contraindications or with infections. Then we did perform several echocardiographic views, as you can see here in this slide. The first one is for short axis, external short axis, which is very complete for the observation of the ductus, the aortic, the cardiopulmonary, then we can see the pulmonary artery, and then when we have the ductal view, with which allows the elongation of the descending aorta as well as the ductus. This is a suprasternal view, which allows us to see the ductus in its entire extension to avoid the doors into the aorta. The apical with 4 chambers allows us to see the repercussion hemodynamically and in the different valves. And this is the subcostal view, the sagittal, with deployment of the descending aorta, which is friendly to the hemodynamics expert because it's similar to the angiographic view. It's especially useful to assess the length of the ductus, which can be underestimated for the external left side. And it's also useful for small patients with a good subcostal window. When do we perform the TTE? In the office to indicate the percutaneous closure, to screen the patient. In the hemodynamics lab in the baseline, in the procedure, and after the closure, and 24 hours later. Then we value the PDA based on the shape and the measurements, the diameter of the pulmonary end, and the length and the aortic ampoule. Then we have the shape, the aortic blister, sorry. Then we have also the shapes in which we can see the ductus. Based on the shape, we can see that the ductus could be tubular, saccular, elongated, or fetal, which is wide and tortuous. we expect them to be conical normally because of the population that we assess. When we perform the measurements of the aortic blister and the pulmonary end, on the length, we need to compare the different views because we cannot see the same things, and it's not good to have everything in the same plane. We can do the same measurements. We always have to compare them. And now we can see the repercussion of the ductus with the transvalvular places, and we can see also the presence of some chambers and the flow. We also need to evaluate the repercussions of the ductus, assessing the Doppler. We see, for example, here that we have a large ductus, and we also need to look for the presence of pulmonary hypertension, taking advantage of the continuous gradient with the ductus. At the baseline, we assess the cardiac structures that can be affected: the descending aorta, the left pulmonary, tricuspid and pulmonary valves, and the pericardium. During the procedure, we will monitor the advancement of the guide, the sheath, and the occlusor, then the deployment of the device, the positioning, and always evaluate the protrusion that isn't excessive, the presence of shunts, and then the compromise of adjacent structures, particularly the most vulnerable ones. Then we see during the procedure, we can see the guide positioned in the right ventricle, and here we see a little bit of a shunt because the device has not been deployed, and we are evaluating the left pulmonary branch main. So here we have the descending artery. We can see the device, and we can see the pulsatility with a pulsated Doppler. After the immediate closure, we can assess the PDA. We consider that it's an effective closure if we have a full closure or the persistence of a minimum shunt without hemodynamic repercussions and the absence of complications. And in external projections, we can see that is always evident to see. It's always good to see protrusion of the device. When we check through the colors, that this is not significant because if we got value in all of the planes, it's not protruding towards all of the planes if it is a normal case. But since it is a sensible area, we need to check the pulsating flow to check that there is no stenosis caused by the device. We perform the statistical analysis. We consider the p-value over 0.05, and our results were as follows: that the hemodynamics repercussion and the mild pulmonary hypertension was seen in an important number of patients. The PDA were mainly conical. We had the measurement of the pulmonary end of 3.3 millimeters, 6.10 in the aortic, and the rest as you saw on the slide. In 14 patients, we had a radial force at a known diameter, and we had a good correlation between the pulmonary end measured by the transthoracic echo and the larger opening of the stent. In 9 patients, we had devices without radial force movement, and we had a good correlation between the pulmonary end and the diameter of the mouth of the device. This allowed us to choose the prosthesis, and in all patients, we used a device with a larger diameter of 3 millimeters over the pulmonary end. We had no complications, and we performed effective closures of the PDA in 23 out of 23 of the cases. In 13 of the cases, we had a minimal residual shunt, which persisted in 4 of them after 24 hours, but we consider this a successful procedure because it was just minimal. Our conclusion is that the TTE guidance of the percutaneous closure of the PDA allows to perform the procedure safely and effectively, avoiding arterial punctures. The TTE was enough to perform the necessary measurements to choose the prosthesis, and we will need studies on more cases to a more precise assessment and will reflect the learning curve. If we review the information in our country, Dr. Damsky-Barbosa and Dr. Vignola also did some work in this regard. In our hospital, we have performed an evaluation of the correlation of the medicine with and what we saw was a good correlation in the measurements of the pulmonary end, of the aortic blister, and of the length. This is a review of the works that are being published, where they highlight the importance of the challenge of the venous function to do the TTE and the population of premature children as an interest population, as well as doing this at the bedside of the patient. We have a guide has been published for the PDA for patients with low weight. This is our work that I'm presenting here, which was an important experience, which allowed us to feel safe with this technique. And our challenge is to do this, to continue in this road systematically with patients that need to doctor's closure and to go beyond and achieve using the usage of the TTE as a guidance to perform this on the bedside for patients with low weight. Thank you very much.
I'm going to introduce the experts. Dr. Xavi Francisco, Director of Congenital Interventions of Rio de Janeiro. Jorge Gomez, Chief of Pediatric Hemodynamics in Posadas. Dr. Javier Alberto Gutierrez Gil, Interventional Cardiologist of Valle del Vil, Cali, Colombia. Dr. João Luis Banica, a cardiovascular interventionist in Porto Alegre, and Dr. Ernesto Vallejos Mondragón, also cardiology interventionist in Cali, Colombia. We are open to the questions of the panelists, and then we can go to the questions of the moderators or from the audience. I would like to know if in this work a follow-up of the vascular prosthesis for the pulmonary valve, if you had fractures or ruptures of the stent of the prosthesis, and how you did the follow-up with fluoroscopy and at what time. In the follow-up of our patients, the truth is that we did low follow-up as regards the ruptures of the stent of patients where we placed a stent before. There was a time when we did an analysis, a deeper analysis with the venous valves with radioscopy, and we saw that some patients out of those 6 were different, but we did not do a follow-up, a specific one on the rupture of stents in our patients. The motivation to investigate that, we did not do that routinely, but if we had seen a patient with a significant complication, we should evaluate that in the future, yes.
Eu gostaria de fazer uma pergunta para o Dr. Raul Arrieta. ¿Puedo hacer en portugués?
Sí, por supuesto.
Sí, Dr. Arrieta, os casos de fratura intencional, como você faz a avaliação da compressão coronariana? Se você faz antes da fratura, como você avalia, já que aquela região está fixa e ela só vai se distender depois da fratura? Se você calcula pela simples distância da coronária, e em relação à fratura e o implante de válvula, você faz tudo no mesmo procedimento?
I'm going to answer in Spanish. Very slow for everyone to understand. The translation, that is an excellent question, because when you do the test, we do not fracture the valve and we did not have a distension, and there can be some compromise. In general, we do it before to see that it is not closer to the annulus, and before the implant we do that with a non-compliant balloon to see whether it is compressing the fibrous parts or not. It caught our attention, and we always must take this into account. And adding to that, it is important when you are placing a valve, the pre-stenting or not pre-stenting, which defines the behavior or the things that we're going to do. Because if you have the suspicion there has been a rupture of the stent or of the fibrous area, not only the valve, you need to check that. And the answer is yes. There are 2 tests with the balloon, one before and one after. There was a different question in Portuguese. Yes, in the implant of the valve is the same procedure. In the 3 patients underwent the same procedures. The patient tolerated the intervention very well because it is an insufficiency of a low pressure valve, and they have a degree 1 of insufficiency, but always with the same procedure. I have another question. At which atmospheres do you rupture the metallic ring in your experience? That is a very good question, Alberto. The truth is that you need to, it is not so much as regards atmospheres, but the successive use of balloons. If you have an internal diameter of 17, a true 17, you go with a balloon of 16 first of all, and then when it is lower, you go and you soften the prosthesis. Then you move to 18, and you go to 18, and sometimes that is ruptured with low pressure, or it is not ruptured, and we have to move to a 21, but in a gradual way. I don't know whether there are other questions from panelists. Yes, I wanted to ask something.
Hola doctor, bienvenido a esta sesión.
I can do it in Spanish for everyone to listen. Which device did you feel most comfortable with? And I did not know with which device you had an embolization. The device that I use the most is Medtronic one, MVP. This was not made specifically for the conduct, but I also use Piccolo. But what I see in a lot of cases is that I reach higher conducts, and MVP can be used for bigger ones. These are the ones that suffered an embolism. They are not as rigid as Amplatzer, but if you have to choose the size a bigger than what the instructions say, that is sometimes the case. With the time, there are less embolizations because we're using the larger ones. I don't know if I explain myself. You can, if I use number 5, that is for vessels up to 5 millimeters of diameter, but I start going up to 7 when I reach 4, 4.5. Okay, perfect. One question for PDA closure in low weight. Raul said something about that. If the gold standard so far has been surgery, which patients should we send to surgery and not to a catheterization? I believe Raul mentioned something with prematures below 2 kilograms, saying that over 4 millimeters of diameter and shorter than 3. In these cases, the closure was not performed. In the rest of the speakers, what do you think about that? In my experience, if you're using piccolo, when the duct is lower than 4 millimeters, you cannot use it. With MVP, I have closed it up to 5 or 6 millimeters. So for me, I do not think there is a ductus that can be sent to surgery. I have not found so far one to send to surgery. Sometimes in kids that are a bit bigger than, or that weigh more than 2 kilos, and the duct is type C maybe. If it is too short, we cannot use any MVP. Sometimes we need to use piccolo. So instead of using that, we should use Amplatzer type 1. That should not be used in this size of patients. These are the ones that are very difficult to close during a catheterization. Perfect. And a clinical condition that makes you choose want to go to surgery or catheterization. Surgery instead of catheterization. There is a risk of if there's a risk of endocarditis or an infection, maybe that will be a situation in which with that device we can have problems, but no more than that. I have had some cases that have problems with the liver, with the kidneys, I'm sorry, and I try to use contrast, but just a small amount. Perfect, thank you very much. One question to Dr. Talita Ribeiro. As regards coronary fistulas, in which type of fistulas do you indicate anticoagulation or anti-aggregation, and for how long after the percutaneous closure?
Boa tarde. A gente não tem um protocolo definido, essa é uma discussão grande em relação ao uso de anticoagulante ou apenas antiagregação, mas nos casos em que foram revistos no trabalho, a opção da anticoagulação foi empregada apenas nos pacientes que tinham dilatações importantes da coronária, da artéria coronária proximal à fístula, como, por exemplo, um daqueles pacientes que realmente teve uma clínica de isquemia miocárdica após a oclusão por conta de lentificação do fluxo e desproporção entre a coronária proximal e a coronária distal à fístula. Então, na nossa causística, a gente optou por anticoagulação oral em 2 casos. Infelizmente, a gente não tem os dados de longo prazo desses pacientes, mas eles foram mantidos em anticoagulação oral por pelo menos 6 meses. E os demais pacientes foram mantidos apenas com aspirina, mas aspirina apenas para os pacientes que tiveram shunts residuais. Então, nesse caso, a gente teve 3 pacientes com shunts residuais após 24 horas, então eles foram mantidos com aspirina a longo prazo.
Perfect. I will ask a question to Victorio. The presentation we could not show all of it, but in which time of pregnancy do you think we should intervene to avoid hypoplasia of the right ventricle and of the left ventricle? I would like to make a question to Judith, and apart from congratulating you for the presentation, it is remarkable the work that you have done and the cath lab. I have two questions, in fact. The sagittal, where you have an image almost the same of the angiography, you put it in 90 from to the top to the bottom, or is it the same? Yes, exactly, that is the case. And the other question is, the pulmonary end is measured with color or without one? The measurements, we should do it with and without color, and we do different measurements to reach the conclusion of what is the grade measurements. Some guys said that we should do it in black and white, some others suggest we should do it in color, and in my experience it is an average of the different measurements, and you see that there is a good correlation when you do several measurements and you take the average of those. And can you see the systolic and systolic part of the ductus? It varies in the angiography, it's very difficult to measure, but maybe with the ultrasound it is a constant in the image. Yes, it is true that there are some differences, so we need to have an average of them. We need to see the cardiac cycle when we measure the pulmonary and aortic end to see whether there is a correlation. Yes, that is very important. Something I wanted to say about the sagittal view is that it is not the case of this job, because this was performed in older patients, but as we talked about preborns of low weight, in the cases we have to do in the bedside in the hospital of 900 grams, this view was a great finding, because he could not deal with the thoracic compression. And going with the procedure, we did the subcostal view to have a friendly view for the hemodynamic specialist. I don't know whether we have more questions. I don't see any more questions from the audience. I have one question for Diego Antoni. In your presentation, I did not see a protocol to follow or follow up of the valves. If you have for how long you should do the follow-up, if it is echoes, ultrasound or not, for the follow-up of the pulmonary valve. Do you have? You are mute. You are mute. Follow-up, we do an echo, an ultrasound 1 day after the implant. Then we do a control after the month, 6 months and a year, and then a 3 years. Okay, perfect. Yes. As a closure of septal defect. We do not have a MRI of all the patients, and this work was specifically going to see the ultrasound of the pulmonary valve. Maybe we can see what happened with the stenosis, for example. We needed to see how the valve was functioning, in fact. I have one question, Diego. Did you see any differences as regards the progression of the pulmonary failure in the valves that were without a gradient as compared to those where we had some gradient? No. In the follow-up of these patients, the pulmonary insufficiency was not modified regardless of the gradient after the intervention. There was minimum or mild insufficiency or failure. One patient had an increased problem and was the one with endocarditis. and we had a bigger gradient with him. We had a gradient that was very high in this specific patient. I don't know if we have a different question from the panel or the audience. I would like to thank you all and congratulate you for the presentations, and we finish with the session. Thank you very much. Hello, good afternoon everyone. Welcome to this session. That is the oral presentation of different cases. I will be as a moderator together with Jose Alonso, and I want to introduce you to the panelists we're going to have today. All of them are colleagues and great friends of mine, such as Dr. Damsky Barbosa, Dr. Rolando Gomez, Dr. Mauricio Jaramillo, Dr. Walter Mosquera, and Dr. Raúl Rossi, known by everyone. Now we're moving to the presentations of the different works, and due to administrative constraints, we will be as moderators with Jose, and we will also introduce some of the works. And Jose, you can introduce the first one. Dr. Luis Carlos Giuliano, about percutaneous occlusion of the interatrial communication. Luis Carlos Giuliano, who will provide this talk.
Anda a paso para discutir o acceso vascular. Mi portugués es muy malo, pero adelante, Dr. Giuliano.
Bom dia a todos. Primeiramente, queria agradecer a oportunidade de compartilhar com vocês esse caso, que é bastante interessante, na minha opinião. É a apresentação de um caso clínico a respeito da oclusão percutânea de comunicação interatrial. Ainda há espaço para discutir o acesso vascular? Depois de tanto tempo, depois de tantos procedimentos já realizados há mais de 20 anos, com a técnica de abordagem de acesso vascular pela técnica de Seldinger, uma técnica já classicamente conhecida, será que ainda há espaço para se discutir a utilização do ultrassom para se fazer o acesso vascular nas intervenções percutâneas da comunicação interatrial? Essa é uma pergunta que nós vamos tentar responder. Eu declaro não haver nenhum conflito de interesse para essa apresentação. Trata-se, então, de uma paciente do sexo feminino, de 37 anos, assintomática do ponto de vista cardiovascular, com uma história pregressa de migrânia. Vale a pena salientar que era uma paciente atleta, ela era participante de várias competições de triatletismo, e na consulta de rotina apresentava-se, como eu disse, assintomática, numa classe funcional 1 da New York Heart Association, com um eletrocardiograma apresentando distúrbio de condução pelo ramo direito e um ecocardiograma transtorácico que mostrava uma comunicação interatrial tipo ósseo secundo e um aumento discreto do ventrículo direito. Pois bem, essa paciente foi admitida eletivamente em novembro de 2019, submetida a anestesia geral, mais o ecocardiograma transesofágico para acompanhamento do procedimento. Mostrava pelo eco uma comunicação interatrial única de 10/9, com fluxo esquerdo-direito. Foi realizada uma punção femoral pela técnica convencional, isso realizado por um operador experiente, com mais, como eu disse, com mais de 20 anos de experiência no procedimento de comunicação interatrial. Foi utilizado o introdutor 6F. Depois que foi colocado o introdutor, introduzido, houve o refluxo na via lateral do introdutor, porém, houve uma dificuldade bastante grande na progressão do guia 035 colocado num catéter multipurpose. O guia simplesmente não subia para o átrio direito, para depois a gente alcançar o átrio esquerdo. Então, nesse momento, foi retirado o guia 035 e foi realizada uma injeção de contraste dentro desse catéter. E vejam o que nós encontramos. Nesse vídeo dá para perceber que nós vimos uma contrastação de uma cavidade que certamente não é a cava inferior, certamente não é a veia femoral. E confesso aos senhores que ficamos absolutamente perdidos, não sabendo em que cavidade estávamos injetando esse contraste. Parecia um cisto, poderia ser uma alça intestinal, mas realmente não tínhamos a menor noção de onde estávamos entrando com esse catéter. Bom, essa é uma imagem estática. Nesse momento, nós chamamos a cirurgia gastrointestinal. O cirurgião veio até a sala, olhou e disse: eu também não sei onde vocês estão. A grande preocupação era que estivéssemos dentro de uma alça gastrointestinal, e isso poderia ser um desastre. Bom, a solução que foi tomada, naquele momento, a decisão tomada, foi de levar a paciente para o centro cirúrgico, já anestesiada, e se fazer uma laparoscopia exploradora. E assim foi feito. E na laparoscopia exploradora, vejam os senhores o que encontramos. Um cisto ovariano à direita de 15 centímetros cúbicos, no qual o catéter, o introdutor, foi inadvertidamente colocado dentro desse cisto. Percebam aqui um pedacinho da imagem do introdutor 6F entrando diretamente no cisto, e aqui a imagem de uma estrutura vascular. Bom, aqui embaixo nós notamos o cisto novamente, de um tamanho grande, fazendo compressão no fundo de saco, e nesse momento foi realizada então a oforectomia direita, por videolaparoscopia, sem intercorrências nenhuma. A paciente recebe alta no segundo dia de pós-operatório, bem, e nós abortamos nesse dia o procedimento de oclusão da comunicação interatrial. Vejam aqui nessa imagem aqui embaixo, depois de retirado o cisto, a ponta do introdutor, ela foi retirada tranquilamente, sem o menor sangramento. Essa paciente foi readmitida em janeiro de 2020, onde foi novamente colocada na mesa de hemodinâmica, e agora foi feita uma punção sobre a visualização de ultrassom e colocado o introdutor certamente agora na veia femoral direita. Essa imagem tridimensional do eco transesofágico mostra uma CIA de 10/9, um diâmetro estirado de 12, e foi feita a oclusão, então, com uma cera flex ASD 14 milímetros. Percebam os dois discos aqui ocluindo a comunicação interatrial. Interessante aqui o ecocardiograma transtorácico no primeiro pós-operatório, mostrando a oclusão total da comunicação interatrial. O ecocardiograma transtorácico em 30 dias teve os achados semelhantes, e no segmento de 3 meses não houve nenhuma intercorrência com essa paciente, do ponto de vista gastrointestinal não, mas do ponto de vista ginecológico, e também tão pouco do ponto de vista cardiovascular. Isso aqui eu fui procurar na literatura, e a literatura tem pouca coisa a respeito de acesso vascular com dificuldades ou com as complicações. Vejam que esse aqui é um trabalho multicêntrico e que comparou a abordagem pelo ultrassom no acesso vascular femoral com o acesso normal, ou seja, o acesso já padronizado há muitos anos. Bom, vejam que eles pegaram tanto operadores treinados como operadores em treinamento. E quando os desfechos primários foram comparados, os desfechos primários foram hematoma com queda importante da hemoglobina ou com a formação de fístula arteriovenosa, vejam, senhores, que não houve diferença estatística entre a técnica convencional com a técnica do ultrassom, mesmo nos operadores em treinamento. E nos operadores treinados, já com experiência, também, da mesma forma, não houve nenhuma diferença estatística. Já quando nós vamos para os desfechos secundários, que seja o tempo de punção, seja a primeira passagem no acesso, ou a necessidade de de punções extras, ou até mesmo punção inadvertida da artéria femoral, observem os senhores que houve uma diferença, sim, estatística, mesmo nos operadores mais experientes. Então, nos desfechos primários não há tanta importância, não há diferença nenhuma, mas nos desfechos secundários, de verdade, há uma diferença quando se usa ultrassom em relação à técnica convencional. A literatura também é muito pobre em relação ao achado de cistos ovarianos com procedimentos de comunicação, de oclusão de comunicação interatrial. A comunicação interatrial é um defeito comum da cardiopatia congênita, ela é estimada mais ou menos a prevalência de 1,6 para 1.000 nascidos vivos, né? E a comunicação tipo ósseo secunda, ela constitui 75% desses defeitos. A predominância do sexo feminino, aproximadamente 2 para 1, e ela frequentemente ela é diagnosticada na vida adulta, porque passa a infância sem sintomas e passa desapercebida. E quando eu fui procurar na literatura a respeito de cisto ovariano com comunicação interatrial, vejam que a literatura é bastante pobre em relação a isso. E eu achei um trabalho a respeito de uma paciente que tinha pericardite, defeito do septo atrial e a presença de cisto ovariano hemorrágico bilateral. Isso são sempre achados, assim, são casos anedóticos, porque realmente não tem nada a ver a comunicação interatrial com essas duas entidades. Então, em conclusão, o defeito atrial é uma condição congênita, não está relacionada com pericardite ou com cisto hemorrágicos ovarianos, né? E nós apresentamos esse caso raro, na realidade, um achado raro, ao longo da nossa experiência. E fica aqui a pergunta, né? Precisamos fazer acesso vascular em adultos, evidentemente, porque quando se trata de criança, a conversa é diferente, mas em adultos, há necessidade, é imperativo que se faça uso do ultrassom? Ou será que ainda podemos continuar fazendo o nosso acesso vascular da maneira convencional? Essa seria a pergunta deixada aqui depois desse caso interessante no meu ponto de vista. Muito obrigado.
Olá, meu nome é Thalita Ribeiro, eu sou residente de hemodinâmica do Instituto Dante Pazanese e hoje vou falar sobre a oclusão das comunicações interventriculares musculares pela técnica híbrida perventricular, com enfoque nas indicações, resultados imediatos e tardios. As CIVs musculares são o segundo tipo mais frequente de CIVs, constituindo de 5 a 20% dos casos, e a característica anatômica que define esse grupo são suas bordas exclusivamente musculares. Tradicionalmente, as CIVs são corrigidas pelo tratamento cirúrgico com o uso de circulação extracorpórea, mas frequentemente as CIVs musculares ficam escondidas nas trabeculações grosseiras do ventrículo direito, o que muitas vezes requer do cirurgião o uso de técnicas mais agressivas, como a ventriculotomia ou o uso de retalhos superdimensionados. Isso faz com que aumente a morbidade, seja pela maior taxa de defeitos residuais, disfunção ventricular ou ocorrência tardia de aneurisma da parede ventricular. Além disso, o uso de circulação extracorpórea, ela é particularmente danosa nos pacientes de baixo peso. Outra opção de tratamento é a bandagem pulmonar, mas as bandagens são de difícil ajuste e representam uma alta taxa de reintervenção. Já o tratamento percutâneo é um tratamento já consagrado, já tem sua eficácia e segurança demonstrada, mas fica evidente nos estudos de que esse tratamento tem maior taxa de complicações em lactentes de baixo peso, isso seja pela confecção da alça arteriovenosa, que pode causar instabilidade hemodinâmica especialmente em pacientes menores, ou também pelos riscos em relação aos acessos vasculares nessa população. Visando preencher uma lacuna entre o tratamento cirúrgico e o tratamento percutâneo para uma população específica de pacientes de baixo peso ou pacientes com, num cenário clínico desfavorável, foi criada e desenvolvida o tratamento perventricular, que consiste no acesso através de estenotomia mediana, punção da parede livre do ventrículo direito sob visualização direta, e um tratamento guiado por ecocardiograma transesofágico para o implante da prótese intracardíaca. Aqui se vê um exemplo dos pacientes, de um dos nossos pacientes recebendo esse tipo de tratamento. Então, no primeiro vídeo de ecocardiograma, a gente vê a determinação do local de punção, que tenta buscar um ângulo mais retilíneo possível em relação ao defeito septal. Em seguida, se vê o posicionamento da bainha através da CIV, e aqui, já com a sua ponta na cavidade livre do ventrículo esquerdo. E aqui nessa imagem, é possível ver a liberação do primeiro disco desse paciente. Os objetivos desse estudo foram avaliar os resultados imediatos e tardios do tratamento perventricular das CIVs musculares em recém-nascidos e lactentes em centros de referência em cardiopatias congênitas e avaliar suas características clínicas e anatômicas pré-procedimento, indicações de tratamento com a técnica híbrida, complicações no pós-procedimento imediato e tardio, além de parâmetros clínicos e ecocardiográficos do segmento. Esse foi um estudo retrospectivo de pacientes submetidos à oclusão perventricular de CIVs musculares congênitas no Instituto Dante Pazanese de Cardiologia do Estado de São Paulo e no Hospital do Coração, entre os anos de 2007 e 2017. Foram coletadas informações do período pré-operatório, intraoperatório e pós-operatório precoce e tardio do prontuário médico desses pacientes. A fim de analisar esses pacientes, eles foram divididos em 2 grupos de acordo com a indicação do método perventricular. Um primeiro grupo, em que o tratamento, em que a oclusão da CIV era parte do objetivo principal do tratamento, e esse grupo incluiu pacientes portadores de CIVs musculares isoladas ou associadas a cardiopatias acianogênicas de perfluxo, como persistência do canal arterial ou comunicação interatrial, e o outro grupo em que pacientes que possuíam cardiopatias complexas associadas, com necessidade de tratamento cirúrgico ou percutâneo concomitante ou logo após, em que a oclusão da CIV era parte de uma terapia coadjuvante. Nesse período, foram realizados 23 procedimentos em 21 pacientes com mediana de idade de 4,7 meses e com mediana de peso de 5,5 quilos. Esses pacientes, mais da metade deles tinham menos de 6 quilos ou menos de 6 meses de vida, e aqui chama a atenção como essa população era constituída por pacientes com algum fator específico. Mais da metade dos pacientes apresentavam comorbidades, 15 desses pacientes já haviam sido submetidos a procedimentos prévios, e 11 pacientes foram encaminhados da unidade de terapia intensiva, ou seja, já estavam em cuidados intensivos quando foi indicado a oclusão perventricular das CIVs musculares. Da nossa casuística, 10 pacientes foram incluídos no grupo de tratamento primário, ou seja, eram pacientes, metade deles com CIVs musculares isoladas e metade deles com CIVs musculares associadas à comunicação interatrial ou persistência do canal arterial. E, por outro lado, no grupo de tratamento complementar, foram incluídos 11 pacientes. Desses pacientes, 4 possuíam coartação da aorta, sendo que um deles tinha um ventrículo esquerdo limítrofe e foi tratado de forma híbrida inicialmente. 2 pacientes tinham transposição das grandes artérias associadas à coartação da aorta, 2 pacientes portadores de tetralogia de Fallot, um paciente com estenose valvar pulmonar, um paciente com defeito do septo átrio ventricular e um paciente com displasia aórtica, com insuficiência aórtica importante. Em relação aos dados pré-operatórios, eu vou ressaltar que, a princípio, mais de metade dos nossos pacientes tinham mais de uma CIV muscular, sendo que 4 deles tinham CIVs musculares múltiplas, com diâmetros de CIV no grupo de tratamento primário de 8,1 milímetros e no tratamento complementar de 7 milímetros, com diâmetros indexados elevados. Esses diâmetros indexados, eles são cerca de 2,5 a 3,2 vezes maiores do que os diâmetros indexados encontrados nos estudos de pacientes que foram tratados de forma percutânea para a oclusão de CIVs musculares. Do período intraoperatório, esses pacientes, 3 desses pacientes no grupo primário, além da oclusão perventricular, foram posteriormente para a correção de defeitos com circulação extracorpórea. No grupo de tratamento complementar, também 3 pacientes foram para a correção com circulação extracorpórea de defeitos adicionais, mas chama a atenção que no grupo de tratamento complementar, pelo menos 3 pacientes com coartação da aorta foram poupados da circulação extracorpórea por terem sido submetidos à oclusão perventricular da CIV, e a coartação da aorta foi corrigida, então, sem SEC. Nos nossos pacientes, 5 pacientes do grupo de tratamento primário foram corrigidos com prótese única, 10 pacientes do tratamento complementar foram corrigidos com prótese única, enquanto 3 receberam 2 próteses. Foram utilizados no total 31 dispositivos, quase 70% desses dispositivos eram próteses ceras dedicadas para CIVs musculares, os outros 23% eram próteses Amplatzer de CIV muscular, e a prótese fígula de CIV muscular foi utilizada em uma vez, a prótese memoparte uma vez, e em um dos casos foi tratado com uma prótese fígula de persistência do canal arterial. Em relação aos dados pós-operatórios, foi considerado sucesso aqueles casos em que houve comunicação interventricular alvo ocluída, ausência de shunt residual significativo e ausência de complicações graves. Isso foi atingido em 9 dos 10 pacientes do grupo de tratamento primário, mas em um desses pacientes houve deslocamento do dispositivo no sentido inferior, a prótese acabou ficando apoiada na corda da tricúspide, levando a shunt residual significativo e insuficiência tricúspide importante. Essa paciente foi encaminhada, então, para a retirada cirúrgica da prótese, o que facilitou para o cirurgião encontrar a CIV, já que a prótese ainda se encontrava lá. E depois da correção, o paciente teve uma boa evolução, não tendo maiores intercorrências no período pós-operatório. Já no grupo de tratamento complementar, também 12 dos procedimentos foram bem-sucedidos. Em uma paciente especificamente, a paciente que recebeu a prótese fígula de tratamento de canal arterial evoluiu com shunt residual significativo, um quadro de insuficiência cardíaca congestiva grave, com falhas de extubação, e ela foi encaminhada cerca de 12 dias depois para a troca da prótese. Nessa segunda tentativa de oclusão periventricular, essa paciente apresentou um sangramento significativo na retirada da primeira prótese, com choque hipovolêmico e hemorrágico, evoluiu com parada cardiorrespiratória, que foi revertida, mas a paciente manteve-se instável e, infelizmente, foi a óbito poucas horas após o procedimento. Apesar da gente não ter conseguido dados de longo prazo em parte desses pacientes, os dados do segmento mostram mostram resultados animadores. Então, o tempo de segmento foi de cerca de 4,6 anos, nenhum desses pacientes evoluiu com reintervenção não planejada, todos os pacientes evoluíram com classe funcional 1, assintomáticos, sem necessidade de medicações para tratamento cardiovascular, e nenhum deles evoluiu com arritmia. A partir dessa nossa casuística, nós concluímos que o tratamento perventricular de CIV muscular, ele é indicado para pacientes com baixo peso, com CIVs amplas ou múltiplas, com grande repercussão hemodinâmica e portadores de comorbidades importantes, ou em pacientes com cardiopatias complexas associadas com necessidade de tratamento concomitante. Também é um método considerado muito útil em pacientes em recuperação após procedimentos prévios. Aqui fica claro que é uma técnica com alta taxa de sucesso, um baixo índice de complicações a curto, médio e longo prazo, e que potencialmente ainda elimina a necessidade de circulação extracorpórea em casos específicos. Muito obrigada.
Hello everyone, for me it is a great honor being part of the SOLACI Congress. The work I'm presenting today is rehabilitation of pulmonary branches in patients with duct-dependent pulmonary circulation with ductal stent. This was performed in the Instituto Nacional de Cardiología Ignacio Chavez in the city of Mexico. I'm Dr. Luis Alfredo Romero, pediatric cardiologist, interventional cardiologist. I do not have any conflict of interest. Our work had as objective to describe the procedures of rehabilitation of the pulmonary branch with ductal origin to see the efficacy and the complications. Our design was descriptive, longitudinal, observational, and retrospective, and we observed 24 patients of Instituto Nacional de Cardiología in a period from 2009 to 2018. We observed 24 patients as we did all the echocardiograms, the angial CT, and the physical examinations before the interventions. The selection of patients was with patients with the absence of right pulmonary branch, or left one, or bilateral, in the ductal origin, associated or not associated with congenital heart disease. What we did in this procedure, in these 24 patients, was a stent angioplasty in the ductus arteriosus to do a rehabilitation of the branch on the right, on the left, or bilateral, and then to take it to a second stage for a total correction, complete correction, or final correction. And we assessed palliative treatments as well. The results we observed in these patients, of these 24 patients, was that the Z-score between the first measurement and 1 year after the implant of the stent was 2.7 plus minus 1.58. And we measure that through an angial CT in all of the patients at the time of the diagnosis and 1 year after the stent angioplasty. Out of these patients, 5, that is 20.8%, required reintervention due to an obstruction of the stent. In 4 of them due to thrombosis of the stent, where we performed a new stent angioplasty within the stent. 25%, that is 6 patients out of 24, underwent surgical correction. That was one of the limiting complications. 6 went to surgery to be corrected. The mean of age at the time of surgery was 65 months. That will be like 5 years, plus minus 79 months. And the rest of the patients, we did not. There were some complications and they could not undergo full correction. In this chart we can see the demographic characteristics of the patients. We observed that 11 patients, 45.8% were male and the rest, 13, were female. The pulmonary artery most affected was the left one, 75%, and right in 3 patients. This corroborates in some studies that we observed. They said that the left branch is mostly associated with congenital heart disease and the right branch was seen in isolation. In our study we observed the same proportion. We see that the left branch is associated with congenital heart disease, the most frequent one that we observed was pulmonary atresia with intact septum, and on the left on 3 patients in an isolated way. Signs and symptoms we observed were at the cyanotic level. 9 patients had cyanosis and the rest had pulmonary hypertension or pneumonia or cardiac failure and dyspnea associated with cyanosis. The measurements, as I said before, of the Z-score at the time of diagnosis with angio-CT and 1 year after a follow-up, 1 year after the stent angioplasty. The measurement of the pulmonary branch at the time of diagnosis from 7.67, and at a year after the angioplasty we see an increase, very considerable one, of 12.81 with a standard deviation of 5.4. In the Z-score we had at the start a mean of minus 1.63, and at follow-up there was 1.08. We also evaluate the clinical studies, the functional area that was modified with Ross. Most of the children had a mean of a functional class of 2. At follow-up, the functional class improved with class 1. What we observed during the whole work from 2009 to 2018, there was a significant increase in the pulmonary branch in the first measurement and then after 1 year after in the follow-up. In the studies we have had that there are very few. There is no consensus over the optimal treatment for this condition. Some studies propose after the diagnosis performing an anastomosis in this area, and some others do a stage procedure. There are a lot of conflicts in this aspect on how to manage this problem. There is no consensus. This study that we performed has a great number of patients, 24 patients, but they have wait for the surgical correction in most of them. Only 25%. It is very difficult to assess when we will have complications if there was improvement or not of our patients. At follow-up, the complications of the definite final treatment would clear a global perspective of this treatment. If we could have taken them to total correction, we could solve the complications or see whether they need re-intervention or not. As a conclusion, in our work, we observed the rehabilitation of pulmonary branches in patients with pulmonary circulation dependent on the duct with implanted ductal stent is effective, but it would have been more complete if we have had all the patients taking to a full correction. This follow-up of patients complemented with surgical treatment is essential. We want to get there, and that is one of the conclusions we arrived at in our work. Because if we can do a follow-up in all of the patients, not only in the first stage but in the complete surgical correction, we can assess the efficacy of this intervention and compare that with some other strategies that are not staged but with a correction at the time of diagnosis, and we could establish a better management for this pathology. Thank you very much.
Okay, hello everyone. My name is Jose Alonso. I'm from Buenos Aires, Argentina, and I'm here to present the ductal stent implants in patients with congenital cyanotic heart disease, patients with dependent ductus. They need quick treatment and prostaglandins and the greater surgical anastomosis improve the product. keeping in mind the morbid mortality associated, the ST has appeared as a therapeutic alternative. Since the beginnings in the decade of the 90s till now, there have been many technological improvements and methodological improvements which have improved the results, which make this a more than satisfactory alternative. In this work, we're trying to assess the indications and the results and the technique to learn from ourselves and see if there's anything that we need to change. Between July 2017 and May 2020, in 10 patients, 3 of them women, female, with age 19 plus minus 2 days and the weight of 2.9 plus minus 0.8 kilograms. We started working for some reflux, some pulmonary reflux, and pathologies associated were 5 patients with pulmonary atresia with an integral septum, then pulmonary atresia with interventricular communication, an external extreme phallotetralogy, one with and 2 with other issues. The echocardiogram is fundamental in selected cases when we cannot perform a TC scan, a CT scan. So the multi-CAT CAT scan is necessary to get an appropriate image of the ductus and see the way that the pulmonary artery goes into the femoral arteries. These are both important in patient screening and in the appropriate planning. The advantage that we have with the CAT scan, with the new equipment, is that many times we are able to work with the image to define the best position available for a ductus, which reduces the amount of contrast and the number of positions that we need to do. We need to have for the procedure. Here we have an echo, an ultrasound, where you can see the colors here and how the ductus moves in till it comes into the pulmonary. So we can see with the vessels from the neck, and we can see that the brachiocephalic trunk is inside in the ductus, favoring the idea of trying to get to the ductus in the most direct way possible. Here we can see a ductus that seems to come out of the lateral side, but it's hard to confirm if it is from the lateral or from the inferior side of the aorta. So in these cases, when you're in doubt, it's best to do the CAT scan. Here in this echocardiogram for the ductus, we see a little bit here into the brachiocephalic trunk. So in these cases, we cannot define it precisely, and we need to do the CAT scan. Sometimes it allows us to see a little bit and to apply contrast injections in the procedure. But if they are patients with metabolic acidosis or some other cases, then we seem to have problems with those patients, and here the CAT scan is very good. Here we can see how it goes into the lateral side of the aorta, and we can see the length of the ductus with the pulmonary artery and the pulmonary branches. The advantages of the CAT scan, as I said, is that it not only allows us to see it with plenty of precision, but we can actually see where's the stenosis, where the route. In this case, it goes left towards lateral, then towards the front, then ascending, and this is then we can see the pulmonary arteries, and this allows us to see a little bit about the shape of the system of the patients. As for the prostaglandin, when the stenosis is very large, it's important to stop with leave the perfusion in spite of the prostaglandin. And if we have administered heparin, we can try with the prostaglandins a few hours before. If the stenosis after taking out the infusion is very high, we can reduce the dose of prostaglandins to a minimum so that the patient is stable when we reach the cath lab. The procedure is done with general anesthetics, and here we need to keep the values over 200. And heparin, sometimes we continue administering during the procedure, depending on the case, and the patient needs to be stable hemodynamically. We may think that they may go into a stroke, which may create instability. Maybe we need to use vasopressors in certain cases. It's important when we have stenosis in the pulmonary branches or pulmonary coarctation. It's best to cover the entirety of the extension of the stenosis, as well as the entire extension of the ductus. This could provoke a jailing of the lateral side, and that so maybe for open cells that might be the case. So we might not need any other kind of intervention if we cannot dilate the cell. In this case, we place the stent, covering all of the stenotic area, the whole ductus, the right carotid, the brachiocephalic trunk, and we can see how we did not need any other type of intervention. To choose the stent, we need to consider the weight of the patient. We choose a stent for patients over 3 kilos, 3.5 to 4 millimeters, and under 2 kilos, we choose a 3 millimeter stent. So it's important to understand the emergence of the ductus, the length and diameter, the number of curves, as well as the pulmonary anatomy, to decide if we need one or more stents and which is going to be our approach. In general, we prefer to use the least amount of stents possible. We want to use one, but sometimes this is not possible. If this is necessary, we try doing an overlap around 25% at least. We try to use drugs and biodegradable platforms, but the effect of the drugs released by stent, that's what we're checking out right now, but we wouldn't have major problems with this. This is a case of the lateral side. We see a pulmonary atresia with some of the materials that we need are hydrophilic guides, extra supports, and sometimes we get guides for chronic occlusions if we have thrombosis. And then we have right straight coronary catheters, 5 French guides to improve results. And here we have the final case that I showed you with the brachiocephalic trunk, and this is when we have really direct access. Sometimes this makes us be able to place a stent. These are patients very, very young, so we try not to use large catheters. We try to do it through 4 French, but so that we don't injure the patient. And then this is the final result. We placed 2 stents. Not the final curve would have straightened far too much. And in this series, the effectivity was 100%. The saturation was increased from 75.5% to 91.5% on average. The patients were both with double antiplatelet treatment, DAVT, and 7 patients didn't require reintervention. The complications that we had, this is important, is that in the procedure we haven't had ductal spasm. We haven't had hyperflow. In one of the patients we had a stent acute thrombosis, which was aspirated and redilated with a balloon, which was 1 millimeter larger than the original balloon. 2 of the patients had a stent migration. In both, we placed a second stent covering the entire ductus. 1 of them was actually sent for surgery 8 days later, and for the other one we waited until 3 months had passed. Both had been stable, but what we get is an undesired jailing, in which the flow can be maintained, and having the surgery 8 days after the stenting was okay because the patient was stable, and for the other one we waited for 3 months. After the procedure, one of the patients died a few days later due to a severe cyanosis. After this patient, we started giving them with DABT, with aspirin before. We did aspirin before. Then we see that in the first 3 months there was an important risk of this happening. One of the stents caused stenosis in the left branch, and after the 3 months they required a plasty in the surgery. So to conclude, we are learning. The decision must be made by a heart team, a multidisciplinary heart team. We need to know which is the surgery that's going to be performed. In this case, the series of patients. This operation was a good therapeutic alternative, but we believe that previous planning is very important, using appropriate imaging. We need to have all the materials that are necessary. There are different technical approaches. We need to consider all of them beforehand, and ductal stenting is an alternative palliative measure action that requires a learning curve. That also has complications and good results. Thank you very much.
Olá, meu nome é Thalita, e agora eu vou falar sobre o tratamento percutâneo combinado com técnicas vasculares para o tratamento de coartação da aorta associada a aneurismas. É de longa data a descrição de aneurismas associados à coartação da aorta, e eles podem ocorrer com lesões associadas à coartação nativa da aorta em pacientes com diagnóstico tardio, ou como sequelas no segmento de pacientes que já passaram por tratamento cirúrgico ou percutâneo. A abordagem de coartações associadas a aneurismas é particularmente desafiadora quando esses aneurismas, de certa forma, acometem o arco distal ou os vasos da base, e ela depende de múltiplos fatores, como a idade, a localização dos aneurismas, os calibres de referência da aorta e das regiões coartadas, a presença ou não de circulação colateral e as características anatômicas de possíveis landing zones para o implante de endopróteses ou estentes. Devido à maior morbidade do tratamento cirúrgico, na maioria dos centros atualmente é realizada a associação de técnicas para permitir um tratamento efetivo com menor taxa de complicações. Os objetivos do nosso estudo foram descrever uma série de casos em que o tratamento da coartação da aorta e dos aneurismas foi realizado com técnicas associadas de cirurgia vascular, endovascular e percutânea. Esse foi um estudo retrospectivo, descritivo, de todos os casos de coartação da aorta associada a aneurismas submetidos a tratamento com técnicas combinadas de intervenções vasculares no período de 2012 a 2020 no Instituto Dante Pazzanese. As informações obtidas do prontuário médico foram os dados demográficos, o diagnóstico de base, a realização ou não de procedimentos prévios, manometrias e informações angiográficas, qual o procedimento realizado e as complicações imediatas. Nesse período, nós tivemos 5 pacientes tratados com técnicas combinadas, sendo 4 pacientes do sexo feminino, 1 paciente do sexo masculino, com uma mediana de idade de 29 anos, mediana de peso de 60 quilos, e desses pacientes, 4 já haviam passado por procedimentos prévios. Os primeiros 3 pacientes foram pacientes que receberam tratamento com endoprótese, sendo que 2 deles receberam ainda um tratamento complementar percutâneo com implante de stent, devido ao gradiente significativo na região de coartação. O paciente 1 e o paciente 3 eram pacientes adultos que haviam sido submetidos à correção cirúrgica de coartação da aorta com tubo de Dacron. Já a paciente 2 era uma paciente de 16 anos que havia sido submetida a dupla troca valvar e correção de CIV na primeira infância. Essa paciente, então, ela, além da região de coartação, tinha um aneurisma de cerca de 44 milímetros na aorta torácica descendente, e essa região da coartação nunca havia sido abordada, ela havia sido abordada apenas para correção das cardiopatias associadas. Nesse caso, foi implantada uma endoprótese Valiant de 24 por 150 milímetros, com sucesso, com bom posicionamento final, mas ainda a prótese não tem força radial para o tratamento da coartação, e por essa razão o tratamento foi complementado com implante do stent Palmas Gênesis 4014. E aqui as angiografias com o resultado final, mostrando um excelente posicionamento do stent e da endoprótese, além de um tratamento efetivo do aneurisma, sem complicações vasculares associadas. Os outros 2 pacientes possuíam aneurismas associados à origem da artéria subclávia esquerda, e por essa razão foram submetidos à derivação da carótida para a artéria subclávia esquerda. Um dos pacientes essa derivação foi realizada por anastomose direta entre os vasos, enquanto na outra paciente, essa derivação ocorreu com implante de um tubo de PTFE número 6. Esse paciente número 4 chamava atenção que ele já tinha 3 abordagens prévias na região de coartação. Na infância, ele havia sido submetido a uma estimoplastia com anastomose término-terminal, ele evoluiu com recortação, foi submetido à ortoplastia com balão, e cerca de 3 anos depois ele foi submetido ainda a uma ortoplastia com stent. E aí no segmento, cerca de 7 anos depois, esse paciente evoluiu com 2 aneurismas associados ao stent, um deles no terço médio do stent, um outro aneurisma na borda superior, que era o aneurisma que estava próximo à origem da artéria subclávia esquerda. E a última paciente da casuística, que é essa paciente número 5, ela era uma paciente adulta, que é a única da nossa série de casos que nunca havia sido submetida a procedimentos prévios. Então, essa paciente tinha um aneurisma associado, uma hipoplasia do arco associado à coartação, com um aneurisma na região do arco distal, bem próximo à origem da artéria subclávia esquerda. Então, essas são as imagens da angiografia, da primeira angiografia que ela fez. Na época, ela não tinha ainda um exame de imagem com tantos detalhes anatômicos. No momento em que foi identificada essa lesão, esse caso foi levado para discussão em equipe multidisciplinar, e naquele momento foi decidido pela tentativa do tratamento com a derivação carotídeo subclávia esquerda, para permitir, então, o tratamento dessa paciente. Aqui são as imagens dessa mesma paciente, aqui a imagem do intraoperatório, quando foi realizada a derivação com o tubo PTFE número 6, e a gente vê aqui exatamente a região da anastomose, e aqui já no segundo cateterismo, que ela realizou 2 dias após a derivação, mostrando a patência do tubo PTFE e a perfusão preservada da artéria subclávia esquerda. Depois, então, a paciente foi submetida a um tratamento da hipoplasia do arco e da coartação com um stent revestido CP de 39 milímetros. E aqui já a angiografia de controle, mostrando um excelente resultado e preservando, então, a origem da artéria carótida esquerda e a perfusão, e aqui a gente pode ver a perfusão da artéria subclávia esquerda, aqui no canto superior esquerdo da imagem. Dessa nossa pequena série de casos, todos os procedimentos foram bem sucedidos, tanto na correção da coartação, quanto no tratamento dos aneurismas, e não houve nenhuma complicação imediata nesses pacientes. A partir desse nosso estudo, nós concluímos que o manejo da coartação da aorta associada a aneurismas é desafiador e requer uma análise criteriosa e individualizada com equipe multidisciplinar. A combinação entre intervenções percutâneas e vasculares é uma opção factível e que possibilita a abordagem menos invasiva para casos complexos, e os principais candidatos a essa técnica são pacientes com recoartação e aneurismas de grandes dimensões, ou aneurismas com comprometimento da artéria subclávia esquerda, e em casos bem selecionados, essa combinação parece ser segura e eficaz. Obrigada.
Hello everyone, I would like to thank the SOLACI organization for this invitation to this prestigious congress. Today I'm going to be talking about stent in ductus arteriosus, experience of 5 years from 2015 to 2020. I am a resident of the second year of interventional cardiology in pediatrics of Hospital General de la Plaza in the city of Mexico. As an introduction, the use of the stent in the ductus arteriosus to keep its patency has been widened in patients with congenital heart disease with diminished pulmonary flow. Management is a challenge in the neonatal period since we need to avoid the use of prostaglandins for a prolonged time. The general objectives are to describe the experience in the stent of the stent in the ductus arteriosus in congenital heart disease with decreased pulmonary circulation depending on the ductus. Specific objective: identify the heart disease that is most frequent, with ductus-dependent pulmonary circulation, establishing the success rate with stent, and listing the complications. Within our materials and methods, we have that this is a 5-year study, descriptive, transversal, and perspective observational. In the sample, we have 31 patients with congenital heart disease, with ductus-dependent pulmonary flow, with cardiac catheterization, and in an attempt to place a stent. We could place the stent in 24 patients under general anesthesia, orotracheal intubation in all of the patients. We use this modified Seldinger technique for vascular access and heparin non-fractioned 100 units per kilogram, and all the patients were with antibiotics with cefotaxime. Most of the stents were coronary stents. Within the inclusion criteria for our patients, we had patients with congenital heart disease with ductus-dependent pulmonary circulation diagnosed with echocardiogram, entering hemodynamics to be placed for us to place a stent from 2015 to 2020. We also saw patients with associated comorbidities who were low weight, premature, who had stenosis or hypoplasia of the pulmonary branches, and associated syndromes. The exclusion criteria: patients without the authorization of the parents to perform the procedure, patients with data of systemic infection or septic shock, or the patients we decide to send to surgery. These are some images and videos of a patient with a ductus arteriosus. It stems from the ascending aorta. I used this to mention that what we did was a carotid access. It is not frequently used, but in this case we used that because it is not a very easy access. We have a ductus that is very tortuous and very difficult to access. The technique is very complex but possible, so that's why I'm showing you this. In the first image you see the red arrows of the road of the ductus arteriosus and the pulmonary artery. Then in the video we see the coronary guide that is already placed on the right and the left ventricle, and through the guide we can pass the coronary stent. We used coronary stents, most of them are without drugs, and in the last image what we see is the procedure that was had successful outcomes. We see the placing of the stent that is attached to the ductus arteriosus. The yellow arrows show the stent. For us, this was a successful procedure. In the frequent diagnosis we have, where we have placed the stent in ductus arteriosus, we have 13 patients with pulmonary atresia without VST, and pulmonary atresia with VST. We had some others. Then we had atresia in the tricuspid. Then we have pulmonary atresia with VU. Then only the single ventricle with pulmonary atresia on 3, and one patient with transposition of the great vessels corrected with pulmonary stenosis. Within our results, in 31 patients, we had that the most frequent gender was male of 16 patients, constitutes 61.6%. The mean of weight was 2.8 from 1.7 to 6. The mean of the age was 6 days from 1 day to 90 days. The oxygen saturation at the beginning was of 70%, from 60 to 80, and the final one was 85%, from 75 to 95. To place the stent or the vascular implant, we use for femoral artery 5 French introducer and 5 French guide, and for femoral vein the same measurements. For the carotid, we use a 4 French introducer and a 5 French guide. Within our complications, we had early complications in 7 patients, that is 22.58% of patients. We had a migration of the stent in 4 patients with arterial insufficiency and 2 with thrombosis of the stent. Within our success rate, we could place the stent in 24 patients. That would be a success rate of 77.41%. Stents we used were without drugs in 3 patients. We could not place a stent in 6 patients, and we used coronary stents that were not medicated, we did not have drugs in 22 patients, and with medication in 3 patients. Type of vascular access in the pulmonary artery of 20 patients, vein and the femoral artery and vein in 6, femoral vein in 2, and carotid in 2. The mean time of the procedure was of 135 minutes. It is not very easy to do that, and sometimes we have some delays depending on the conditions of the patient, and we have to stop the procedure until we stabilize the patient. These are complications we may have. All of the procedures were done under intubation, orotracheal intubation, sedation, prophylaxis with cephalotine, for example. We used non-fractioned heparin of 50 to 100 units per kilogram, and we stopped prostaglandin before the intervention. Sometimes we interrupt that when the patient goes to the cath lab and start with the puncture. We had some complications in these cases in 3 patients, 9.67%. We had a stenosis of the stent in 3 patients, and we had to re-intervene in 3 patients. We had In 19 patients, the proximal region of the aorta, descending aorta, where the origin was placed, we had some tortuosities in 13 patients. Most of the procedures were urgent. Patients that come in very bad conditions to the hospital, and we have to take them to urgency care to place the stent in the ductus arteriosus. Our experience has been increasing year by year. My tutor placed 1 in 2015, 2 in 16, 5 in 17, 4 in 2018, and in 2019 13 were placed. In 2020 they performed 6, and this modified the parameters that we have had. Now, as for the conclusions of our experience in Hospital General La Raza of Social Security in the City of Mexico, is that the placing of stent in the ductus arteriosus is a palliative procedure that is effective and feasible. Our mortality morbidity rate is low, 6.45%, and the success rate near 80% is very encouraging and goes with what is described in literature, and this motivates us to continue to place stents in ductus arteriosus in patients with ductus-dependent heart disease. Placing stents in patients that are under 2.5 kilograms with long ducts and very tortuous ones does not represent a contraindication. And we had a great sometimes the procedure is not very easy, but we can do it. And in our hospital, the learning curve has been increasing gradually with the passing of years. These are our conclusions, this is our experience, and I thank you for the opportunity of inviting me. Thank you very much.
Good afternoon. I would like to thank the scientific committee for accepting this presentation, this poster presentation, my poster presentation. The topic is the venous ductus stent and septostomy as an atrial septostomy bridging strategy in a very low weight, birth weight infant to reach the surgery. I have no conflicts of interest. This is a case of maybe a twin baby with body weight 1.6 kilo, low weight, with a total anomalous diaphragmatic pulmonary venous connection restricting for foramen valve. We know that this is a cardiopathy with very high mortality and especially augmented, increased by the patient weight. So the treatment decision becomes complex for the interventional team as well as for the cardiological and surgical interventional team. So we had to decide what to do. So we went to the bibliography, to the literature to find a strategy where we found we had a hard time finding publications, and we went to year 2011 and found this work where there's a temporary stent, venous ductus in a newborn. So in reality there were 3 cases in which 2 of them with low weight, 1.7 kilos, 1.5 kilos, and the other one was 3.2 kilos. And all of them had procedures with stents. The particular situations were that when you could see the patient with 1.7 kilos, after the stent was placed, the patient had infectious complications and died 2 months later. And the 1.5 kilos was very successful from the beginning to the end, and in which we could do the corrective surgery at 5 weeks of living, and the other case is the case of the patient with 3.2 kilograms, which has pretty good weight, but they decided to use transitory stenting, temporary stenting, and one of the things that we wanted to point out was that they were able to operate at 4 days of the ductus, and the ductus remained open, which caused an important anemia, which needed to be closed later. And we found another work in 2014 in a patient with 1,270 grams, which required the same situation of with an obstruction of the infradiaphragmatic venous collector. And the problem was that the patient also had dysmorphia, so there was a chromosomal anomaly, and since a couple of days were elapsed after making the decision, they did it through a jugular approach. They implanted a stent on a venous ductus and re-stenosed 2 weeks later, so the stent needed redilation with a balloon. And at 2 months of living, they were able to do the final procedure, correction. So these were the history, the antecedents, the background. So we had this patient, 6-day-old. We had a catheterization with positioning a 6 French introducer in the vein, using the umbilical vein, and it went through the ductus. So we did auricular cytostomy to we used a C5 balloon, Z5, and this is one of the balloons most known that we have, and there we had to try to de-obstruct the venous collector, the infradiaphragmatic venous collector. So we decided to go through the umbilical and using the 6 French introducer to implant a renal type stent, a 5/18, the Herculean model, and this was successful. We see here the image. We have the introducer in the venous conduct, this venous ductus, and this allowed us to enter a catheter on the right side inside the right ventricle, and to be able to do the angio and be able to show the venous collector, how it goes down, and it positions on the area of in the portal sinus to later be able to empty out into the right atrium. This is all, of course, based on the conditions that the patient had. If I can show you here a picture, you will be able to see the picture of the venous return, and you can see how the entire portal system, how it's filled, and the way that we get to the portal sinus that communicates with the umbilical vein. And also you have the left portal vein and the right portal vein. So to be able to empty through this venous ductus to get to the cava, to the inferior cava, vena cava, and this is how we put this in the stent by setting a first injection through the 6 French sheath, and we could see and take the necessary measurements where we would have to place the stent. Here we have the first initial length of approximately 12 millimeter. And this is why we opted for the Herculean, the 5/18, mounted, to have it mounted, and You have a rapid exchange, and it goes through a 014 with a very good navigability. And here you can see the passage is wide in the venous ductus. So this allows for the emptying of the venous collector. Here we have a static image where we can see the stent implanted and in color how it passes through. So the child was able to be subjected to corrective surgery at 20 days of age with the connection of the pulmonary vein confluence to the posterior wall of the left atrium. The patient was discharged from the hospital at 2 months of age with a body weight of 2.5 kilos. Remember that the patient weighed 1 kilo 600 and they had a chronic sildenafil treatment. The patient remains with pulmonary hypertension which remains, the pressure remains high, and after these problems in the during the patient's fetal life. The patient continues to receive controls even today, 1 year and 10 months after the procedure. So we had an excellent result for a heart disease with high morbidity and mortality. So we thought that it would be relevant to do this presentation, especially because we have found no records of these types of procedures associated with the obstruction of the foramen ovale that required before anything else, we required to do an auricular septostomy. So I hope that this has been interesting. I thank you very much to all of you.
Can you hear me? I believe we're on time. If we have some minutes, I would like to thank the panelists and the speakers. The truth is that all the cases and presentations were very interesting. If you want, panelists can ask the questions to the different speakers. Thank you, Marcelo. First of all, congratulations for that case, Marcelo. I have some questions for José Alonso and Dr. Javier Enrique Fajardo about the ductal stent. Prostaglandins, I know you talked about that, but I would like to ask you about the time to interrupt them, to start with the procedure, because here sometimes we have the problem that when we take the patient to the procedure, sometimes 6 hours, 3 hours, sometimes we interrupt that at the time and we see ducts that are very big, and it is very difficult to choose the stent. That's one question. And the other one, which ductus would you rule out as regards the curves of the ductus? There are some ductus that have 1, 2, or 3 curves, and which would you rule out to take to the cath lab or surgery? Dr. Fajardo. Hello, can you hear me? Yes, perfect. This is a very interesting question, particularly from us regards to what we have studied. It will depend on the experience of each school. There are some schools that stop that 2 hours before the procedure or 6 hours before. Particularly, what we do is as soon as we are going to start with the puncture of the patient, of the vascular access, we stop the prostaglandin at that point. Of course, sometimes it happens that having prostaglandin for a long time in a patient that will undergo the procedure may dilate the ductus, and when we place the stent, it may happen that the stent is not the correct one in the measurement, in the sizes. But if we suspend the prostaglandin just before starting the process, it's good. We did not have major complications, and as regards the size of the stent as well. Can you repeat the other question? Which would you rule out? In our experience, we have been gaining experience with the time. My tutor was a very capable person. I learned a lot from him, and we do not rule out any ductus arteriosus, regardless of the amount of curves or tortuosity. We try to place stents in all of those stents. And the interesting point is that from our study that we performed in 5 years, most of the ductus are tortuous. They have 2 or more curves. They are of complete access. And we also place stents in patients that are under 2.5 kilograms. And even if they have some stenosis in the pulmonary branch, we also treat that and place a stent there. We do not rule them out. Each stent for us is welcome. Each ductus is welcome for us. We try to place the stent anyway. In our experience, as regards the prostaglandins, we do not have a standardization. We go and see with the patients. There are some patients that are good, and we may interrupt prostaglandin and to see the response of the patient in reducing the ductus. Once we do that, we can resume the prostaglandin while you try to look for the materials and having the materials here in this country is very difficult. We do not have them. Sometimes it takes 2 to 3 days. That is one of the techniques. If the patient has a lot of cyanotic state, we continue with prostaglandin, but we do not have a standard to follow 6 hours or 12 hours. We see with each of the cases. If the patient is stable with the prostaglandins, we see a weaning study to know when we can interrupt that. And sometimes we can reduce the doses of prostaglandin without interrupting it. In some other cases, we can interrupt it at the time of the procedure. In some cases, we cannot. Initially, we have an experience of 10 patients, and patients who have a very tortuous ductus and very big one were ruled out. But we think that in the future, adjusting the technique with the new materials, microcatheters, for example, to navigate the ductus, mainly when they have a very close curve that are very difficult to rectify with support guides. Those patients initially are ruled out, but we think that in the future we will also be able to treat them. Yes, I agree. We need to cover the complete extension of the ductus. Yes, we need to cover that entirely. And if stenosis or pulmonary coarctation is present, we also have to treat that even if it is jailed to the adjacent structure. If it is necessary, we dilate the strut, but sometimes that is not necessary. Dr. Jaramillo, Dr. Rossi, would you like to ask a question? I have 2 questions. One for stent in the ductus, the use of different axes. Would you rather use the femoral one? When do you choose the axillary one or carotid access here in Brazil? We have Dr. Juliana and Raul Arrieta who use axial approach. Do you recommend that? And for Luis Carlos Juliano, as a curious question, if the patient did not have any symptom of or a kyst of that size or anything that could make you suspicious when when you injected the contrast and you saw that surprise that you described before?
Bueno, olha, essa paciente não tinha nenhum sintoma, na realidade ela era oligosintomática e chamava a atenção que ela era uma paciente magrinha, uma paciente que fazia atletismo e não, de verdade ela era uma paciente que não apresentava nenhum sintoma ginecológico. Foi realmente um achado surpreendente para nós.
Bom, a minha pergunta é, fiquei muito interessado. Primeiro, parabéns para o Marcelo por um caso muito complexo, de implante muito preciso do ducto arterial, do stent no ducto. Então, isso não é fácil e eu acho que muda a evolução dos pacientes, dessa criança. Agora, a pergunta é, para os colegas, por que não usar a via carótida para acesso? A maioria desses ductos arteriosos, eles saem a 90 graus do istmo e acesso carotídeo é muito fácil. O nosso protocolo é fazer na sala híbrida, com a tomografia nos mostrando qual é a carótida para dissecar, se é a direita ou a esquerda. O cirurgião disseca a carótida com segurança, se necessita pouco contraste, já que se sabe a direção do canal arterial, e no momento que se tem a imagem, eu já pré-monto, já escolho o stent, porque esses pacientes às vezes fazem espasmo, eles dissecam o ducto com a guia, e eu tive, depois de ocluir um ducto, quase morrer de susto até reabri-lo. Hoje eu faço a imagem, escolho o stent e deixo pronto para implantar. Mas, assim, a pergunta é, por que não acessar mais a carótida?
Excellent comment, thank you very much. Yes, I agree with you. If at presentation, in the presentation I said, depending on what we see in the CT, we go through the left or right carotid if the ductus is in the transverse aorta or in the lateral part of the transverse aorta, because the access is more direct and you avoid the different curves that may place the stent in the wrong position. We do not use the subclavian access because terminal circulation is smaller, and with the carotids we did not have any problem with the direct puncture of the carotid guided with the angiography, with the CT, I'm sorry. I agree with you. We use a classification that is Arwick-Ereja that indicates the location of the ductus arteriosus as regards the aorta, and we see that the classification indicates that there is a conduct that origins from the aortic arch, the other from the proximal area of the descending aorta, and the other one from the subclavian, 1, 2, 3. So particularly, most of our ductus arise from the proximal area of the descending aorta. So this is why our approach tends to be femoral. We did not have any complications with that as well. We did not have problems with the femoral access, and the axillary, the carotid approaches are also described, and they may be useful in ductus arteriosus from the subclavian area or the aortic arch, but the only ductus that we have treated was with the carotid access that originated in the aortic arch, and we have some other ductus that I did not show in the subclavian area, but our learning curve will be increasing with the passing of the years. So these are approaches that we may use, they are described, and I believe that in the future we may use them more frequently. We have 1 minute for one last question. Dr. Gomez or Barbosa, would you like to ask a question? Jesus, I want to ask a question. Dr. Taita, when talked about the SVD the VSC, I'm sorry. What do you do with those cases in the periventricular cases?
Se alguém puder traduzir ou falar um pouquinho mais devagar para mim, por favor.
Sí, no la entendió la pregunta.
Thalita, ele está perguntando se nas comunicações interventriculares da ponta costumam fazer alguma fixação com ponto, com o cirurgião, ou de que jeito utiliza a prótese.
Sim, isso, em alguns dos nossos... Obrigada. Em alguns dos nossos procedimentos, onde não havia, em seives mais apicais, que não havia espaço suficiente para abertura do disco direito dentro da cavidade dentro da cavidade livre do VD, foi realizado o ponto do pino na parede exterior do ventrículo direito. Isso foi um artifício utilizado em alguns casos, realmente em que eram seives mais apicais.
Perfect, we're on time. Jose, would you like to close the session? And thank you everyone for the participation. Yes, I would like to thank all of you. It was a very good session. We could talk a lot more about this, but unfortunately we need to stop for the next sessions. So thank you very much. See you in the next SOLACI. Thank you everyone. Congratulations.
Muito obrigada.
Hay otra mesa pediátrica.
Hello everyone, welcome. It is a pleasure for us having you here in this very interesting session entitled Fetal, Neonatal and Expanding Limits of Interventions. The talks will be pre-recorded. The first of all will be of Carlos Pedra, Director of the Institute of Cardiology within the Department of Intensive Care and Interventions. Fetal aortic valve dilation. Are we changing the course of the disease? Victoria. Welcome everyone. This is a pleasure for us having you here. We have very interesting topics, as Raul said. Then we'll have Daniel Springmuller from Santiago de Chile. He will talk about the percutaneous closure of sinus venosus atrial septal defect. Is it possible? Then Dr. Luis Cárdenas talking about ductal stent in pulmonary dependent circulation, how to select patients to avoid failure. And last but not least, we're going to have Raul Rossi, Director of the Cath Lab and Congenital Heart Disease of Porto Alegre, Brazil, a great friend of mine. He will talk about the following. Is right ventricular outflow tract stenting the preferred option for symptomatic neonatal tetralogy of Fallot? And then we will introduce the panelists. Now we can start with the presentation. Hello, good morning, good afternoon to all of my Latin American friends. The topic today is the fetal aortic valve dilation in the uterus and if that changes the course of the disease. I do not have any conflicts of interest for this talk. We have performed 100 procedures here in Sao Paulo with 45 procedures in 43 patients in the aortic valve with an average of pregnancy of 27 weeks of a weight of 1.2 kilograms. This is an intervention with a multidisciplinary approach in the perinatologist and the interventionist. We perform spinal maternal anesthesia. We change the position of the fetus. We also use the percutaneous approach with an ultrasound probe, and we use Chiva needles, as you can see here, generally 17 gauge, and we use balloons of coronary angioplasty from 3.5 to 4 millimeters, inflatable up to 4.5, and we marked the system to know where we are within the uterus, what is the logic and the rationale and the objectives of this. We need to avoid the progression of the hypoplasia of the left ventricle and to obtain better survival rates and biventricular correction. When we have a ventricular dysfunction, as we see here, coupled with a monophasic flow in the mitral valve, when there is a left to right shunt in the septal atrium, and in the aortic arch, and critical aortic stenosis in this patient, that will change to hypoplasia. Our policy is the following: we rehabilitate the right ventricle in a staged process. We start in the uterus, then we go and do a bridge in the neonatal period, and then we end at the first year of age. Then we do the C-section at 38 to 39 weeks of pregnancy, so as not to have any surprises. With normal delivery, we open the AST, and from 9 to 12 months we do the biventricular correction, as we will see in the slides. This is the spectrum of the disease in utero, with the left dilated LV, fibroblastosis. In most of the patients, we see a smaller LV, and we see right ventricles with without a lot of complication, but a left atrium that is very big, and hydropsis, fetal hydropsis. We had some cases of hypoplasia of the right ventricle. These cases had some gigantic LA, for example. In most of them had, in the classic presentation, and 25 of these patients had hydropsis with a different degree of the disease. We had 3 deaths related to the procedure and 2 failures. Well, they were 4 failures that were repeated. This is an example of a case in uterus. You see from the valvuloplasty, the kid was born, and we did the valvuloplasty only with catheter balloon, and it was very good. This has a very good outcome, and part of our cases required a staged rehabilitation of the left ventricle with a hybrid procedure. This is the example, the prenatal one. This is an educated, we presented this in CSI, and after birth we performed a new valvuloplasty. We opened the AST, and with good outcomes. At 9 months we performed a catheterization. You can see the stent in the duct. The appearance of the left ventricle has improved in terms of size. We also emphasize the telediastolic pressure of the right ventricle, and we also use MRI to determine the degree of fibroblastosis and the volumes of the left ventricle. And when the surgeon, let's go back, when we take the person to surgery, the surgeon takes the layer of fibroblastosis of the left ventricle, And this is the ultrasound, the TEE, after the CBP, with the size of the ventricle that it was very good, with a good function, and we had a residual ASD to function as a relief valve, and this is the appearance of the aortic valve after the surgeon has done a plasty. This is another example before the valvuloplasty, the aortic valvuloplasty, a left ventricle that is dilated with an dysfunction. You can see the fibroelastosis layer after 2 months. After hybrid, we had to open the ASD with a better function and better size. And then at the end of the first 8 year of age, the patient required a widening of the outflow tract of the left ventricle. And we also performed a mitral valvoplasty at 8 months. He's a good candidate for a valve change. This is another case. The child had hypoplasia of the right ventricle, as you can see here at the top, before the valvuloplasty at 27 weeks, and at the bottom after the valvuloplasty in uterus. There was no significant change as regards the size of the left ventricle, and that is why we performed a hyperoxygenation, maternal hyperoxygenation, that started in the at 33 weeks of pregnancy. We monitor with ultrasound, and we perform the C-section at 38 weeks. Before the in utero intervention, then in day 1, and then 5 months after hybrid, and you see a significant increase of the volume, of the size of the left ventricle. And we did the catheterization at 9 months. Here you can see that the aorta, the ascending aorta, all the aortic arch has a anterograde flow, and we do the MRI to check the volume. As you can see here, we have the TEE after surgery with a very good improvement of the left ventricle and an appearance of the aortic valve that is very good as well. These are the images with 2.5 years. The patient is now 8 years old and has had very good outcomes from a clinical perspective. You could not imagine we could go from this image and having a very good result. This is very encouraging. And finally here, this is an example of the critical stenosis with a severe mitral regurgitation, a left ventricle that is very severe. After the valvuloplasty, after the procedure, this kid was born in a C-section, and we opened the ASD almost urgently. We did the hybrid procedure. You can see the opening of the ASD, and it worked very well. We always use MRI, as you can see here. And again, the catheterization, you can see the bandage of the pulmonary artery and the right branches, occluding the duct with a balloon within the stent. You can see the banding of the left branch, the size of the left ventricle. Of course, there is a very significant hypertrophy. You can see the coronaries here, but all the circulation in the aortic arch, almost all of the flow is anterograde. So this is a very good sign to obtain a correction, a biventricular correction. As you can see here, 2 years after, 1 month after, and 2 years after the biventricular repair. So you go from this very catastrophic stage to have this very good result. So we believe we can change the course of the disease actually. We have here a summary. This is a slide that is a bit complex. We had 45 procedures in 43 patients. We had failure in 4, 2 were repeated. We had intrauterus deaths in 3 patients, which amounts to 7%. That is a very good rate. 1 patient decided to go to abortion, and after birth we had 16 deaths. This is not a very small number. 1 opted for comfort care or palliative care. We had 5 neonates who died and 10 during infancy, and as regards the time of death, we had 4 deaths before procedure, 3 after hybrid, 6 after biventricular repair, and 3 after single ventricular repair. So out of the 43 patients, we had a survival rate of 51%. That is more or less half of these patients die after the procedure. As regards the status of circulation status of the survivors, of these 22 survivors, we have 6 with single ventricular repair, that is 14% of total cohort, and 16 patients with biventricular repair, 37% of the total cohort. 73 survivors had a biventricular repair, and 2 are on the waiting list for transplantation due to the diastolic dysfunction. That is some other topic we need to evaluate while doing the follow-up in the long term. And within the survivors, 8 survived after a neonatal valvuloplasty of only 1. 1 underwent a Ross procedure, and we had 7 of staged rehabilitation. Here you have some conclusions. Fetal cardiac interventions were feasible in our hands. We did not have a very long learning curve because we were based on the Boston experience. We are lucky enough to have a very skilled perinatologist, and we had some complication rates that were acceptable. We did not have maternal complications in any of the 100 cases. And our general fetal demise rate was of 9% compared with the international registry, and 7% in the aortic valvuloplasty. This is a procedure that is easier than in the pulmonary valve. Probably we're dealing with a cohort that is more complicated. We had some death rates that were very significant after the birth, maybe due to a postnatal care that we need to improve, and our rates of biventricular circulation were very good. So we believe that yes, we changed the course of the disease, especially to obtain a biventricular repair. Of course, when we have a mitral valve disease and smaller hypoplasia of the aortic annulus, that may be a limiting factor. And of course, the long-term outcomes should be better elucidated. First of all, as regards diastolic dysfunction, pulmonary hypertension, the need for a transplant in 2 patients who are on the waiting list, for example. And I make a question: if a biventricular repair, a perfect one, would be better than a biventricular suboptimal repair? This is a question that only the follow-up can answer. Thank you very much for your kind attention. I give you a great hug to my Latin American friends. Bye-bye.
Good afternoon, good evening, maybe, for some of you. My name is Daniel Springmüller. I first would like to thank the organizing committee and especially Dr. Rigoni because of this invitation to be able to talk to you about this novel topic that is percutaneous closure of sinus venosus atrial septal defects, where I ask if this is possible or not. I have no disclosures related to this presentation. You know that the venous type ASDs were described by Peacock. It happens in 4 to 11 of the ASDs. There are two anatomical types. For the superior vena cava ASD, this 87 to 90% is associated to the right side, and then we have for the vena cava inferior, which happens in 10 to 13%. It has associated to the right side, and this has been treated surgically. This is from prior works for surgical reparation with the Warden technique, and we see that we have these both techniques have their complications. As you can see, the arrhythmias post-op they tend to be high, and then the arrhythmia and the obstruction. And this is another article from Quebec in Canada. We can see how the percutaneous closure of the ASDs is going to in relation with the surgery. We can see the surgery in red. It starts decreasing. This is per year, and we see the rise of the percutaneous closure. We can see how the percutaneous closure has been gaining terrain, but we still have plenty of surgeries that need to be performed. The changes basically depending on the anatomy, because we're not talking about the atrial septal defects, but we actually talk about inter-atrial communications, ASDs. So we have the inter-atrial communications. Then we have the true interauricular septal defects. So we got the separation due to we may have the patent foramen ovale, the ostium secundum or the vestibular ASDs, or we have the interauricular communications, which we have the ostium premium ASD, the venous sinus ASD, and the coronary sinus ASD. And for the septal defects, we've been using the percutaneous closure using devices, and for the second set, we've been using the surgical closure. Which are the changes in knowledge that have appeared in the latest years is what many of us learned in the medical school, is that the septum is not just a septum, but rather a folding of the roof of the atrium, which falls into the atrial chamber, sorry. And then we have a fibroadipose tissue. That what happens when we have the sinus venosus defect. We have we have an anomalous place of the VP, and this is permanent. This is a secundum that remains like a tube of extra tissue. And the septum primum, we can see that it's completely normal. This is an example here in anatomopathology, and here we see the interatrial septum with outside of the margins of the fossa ovale. And here we have the superior vena cava, very close to the defect, and which makes that the superior vena cava communicates with both of the atria. So, and we see the communication with the left and the right side. And through the defect, the blood goes into the right atrium, and it remains connected with the left atrium. Then the first time that it was suggested was in Frankfurt, and they published that information, the paper with 4 patients, where they used this technique. From 2013 on, we've seen multiple clinical trials related to percutaneous closure of the sinus venous in the superior vena cava. We have used several imaging techniques for this. We've used 3D printing, we've used simulations, CAD simulations, and the first one is a group the second is a group in Italy, where they've used holographic images to be able to locate themselves dimensionally in this pathology. And the final is a group in France that they've done a fusion of 3D images, and they've fused angiography with other types of images. So I wanted to talk to you about a couple of papers that we have seen, and they're important because they've had an important number of patients. This is Rosenthal in England. They have 25 patients with percutaneous closure, basically adults with an average age of 25 years old, and I wanted to share their experience with these types of procedures. If you want to know about this, you should read very closely this paper, because they describe how to do the procedure very clearly. And we can see that in spite of everything, they performed virtual implantations. So in spite of this, they have 25% of patients that you study, and you see that you cannot do a percutaneous procedure. And this is another paper published by an Indian group, and with 44 patients. And since it is a paper from India, they do not use any advanced imaging techniques. They only use the ultrasound or the angiography for the percutaneous treatment, and you can see that they include children. So they have children from 6 years old on, and we can see this paper was published this year. We'll talk about this further with septal defects with a stent, 10-6 covered stent with 75 patients. They have a stent covered with 10-6. We can see the range of lengths that they are working. They've used stents up to 11 centimeters long. Then the longer the stent, you see the proportion of the patients. You may need to use a second or a third stent. How do we do the procedure? First of all, we need to define the material that we're going to need, the stents that are available, the percentage of shortening we need to consider, and the diameter that we are going to reach. We need to see the balloons. Most of the work is also done with general anesthesia, but you could use sedation. Then you can use the TEE, and most of them are guided using TEE. And then we need to consider the venous access, the venous loop, veno-venous loop, to be able to perform angiography during the procedure, and the veno-venous loop provides stability during the implantation of the stents. We can do angiographies of the superior right vein, portal vein. It reaches to reach the vena cava, the superior vena cava. We may use access through the foramen valve, or you could do a transseptal puncture, or you could do a retrograde access from the left side. So with this, you can do angiographies and pressure measurement if you suspect of an obstruction. Then the occlusion test, there's a discussion between the compliant or non-compliant balloons. The non-compliant balloon not always occludes the shunt. but it may be if you suspect if that it may occlude the pulmonary part, so we may use a projection balloon. Now the technique is showing you one of the cases that we had here in Santiago, and with the thorax projection. Patient we had with complaining of dyspnea, and here we have the scan on the right side, where you can see the vena cava, superior vena cava, going into the right atrium, and you have the superior portal vein getting in here, and you have the mid lobe then entering through the right atrium. And you can see, this is important, this is the superior vena cava, and you can see that as you go into the superior vena cava, you see the anomalous regions, and you can see the diameter of the superior vena cava is increasing until we reach the atrium, the right atrium. You can see this effect, this is the vena effect, and this septum is the tube of extra pediatric tissue. So we have three concepts that are important here for percutaneous closure of this pathology. One of them is that it's just like a river. As we see the affluents getting into the river, it's going to have more water. The size of the river is going to increase. Same thing happens when we have the vena cava. So same scan with measurements. This is the superior vena cava that we see with the anomalous veins. It has 80 millimeters. Then it is when we get the superior right vein, and 22 millimeters. And then when we get to the right atrium, we get to 28 millimeters. So the stent needs to get it firmer in the highest portion so that the stent can hold on to the superior vena cava. The second concept is the lower point of anchor, which is this part that we see here, is that you can go through with a stylet there in this place in the superior vena cava. Here you see the tissue that we have from the septum secundum, and we can send the stylet to the tissue that we go through the anterior side. And this is the one that I've shown you, the picture, how it moves forward. And here you can see the superior vena cava, and here you can see the septum secundum, where you can see the stent towards inferior. So just like these monkeys that we see here, that we played with when we were kids, this is more or less the same concept. The stent, just like the monkey, needs to anchor on top and on the bottom. So this makes us have a covered stent, that the blood goes into the superior vena cava and go through the inside of the stent to the left atrium, to have the blood go through the stent and into the right atrium. This is one of the patients that we worked with. You can see here the femoral venous access, the auricular access, and atrium access, sorry. And you can see how the right superior vein goes into the superior vena cava. So the measurements that we see on the scanner, we can see 80 millimeters and 28 millimeters. And the segment that we need to cover with the stents is about 6 centimeters. So we have an occlusion. We use the sizing balloon. Then we're going to show you here. We can see how the balloon occludes the superior vena cava. And that's how you know that this diameter is the appropriate diameter for the stent. And you can do this simultaneously from injecting on the right superior vein. This goes into the left atrium. So you can see here particularly that the work on the superior right vein was slowed a little bit, that we see an increase of from 10 to 15 millimeters. And since we don't have these very long stents, what we need to do is a telescopic technique using a very tall stent on the superior vena cava. Then we did a covered CP with, then we did an androstent, covered androstent, and then on the bottom we placed a sixth stent, an 8/6 stent, which was another covered stent. And you can see here that the 3 stents are all here. It still filters, leaks a little bit, but what we did was to inflate a little bit balloon to try to dilate this portion. And then with an Atlas balloon, we went from the right superior vein. We put another one to prevent compression with this stent. So you can see on the vena cava, superior vena cava, you can see the blood going into the right atrium, and then we got the flow from the superior right vein, and it flows into the left atrium. So this is the imaging. You can see the stent here, goes on the outside of the stent toward the stent. So this type of ASDs are less than 10% of interauricular communications. Communications. The knowledge and the understanding of the anatomy is fundamental. The percutaneous closure is an alternative to the surgical closing if we avoid the sternotomy and the CEC. And then the percutaneous closure is used in around 75% of the patients with this type of ASD. And then we have the obstruction of the occlusion of the pulmonary veins. We can use a protection balloon, and we need to watch out for migration of stents, and we could use long stents from 6 to 8 centimeters. And what we have pending is that we need to perform follow-up at the mid-term and long-term, and to define the lower limit of the size and age of the patient. That is what I wanted to tell you all, and this is thank you very much for your attention, and you can ask me any questions that you may have during this session. Thank you very much.
Good afternoon, everyone. Thank you very much for the invitation. From 1992, when the first reports of procedures of ductal stents were published, the truth is that things have been changing very fast. The first cases were very shy. They only recommended ductal stent in patients with more than one source and with a proper anatomy. It might be reasonable to place a stent in ductus that were anatomically correct, with a source of a pulmonary blood flow, but with class 2B, for example. And it was not recommended to perform the ductal stent in stenosis, severe stenosis. We have made a lot of progress, and today we have consensus on most of the processes, and they say that at least ductal stent is just as safe and efficient as the ductal shunt. When we try to perform ductal stent, we need to take into account that it is a procedure that has some complications. The morphologies of ductus are very variable. We have multiple physiological scenarios. Morbidity and mortality are not excluded in these procedures. And decision making is a multidisciplinary process that is very complex. Still, it continues to be a challenging procedure. And failure is potential, is real, but it can be avoided. So, which are the keys to prevent this failure? We have to properly choose the patients. we are going to choose for the procedure and do a pre-cath management that is very adapted to each of the patients. We have to appropriately plan for the procedure, the site entry, having all of the appropriate materials, and being prepared to emergency situations in the cath lab and be ready for re-interventions. Something we should not overlook is the fact of acknowledging our learning curve status as an institution or as a technician, and to respect that learning curve and moving step by step, acquiring the experience and the trust before taking the most complex patients. When we have these patients, we need to do an echocardiographic evaluation so that we can see different characteristics of the ductus and make some decisions that have to be complemented with another image, but we can make decisions with this. You can see the origin of the ductus, in this case the descending aorta, how many curves the ductus has, how many changes in direction, what is the length of the ductus, as in this image, the first one or the second one, if we have more than one ductus, not from the aorta, but from the vessels of the neck, of a left pulmonary branch, for example. So there are several things we need to see in the echocardiographic evaluation. When we have a patient with a ductus that is very tortuous, we recommend not suspending prostaglandin. When they are very tortuous, we can continue to have a stent unless the lumen is very high, but in most of the cases we do not have that. And curves allow us to continue with the stent, and having the prostaglandin allows us to prevent the spasm of the ductus and to prevent a worse complication to maneuver. When the ductus is straight, if the saturation is 80%, we continue with prostaglandin, and if it is over 90 and the ductus is big, we can suspend prostaglandin and reach up to 80%, and that will allow us to place the stent and to continue with the same levels of prostaglandin, to decrease them, It is optional to discontinue 3 hours before the catheterization. We always leave the infusion pump ready to restart if necessary. Almost all of our patients are evaluated with a CT scan to see the type of ductus, the origin, the length, the number of curves, and we can also plan for the procedure very carefully, gaining time, decreasing the times of the procedure, and also the complications. Having all of this analysis, we will have some patients that will not go to the cath lab. Some of them will need surgery, for example, for the ductal stent, and they will need a surgical repair. If the ductus were very big and it did not respond to the prostaglandin, which is very rare, for example, and in some ductus, if the pulmonary branches are stenotic, have stenosis, or if it is very tortuous, we can leave some patients as a relative contraindication, and that will depend on the institution or the operator. The rest of the patients will believe that most of them can undergo a ductal stent. You have to analyze the key points that are the origin of the PDA, the tortuosity index, the curvature index, to see whether there is a threatened pulmonary branch, if there is jailing, or if we can provoke stenosis while placing the stent, and also taking into consideration the size of the patient. What is the origin of the PDA? That is very important. It may origin in the descending aorta, below the aortic arch, or the neck vessels, and that will be very important to decide from which we're going to enter. The puncture site. We will try to use a site with the straightest trajectory, the most direct one, with the best orientation of the stent, so we can deal with, in a better way, the tortuosity of the ductus, so that our guides can reach there without a problem. We will analyze the sources of pulmonary blood flow with the ultrasound and the CT scan, of course, the size of the patient and the potential adverse events from each vascular access. Which are the puncture sites we're going to use? The femoral, venous, or artery. Today we use a lot the arterial, axillary artery, the carotid puncture, and cut down sometimes. When we compare the different vascular access sites, we see that there are no major differences in complications. And when we choose how we're going to perform that, or the puncture site we're going to choose for the approach, placing the patient facing down is more comfortable for us, and we can decrease the time of the procedure in the carotid or the axillary approach. We need to have all of the materials handy: flexors, stents, flexible guides and stiff guides, and guide wires, and microcatheters that allow us to move through the ductus without producing spasm or thrombosis of the site. We see the origin of the PDA and the access site that is more used. Our femoral artery and vein, and the carotid access and the axillary ones are also used. This is a straight septum patient, pulmonary atresia, and the stenting is done with the femoral vein approach. We see that the stent is covering the whole ductus. And we dilate the stent. We are going into the position. And finally, with the stent released, we check that it covers entirely the pulmonary and aortic end. This procedure was done with a venous access. When you analyze the most complicated ductus, the tortuosity index is one of the most important parameters. We have three types of ductus. The straight ductus we have on A, type 1. We have ductus with one turn, which is type 2 in B, and in C with multiple turns, which is type 3. Of course, complexity of procedures will increase if that tortuosity index increases. And we also have the curvature index that also helps us to make some decisions, which is the relationship, the distance, the straight distance with the aortic and pulmonary end of the ductus, and the true length, complete with all of the curves. That relation will tell us something about the degree of difficulty of the procedure. The two indexes are interrelated. The most complex, the curvature and index, the most complicated cases. When you use these indexes, you can predict the length of the stent that you will need and some other decisions you will be making. And also the decision of the stent will be from L1 and L2 in general in an intermediate point. When we analyze what happens in the relationship of the tortuosity and curvature index with unplanned interventions of our patients, we see that the most tortuous the duct, the more reinterventions we need to have, both planned and unplanned. Here we have a patient with a ductus that comes below the aortic arch with several turns, and with a tortuosity level that is very high. You see a stenosis in the ductus near the other vessel. In this patient, we could cannulate. We go through with a stiff guide and we place the stent, and it's patent, but the right branch, the origin, is here. Another area of the aortic arch with an innominate artery. You can see the left pulmonary branch, and we placed the second stent that will give us the flow to the vena cava. Going to the left artery now. This is the result evaluated with angio CT. You can see the precision that is a very important factor for the success of this procedure. Another way of analyzing this is the Belgium group using the same parameters that group this patient in group 1 with straight ductus and group 2 ductus from the descending aorta but that are not straight, and we have number 3 and number 4 from the aorta to single lung, group 5, group 6 from the neck to both of the lungs. And this classification is very important. They realized that procedures in which the ductus came from the descending aorta and was straight, and procedures in which it came from the below the aortic arch from one branch to only one lung were the safest ones and with least complications, and the rest of the groups have more probability of having complications. These will be the most complex patients. This is a very tortuous ductus with stenosis of one of the branches, the right branch in this case, and the left branch from the ductus. In this case, we use a stent, we do the jailing of the other branch, and then we dilate, and sometimes a second stent is necessary for the contralateral branch. With the good result, another case in which the ductus come from below the aortic arch, the ductus is short with an angle, and you can see the branches that are very risky for the jailing of the branches. In this case, we make the decision to do jailing of the right branch. We are with this patient flipped, so we do also the dilation of the counterlateral, having a good flow to both branches. What happens when we have this jailing? We see that reinterventions are more frequent, but the results as regards the size of the branches within the procedure and how they continue to grow after the procedure are followed with good outcomes. Jailing branches is not a contraindication. Ductal stent is a safe procedure and at least as effective as a surgical shunt, but still a challenging procedure. Patient selection and proper planning are key steps to avoid failure. Morphological aspects and multimodal imaging are essential aspects to be covered. Multidisciplinary decision-making process and surgical and ECMO backup are mandatory for optimal results. And we also have to respect the differences between operators and institutions, and we need to know in which part of the learning curve we are at to move forward very gradually, and these are the crucial keys to avoid failures. Thank you very much.
Good afternoon, everyone. My name is Raul Rossi. I work in Porto Alegre, Brazil, in the Cardiology Institute in Porto Alegre. I would like to thank the Scientific Commission for the invitation to this spectacular Congress, especially for such an interesting topic like stenting for the tragedy of Fetal. Yeah, it's not like other cases that we need sophisticated techniques or new devices. It changes the life of the patients. The speaker will switch to Portuguese, and there will be no simultaneous interpretation from Portuguese to English.
Já não tenho conflitos de interesse e tenho apenas que agradecer ao meu amigo Dr. Carlo Pila pelas algumas imagens e insights e inputs de dados para essa apresentação. essa apresentação basicamente começa com o que fazer com o tetralogia, bebês com tetralogia de Fallot. Os americanos, já na década de 80, Aldo Castaneda, não os americanos, latino-americanos, lá em Boston, professando interesse em tratar as crianças com correção precoce, neonatal, porque isso diminuiria o tempo de cianose, evitaria uma segunda cirurgia e traria menos distorções das artérias pulmonares a um custo, talvez, de mais PETs transanulares. Quem gostava da técnica, ou recomendava a técnica estagiada, usando um shunt de Blaylock, defendia que era um pequeno procedimento menos complexo no início da vida do paciente, menor permanência hospitalar, talvez maior chance de poupar a válvula pulmonar e, assim, e impacto benéfico sobre o crescimento das artérias pulmonares. Na verdade, a taxa de mortalidade dos dois procedimentos, mesmo em mãos experientes, é semelhante. Esse trabalho do Kids Inpatient Database mostra, é um dos maiores bancos de dados americanos sobre o tema, sobre cirurgia cardíaca, mostra que os resultados não são iguais. É um procedimento que causa mais cirurgia neonatal, mais insuficiência renal, necessidade de ECMO, custo, permanência hospitalar e tem impacto sobre a mortalidade também. E essa curva de sobrevida, dividindo procedimentos estagiados e tratamento neonatal, mostra que, isso vem do Pediatric Health Information Database, mostra que os pacientes têm maior mortalidade e evoluem pior quando não são submetidos a esse tratamento neonatal em serviços de ultra excelência. Os procedimentos paliativos também não têm resultados espetaculares. A mortalidade contemporânea do Blaylock pode ser até de quase 10%. A distorção de artérias pulmonares, todos nós cardiologistas, intervencionistas pediátricos sabemos que é um achado ocasional e nos obriga a implantar stents. Por outro lado, talvez uma saída fosse o tratamento com stents no ducto, nos recém-nascidos. Alguns recém-nascidos chegam ao hospital com o ducto fechado, isso é um problema. E a experiência é maior, na realidade, em pacientes com outras cardiopatias. Seleção de casos é crucial, como todos vocês sabem, e a taxa de crossover pode ser até de 17%. Esse é o trabalho do Gruentzig, que deu início à mudança de paradigma de tratar as crianças sem Blaylock Talsic nos Estados Unidos. Os resultados são verdadeiramente espetaculares, mas, enfim, não é incomum que, às vezes, a gente tenha que pedir para o cirurgião fazer um Blaylock nesses pacientes, às vezes de urgência. Então, longe de ser uma coisa fácil de fazer, os canais arteriais são múltiplos, às vezes tu tem que enjaular propositalmente um ramo e tratar o outro com balão ao mesmo tempo. E o que nós precisamos é achar o nosso lugar no algoritmo de tratamento, porque, embora haja essa tendência mundial, especialmente nos países, vamos dizer assim, mais ricos, muitos centros ainda usam paliação inicial, e especialmente naquelas crianças que têm peso baixo, que têm artérias pulmonares ruins, ou têm comorbidades como defeito septal AV ou anomalias coronárias. Talvez o stent tenha, na via de saída, tenha um espaço, e eu acredito que tenha, nesse local. A abordagem, então, fica one size fits all, ou seja, faz só desse jeito, ou uma abordagem personalizada. Às vezes botar um stent no canal arterial é muito simples, eventualmente se o teu serviço é espetacular em cirurgia cardíaca, a abordagem neonatal pode ser a resposta. O que nos importa são os desfechos melhores possíveis. Implante de stents na via de saída pode ser um game changer? Acredito que possa. A grande vantagem é o fluxo anterógrado, tu não tem sobrecirculação em relação ao pulmão, é uma coisa mais fisiológica do que um shunt. A taxa de sucesso é alta, a mortalidade geral é baixa, não é tão baixa assim em alguns lugares. Há uma melhora definitiva da saturação e excelente crescimento e simetria do fluxo pulmonar. Uma das dificuldades é quando tu não tem um ducto arterioso, o bailout às vezes é o cirurgião. Algumas pessoas dizem que implantar stents é um problema, porque vai fazer a vida do cirurgião miserável. Bom, a gente até gosta de fazer a vida do cirurgião miserável no futuro, mas para retirar o stent. Os cirurgiões já aprenderam como retirar, isso não é difícil para muitos deles. No momento que tu implanta um stent no paciente, apenas em 15% das vezes tu respeita a válvula pulmonar. A maioria dessas crianças necessitam cruzar a válvula pulmonar com o stent. Na nossa defesa, a gente pode dizer que a maioria dos pacientes pequeninhos com artérias pequenas tem anéis pequenos e vão precisar PET transanular. Como o trabalho lá do Sandoval, lá de Toronto, mostrou. Mas a gente podemos atrasar a cirurgia cardíaca e a falha do procedimento é menor que no stent do ducto. A técnica é minimalista e barata, usa angiografias como a gente usa para falou, catéter Judkins Guiding, com guia de angioplastia na pulmonar, de preferencialmente parqueada longe na aorta descendente quando há o ducto. Pré-dilatação é um must, torna a vida da gente mais fácil, e implantação do stent, um stent de coronária ou um stent de periférico. Essa é a técnica, não vou ser maçante, vocês conhecem melhor do que eu, e o resultado final, em alguns casos, é realmente espetacular. Uma via de saída horrorosa, paciente com cianose grave, sai da sala com 90 de saturação. E a gente pode fazer em várias morfologias. Essa criança tinha uma estenose na inserção do ducto, a gente acabou cruzando pelo ducto para a aorta ascendente, se estenteou a saída e depois voltamos e estenteamos o ducto. Então, se pode escolher a maneira, se pode manter a perfusão de ambos os pulmões de qualquer maneira. Esse trabalho do Sandoval, que eu já me referi, mostra coisas bem interessantes, é um trabalho bem complexo. Eles estavam tentando comparar os desfechos com cirurgias precoces, cirurgias tardias, e eles só mostraram nesse grupo de stent primário, que era um número de 42 dos 108 pacientes, que eles conseguiram atrasar a cirurgia em 6 meses para pacientes maiores e com nacatas muito melhores. E esse trabalho do Oliver Stumpfer, um pessoal da Suíça, ele é um estudo retrospectivo que mostra que stent contra Blalock e com avaliação pós com apenas com eco transtorácico, mostrou que os resultados de crescimento das pulmonares foram realmente melhores. E esse é um segundo trabalho do mesmo grupo mostrando a parte clínica, mostrando que esse mesmo grupo tinha uma admissão hospitalar menor, mortalidade menor, ou seja, resultados adequados, com um crossover para Blalock de apenas 4 pacientes. Isso pode ser feito também em pacientes, é um trabalho do Damian Kenny e do Oliver Stumpfer, um trabalho associado aos dois serviços, mostrando que em pacientes que têm defeito septal AV, que têm uma mortalidade muito elevada, acabam tendo um risco muito menor e desfechos melhores com ausência de mortalidade do procedimento. E a válvula pulmonar pode estar fechada. Esse trabalho de Leiden, do Mark Willig, mostra 4 neonatos que eles puncionaram a válvula pulmonar através de um procedimento híbrido e implantaram stents. Ora, todos os pacientes tiveram que ser reintervidos, mas reintervenção é o game nessa história. Esses resultados são os resultados do grupo chileno, dos nossos queridos amigos. Eu não vou citar todos, porque eu vou esquecer algum, não vai ficar adequado. Mas é um trabalho retrospectivo, 12 neonatos, excelentes resultados, sem mortalidade, sem eventos graves. Os stents foram implantados em 92% dos pacientes, e o nacatas surgiu de 63 para 162. Esse trabalho indiano mostra exatamente a mesma coisa, é um trabalho meio confuso, com muitos pacientes, mas eles usaram em 14 pacientes da tentativa de paliação, stents, os resultados foram semelhantes. A nossa experiência, essa experiência mais do Carlos do que minha, os resultados ruins são meus, os bons são do Carlos. São Instituto de Cardiologia, desculpe, Santa Casa, Hospital Santo Antônio de Santa Casa, Instituto de Cardiologia, 29 pacientes, intention to treat, de setembro de 2012 a junho de 21, crianças de 20 dias, com uma média de peso de 2,8, 86% de taxa de sucesso, 28% de complicações, foi uma perfuração inadvertida da via de saída, outra uma paradas cardíacas, BAV total. Nós tivemos 2 mortes, uma foi a criança que fez o hemipericárdio, uma criança muito pequenininha, e a outra foi uma criança que já veio de um pós-shunt muito comprometida em sepsis, choque, e a gente implantou um stent, ele evoluiu bem da parte de saturação, mas faleceu no mesmo período hospitalar, então atribuído o óbito ao procedimento, por causas de infecção. Então, tentando responder a questão de talvez o stent seja uma boa opção ou a melhor opção para implantar, para paliar, desculpe, pacientes com tetalogia de Fallot, neonatos com tetalogia de Fallot, minha resposta é sim. O Blaylock progressivamente tem sido trocado pelos procedimentos percutâneos na opção do staged approach. Os resultados do stent na via de saída nesses pacientes são realmente encorajadores e a técnica está ganhando preferência para uso nos pacientes pequenos. Muitas variáveis melhoram depois do procedimento, mas a curva de aprendizado, por favor, entendam, tem que ser sofrida, mesmo por gente experiente. E se espera-se, obviamente, uma taxa de reintervenção, embora, dependendo da morfologia da via de saída, tu possa antecipar a cirurgia e não ser necessário novo stent ou nova dilatação. Acho que essa técnica é muito boa, porque em países como o Brasil, em que o custo das coisas é tão importante, quanto mais barato seja o custo do procedimento, mais pacientes nós poderemos atender. E eu gostaria de encerrar agradecendo a todos e desejando que meus amigos todos aí da Argentina estejam seguros, vocês e suas famílias, com esse pensamento do Theodore Lewitt, que era um marqueteiro, que dizia que, na realidade, a criatividade é pensar sobre novas coisas. A inovação, que nós fazemos, é fazer as novas coisas. Muito obrigado a todos.
Okay, I would like to congratulate all the speakers, because the talks have been very interesting, the presentations. So we have our panelists here, Dr. Jenny Briones, Dr. Alexandra Heath, Dr. Alberto Robredo, Dr. Jaiber, and Dr. Pila. So the discussion panel is open. I don't know if anyone is interested in asking a question. I think that Jenny had a question. Yes, I had a question. I had a question for Dr. Cardenas, and it's in relation to the follow-up, because the lesion was very well in terms of the implant, and the complications in terms of the implant. To the follow-up, the short and mid-term, to the surgery, and which have been your main complications in relation to the stent obstruction. You had a kind of utilization or some kind of stenosis in relation with that, or if that has motivated new interventions or complications, or what kind of anticoagulants do you use for those kinds of stents? Yes, when facing these patients, we need to realize which is the kind of patient that you are treating. you have patients with that you perform a ductal stent, and you could go with the biventricular choice, and some of them in the single ventricular treatment. So in our experience, when you go with biventricular, it's less time than you need for the single ventricular patients. So in the single ventricle treatment, you need more time, and you're going to have more issues with the stent. In the biventricular, you have a very good results, because since the period is 3 months between the implantation of the stent and the correcting surgery, we shouldn't need to go beyond. So the accident rate is quite low. In single ventricle, we need to redilate the stent. We may need some hospitalization, and you may have some more complications. From the entire series, we've had a single patient who died, who had double stent, and this didn't happen during the procedure, but it was in when he was in the hospital, and has several issues with the arteries in it post-operatory, and the rest of the patients were pretty okay. In terms of most of the patients left the hospital with anticoagulation, and then we moved. We sent them aspirin to most of them, and depending on the size of the stent, 3-4 millimeters, we may have added another antiplatelet drug. That's the scheme, more or less. Okay, Luis, thank you very much for your answer. Alberto, I think that he had one question for Daniel. Yes, thank you very much. In this case with the stenting, I think that it was a beautiful presentation. What kind of stents should we have to prevent, or which care should we have to prevent erosion of the walls? And what we know about the arrhythmia that this might generate, and what kind of antiplatelet therapy we need to provide. Thank you very much. Thank you, Alberto, for your question. This is as for the erosion. I believe that there are no reports with cases due to stents caused erosion. So the main complications are the ones that I mentioned: the stent migration, that you place the stent, or the stents in tandem, and they may have fallen into the right atrium, and we may have had to do some surgery. And the second complication is the occlusion, or the obstruction of the tubular areas, because for both things, first we invented these to prevent migration. We have these longer CP covered stents, that you might need to use one stent or two stents. In one case I had to use 3 stents. So the risk of the migration risk of the stent set is lesser. And for our means in Chile, that we don't have these long stents available, what I did was to know which materials are we working with. Because if they are covered, if I want to dilate the stent this much, I'm going to need this work to make sure that the stent is implanted, and so that we prevent the embolization of the stent. And for the projection, is like saying, if depends on, for example, for the sizing, if we have a compliant balloon or a non-compliant balloon, and there are pros and cons for both cases. For the compliant balloon, is that it allows us to determine which is the diameter, which is the diameter of the cava, the cava atrial union. This is very useful, but we have a problem with the occlusions that we need to make sure that the flow is correctly directed. And the can of the compliant stent is that when it is compliant and you get some bumps, and that may occlude and may get to the pulmonary arteries, the veins, and we may have the false impression that the pulmonary vein is being obstructed by the stent. So what the people in England have done is they've placed a non-compliant balloon that simulates the diameter of the stent that you're going to implant. And this is interesting because we can check if the pulmonary veins are being occluded or not. If you have a non-compliant balloon, you're probably going to have filtration, and when we get to the right atrium. So what you need to do is a combination maybe of both balloons to make a decision, or what we do is what the people in India did is measuring the pressures in the pulmonary vein continuously, and if we have any doubts with the non-compliant balloon, because the pressure rises a lot, then it's probably what we should have is a protective balloon to make sure that to prevent the stent to occlude the vein. Those are mainly the pitfalls of the procedure. Thank you very much. Any other questions from the panel? I think that, I don't know if Carlos Pila has any question from Porto Alegre. Carlo?
Oi, boa noite a todos, ou boa tarde a alguns. Então, como o Raul falou, eu tenho uma pergunta ao Dr. Carlos Pedra, relacionada ao melhor momento da realização da valvoplastia aórtica fetal no feto, né, para como forma de evitar a progressão da doença para uma síndrome da hipoplasia do coração esquerdo. Gostaria de ouvir os pensamentos dele sobre isso. E também gostaria de endereçar uma pergunta ao Dr. Luiz Cárdenas, do Chile, a respeito da reintervenção em pacientes que já tiveram o implante de stent em canal arterial. Em nossa experiência, esse grupo foi o grupo que mais apresentou complicações, a ponto de que, atualmente, quando o paciente apresenta reestenose no canal arterial no segmento, nós temos antecipado o momento cirúrgico ao invés de reintervirmos no canal arterial, devido a um índice de complicação mais elevado nesse grupo. Eu também gostaria de ouvir a opinião dele nesse assunto. Obrigado, Raul.
Hello, my friends. Sorry for the delay, and I wasn't able to see the first presentations. Thank you for the questions. And when we try to bring the procedure to 22, 23 weeks, it ends up being very difficult from the technical point of view because it's very small, very young children, babies. So we have like it's like a bullet in the chamber. If you don't go into the chamber in the first try, it's very difficult because the ventricle coaptation, the imaging, this is not as good. So after 24 weeks to 27, 28 weeks would be the ideal age. You could find a greater, it could be easier to be able to achieve a ventricular correction. which would be the length of the pregnancy. I mean, how, until what moment we could do it in the pregnancy. That is always discussed. We have discussed it, and the people in Boston have done it, discussed it, and they do it up to 32 weeks. And if there's an expectancy of saving the left ventricle, so I think that length of the pregnancy between 25 and 28. Okay. To answer the second question about the ductal stenting, when you perform the follow-up of these types of patients, we see that the ductal stenting is not an adverse effect. It's an expected effect, and every patient is going to experience that. So what we do is very close follow-up. In general, the saturation, the outlet saturation, etc., is that those may be good parameters to start looking at this at the patients. And any drop, any significant drop, is something that we need to research, because even if the imaging, the non-invasive imaging, tells us that there's nothing wrong. So if we have a drop of 10 points of saturation from the procedure, we need to go and research and investigate. It's very important that we do imaging, or take them to the cath lab, or do a CT scan to investigate the branches or the stent, and do the re-interventions that are needed at that point. Because we work it by ventricular, and we try not to wait that long. We don't need to do that so much with the patients, and if then we need to go with advanced imaging and re-intervention in almost all the patients. Excellent. Great. These two answers have been very good. I would like to ask a question to Raul Rossi about when we put a stent in the outflow tract in the right ventricle. When we do that, when the saturation goes up, but we are worried about the reperfusion syndrome. We have small pulmonary branches. What is your strategy, or what would be your considerations or your advice for the care after stent implantation to this point for reperfusion syndrome that we've had at some point? And what is your opinion about all of this? Raul, you are muted. That is a great question.
Eu acho que nós não temos resposta para isso. Na realidade, a recomendação seria usar um stent semelhante ao tronco pulmonar daquela criança. Mas nós sabemos que essas crianças têm uma a circulação pulmonar intrapulmonar é doente, tem muscularização pequena, então reperfusão pode acontecer, mas certamente aconteceria com mais frequência, ou maior frequência, com shunts bleiloctálcico, por exemplo. Agora, eu acho que a saída é usar o menor stent possível, cobrindo toda a via de saída e com um tamanho que seja semelhante ao do tronco da artéria pulmonar.
Perfecto, Raúl. Y también a veces dejarlo en ventilación mecánica, ¿no?
Absolutamente.
Sedado,
se isso acontecer, desculpe, se isso acontecer, se houver edema pulmonar, síndrome pós-perfusão, ventilação mecânica com pressão positiva e PIP, frequentemente resolve o problema.
I have a question for Carlos. Several questions, actually. When do you consider which of the patients do you consider for interventions after the 18th week to make the decision in a patient with fetus over 30 weeks? Is that patient going to benefit? and then about the feasibility. Second, if they have fibrolastosis, when we have dilation, does that play a part in the decision? I know that you also consider the functionality of the left ventricle to screen the patient. We know that maybe if this patient has this good candidate or bad candidate, if you use this as a factor. Okay, thank you. It's a great question, a very smart question, Victorio. And other than the classical criteria, like patient that goes in the arch with a retrograde flow in the interatrial monophase pattern, and the degree of fibrolastosis, and the index that we the sphericity, I don't know the exact name, the seeming like a balloon. The more spherical the worse it is, and the chance of having a biventricular correction is more difficult. And the same thing that if you get a biventricle correction, then the degree of fibrolaptosis is very hard to manage while we are operating. And we've had problems with when the surgeon finds a section that removes the fibrolaptosis layer, especially in the septum, and the septum has a little bit of motion of a like crazy, so we have two patients. One of them was subjected to a transplant, and there's another girl that is probably going to end up going towards that. So I don't know. It's the indication. The basic indication is, if you read the Boston articles, and they do cases like because with younger children, they go for us to provide an anterograde and flow in the aortic valve, and for univentricular single ventricle hearts due to the coronary situation. And we also have the subgroup of the mitral insufficiency, which they have very serious cases in which the left ventricle is large and it's not so bad from the functional point of view. So these cases, they've also worked with those. I don't know which is the age cutoff. I think that you can go up to 30 weeks, but after that it's very difficult to move the baby inside the uterus. We also always need to work with incredible mobility but after that age is very difficult, because those are very particular cases in which you need to individualize and discuss it a lot with the family and try to tell them the truth. From the technical point of view, that we're probably not going to have a good result. And of course, each of the centers have a little bit of a leeway, a flexibility to apply the criteria, to adapt the criteria to the reality of each country and everything. Sorry. Just a brief comment about what Carlos said. We could have a patient 30 weeks, and we performed this due to the Completo criteria very well, and because the patient was in the proper position to perform the surgery. But if not, yes, I would say that after 30 weeks it's very difficult. Alexander has a question. Great. Alexandra, sorry, thank you for giving me the floor. What's the relation of the position of the stent with the outflow tract on the left ventricle? If it is with fallow, and if and in hypoplastic arteries. My curiosity is, do you let it, if the flow is open to the pulmonary artery? Have you had cases of thrombosis? How do you prevent that? What happens with the valve? Because we're going to have to put a stent in a valve. Dr. Rossi, thank you.
Obrigado pela pergunta. Na realidade, a fisiologia do stent na via de saída é uma fisiologia muito interessante, porque nós aumentamos o fluxo pulmonar frequentemente, não demasiadamente. A maioria das vezes, nós temos que cruzar a válvula pulmonar. E em cruzando a válvula pulmonar, o próprio trabalho do Dr. Sandoval, que foi feito em Toronto, mostra que os pacientes escolhidos para essa técnica são pacientes com artérias pulmonares piores e tamanho pior e comorbidades associadas. O pessoal, o Oliver Stumpfer, ele diz que ele consegue em 15% das vezes implantar o stent abaixo da válvula pulmonar nos anéis bons. Mas eu acho que nós temos que contar como cruzando a válvula pulmonar é a coisa a ser feita. E os cirurgiões, eles não têm um grande problema em retirar esses stents, ou se tem problemas, eles cortam através do stent, abrem como se fosse uma canoa e fazem o patch transanular. Então, na maioria das vezes, nós não prejudicamos a evolução da criança. E nós permitimos um QPQS melhor no pulmão do que fluxos extra via de saída. Não sei se eu lhe respondi a pergunta.
And if you use some kind of antiplatelet treatment to prevent the thrombosis?
Aspirina. Nós não podemos dizer que nós temos uma experiência enorme, então, eventualmente pode acontecer trombose, são 20 e poucos casos do Dr. Carlo e meus casos. Mas, na maioria dos pacientes, pelo menos nos meus pacientes, nós usamos aspirina e não tivemos trombose nessa série.
Raul, I want to ask a question to Daniel Springmüller. Daniel, so bad that I missed your presentation. I was trapped in a very ugly case here, and I don't know if we can do this procedure with stents or not with the CP or the JASIC, because here in Brazil, I don't think that it would be possible to import orderly, or I don't know, like the people do in Europe or and all that. So I think that we need to work with the materials that. Sorry if you already went through that in your chat, in your talk. No, I just wanted to ask him exactly the same thing about the endoprosthesis, the use of endoprosthesis. I think that it's easier than those long stents, because he did not mention exactly that. It's a great question. The issue with the stents or the self-expandable prosthesis is that you cannot shape them. And sometimes the diameter of the stent in the top part of the superior vena cava needs to be larger than the stent in the lower part. So with the self-expandable stents, it's going to be a little bit more complex or difficult or impossible to do. So here in Chile, we haven't received the CPE with the 10.6, the extra long, that I showed in the papers. So what we do is put stents in tandem. We implant stents in tandem. First one that we implant is that needs to be correctly anchored in the superior vena cava, so the one that we put on the bottom does not drop, and we put the stents until we get to the caudal atrial union. And as we've seen in the echo with the angiography, and we decide how much are we going to dilate. We do that with a self-expandable stent. It's going to be more complex. There are some cases that have been reported. The initial cases were not the initial ones, actually. After 2013, there was a pair of isolated cases with self-expandable stents, but we tend to use stents in tandem. Okay, Victoria, I think that the time is up. Yes, yes, we are on time. Time is up. Thank you very much to every one of you. The conferences were very interesting, and the discussion is very enriching to all of us, for us, and for the rest of the audience. So thank you very much to all of you, and thank you for watching us, and have a nice rest of the evening.